Good morning, everyone, and welcome to the second day of the SOLACI-CACI 2021 Congress, this year in a virtual format. As you can see, my name is Aníbal Damonte, and I have the privilege to co-moderate this session with my friend and mentor, Dr. Jorge Velardi, and also with Dr. Matthias Steckmann as a digital moderator. This is a very important session for SOLACI. This is the second day and the second session of the TCT at SOLACI-CACI meeting. This is a clear expression of the long-term relationship between both societies. Before turning over to Dr. Velardi to introduce the session, I would like to remind the audience that there is a translation from English to Spanish, from Spanish to English, that you will find in the bottom panel on the right, and they can choose whether language they want to listen. And I also want to remind the audience that they can interact with Dr. Matthias Steckmann, who is the digital moderator. Without further delay, I would like to turn over Dr. Jorge Velardi to introduce the session. Thank you.
Thank you, Aníbal. It's a great pleasure to introduce this combined session with TCT that has been really, for us, a tremendous help in our development and our knowledge and our growth in interventional cardiology in Latin America over many, many years past. Just going into the session, we have the privilege to have Mari Leon, who's going to give a lecture first regarding future of TAVR. We have Juan Granada, future development of transcatheter mitral valve procedures, and also Dr. Dan Burkhoff will talk on interventional heart failure. So this is a superb, really state-of-the-art knowledge in all this kind of intervention. We have also Bailis, Alcantara, Marco, Jorge Baccaro, Barbara Gelata, Hurtado Edgar, Leiva, and Enrique Ribeiro. So I think we have an excellent time now to start. And Mari, please, why don't you, as usual, give an overview, and your overview will be really a master of what's going on in TAVR right now, since you were really one of the beginners in all this technology. So Mari, it's a pleasure, and please, you're on.
Jorge, thank you very much. I really do want to express my greatest respect and support for SOLACI-CACI. I've had the pleasure to be able to work with senior faculty and many of the clinicians and operators over the course of several decades now, and some of my most cherished experiences have been the collaborations that I've had with my colleagues in SOLACI and CACI. So for us to be part of this is a great honor, and I just want to say these are difficult times, so we need to stay close together. We need to collaborate, and we feel your pain because we felt our own pain. So I'm hoping that during these sessions, even though they're only online, we can maintain the kind of closeness that's been so important to us in the past. A TCT will have an in-person and an online version in the fall, and we hope to see many of you there, and we'll do our best to make sure that we can share experiences and maintain the strength of this extremely important relationship for us. So with that as an introduction, I'm going to share some ideas in somewhat random fashion on TAVR. I've been asked to speak about TAVR and to try to project a little bit into the future. And I'm going to do this a little bit differently. I'm not going to focus on the technology because we always talk about the technology. I'm going to speak more about some of the clinical issues and some of the directions that I think the work is going to go in the next 5 or 10 years to be able to enhance this very interesting procedure. These are my disclosures. But let me begin, as I often do, by introducing a great friend and colleague, Alain Crebier, who I worked with in the 1990s to help develop some of this early technology. This is the first case that he did. And to me, it is still remarkable. It is almost 20 years ago. The next spring will be the 20th anniversary of the first case that was done. This was a man in his 50s who had bicuspid aortic valve disease. He was in cardiogenic shock. He had an occluded aorta with severe peripheral vascular disease, previous pneumonectomy, pancreatitis, multiple comorbidities, turned down for surgery with critical aortic stenosis and an ejection fraction of 10% with a large LV thrombus. To imagine that Alain could have done this case at all was remarkable, but he did it without transesophageal echo and without general anesthesia. And this is 15 minutes after the first case. This was truly the proof of concept case. And he demonstrated that you could transplant an aortic valve on a beating heart without opening the chest, using a transcatheter technique, which was, to me, remarkable. I spoke to him on the phone soon after this case, and the obvious question was, what do we do now? Now, this case was in an extreme patient, so we could never have predicted at that time what TAVR would have become in the ensuing decade and a half. In the beginning, we only did the sickest patients, but now things have dramatically changed. This is the most recent version of the TVT registry that was published at the end of last year, which is a comprehensive all-case registry in the United States of TAVRs that are done in all patient categories. And the green line shows you the trajectory of TAVR, and the two flat lines have been surgery, either sole aortic valve replacement or all aortic valve replacements, usually with CABG, shown on the two other lines. And as you can see, that by mid-2018, TAVR alone now exceeds all aortic valve replacements in the United States. The projections are that in 2021, that there'll be about 100,000 procedures done in the United States. And during the last half of this year, we will have done our 1 millionth TAVR case. And it's striking to me when we look at the kinds of patients we're treating, they're younger patients and they're lower risk patients. After the approval of TAVR for low risk indications, it's about a third, which is to say about a third of the cases done in the US now are low risk, a third are intermediate risk, and a third are high risk. So it is moving very, very quickly with a compound annual growth rate of almost 20% per year in the world. Obviously, depending upon resources, it's more or less available, but certainly the magic of TAVR is the ability to have generalized this procedure in a way that can be done safely, can be done quickly, oftentimes with a minimalist approach with reduced length of stay, and there is an avalanche of clinical trial data supporting its safety and efficacy. So I've told you about all the good things, but not everything is perfect with any technology. And I think one of the strengths of TAVR has been that we've been self-critical, and we've tried to look at the things that aren't going so well and see how we can continue to evolve and improve. So I want to talk about some of the evidence gaps and some of the future directions. Things that we don't know everything about and that we'll learn hopefully in the future with good judgment, being thoughtful clinicians, and also subscribing to evidence-based medicine. And that's what I want to focus on. So let me begin by saying that of the things that are unknown, the use of cerebral embolic protection to reduce strokes is not clearly understood in terms of absolute categorical recommendations. Should it be given systematically or selectively or not at all? This is an example of the most frequently used cerebral embolic protection device, which is inserted from the radial artery from the right side. It's a dual filter system. And we did a randomized trial, one of the few randomized trials for approval. And we did demonstrate that there was a 63% reduction in all strokes at 72 hours, which just about achieved statistical significance. It was not powered to show clinical endpoints. But there have been other studies that have been less impressive. There have been small meta-analyses that suggest similar findings. This is reported by David Cohen, who's one of our colleagues at CRF, at the TCT last year, looking from this large TVT registry at the use of cerebral protection. And you could not find very much of a difference between those patients with and without embolic protection. Now, there are questions about the ascertainment of stroke, and the stroke rates were very low, but still, this is not an answered question. So we're in the midst now of a very exciting clinical trial called Protected TAVR. It's the fastest enrolling TAVR study in the world. It's a 3,000 patient study looking at TAVR with and without cerebral embolic protection, with careful neurologic examinations and with a very simple 72-hour stroke rate, as being the primary endpoint. So we should have an answer fairly soon, and there's another 5,000 patient study that is similar in character that will be done in the UK on the same topic. So we'll have some answers about whether or not we should use cerebral embolic protection, but it's still an unknown space. There is an issue concerning a phenomenon called valve leaflet thickening, mainly derived from CT studies and so-called clinical valve thrombosis. So if you see on the film on the right, you can see that there's reduced leaflet motion on a 4D high-resolution CT scan. It's a characterization that we've described as hypoattenuated leaflet thickening, or HALT, which causes reduced leaflet motion. This is seen on CT scans, and it's been a disturbing finding. We integrated this into one of our recent clinical trials in a large sub-study of over 400 patients. And the findings comparing TAVR versus surgery by doing serial CT scans, baseline 30 days, 1 year, indicated that there was a higher frequency of this phenomenon in TAVR versus surgery by about twofold at 30 days. Both increased at a year, and by a year, the difference was not significantly different. These patients were not treated with anticoagulation if the phenomenon was observed, and you can see that more than half of the patients who had 30-day hypoattenuation on CT scan had spontaneously resolved by a year, and about 20% of patients had newly developed HALT in a year. So we're not quite certain what this imaging observation really means clinically. If you look at CT echoes in these patients, there's very little change in mean gradients. Even with the most severe forms of HALT, do you begin to see some changes in gradients? And if you look at clinical events, we cannot find a clear association between any clinical outcome event and this imaging observation. So we don't think there's enough evidence right now to indicate that this finding would commit to systemic anticoagulation or frequent use of CT scans and follow-up, unless it's driven by an event, an increasing gradient or a clinical event. And we'll see to what extent this does affect valve durability in the future. Transitioning to valve durability, this is probably the most important issue that we're going to have to manage in the future. It affects young patients. It affects bicuspid disease. It really affects the use of TAVR as a technology that can be applied to the lowest risk and youngest patients. We spent a great deal of time trying to define what valve durability means, and recently published the Valve Academic Research Consortium 3, where we have a very detailed description of what it means to have hemodynamic valve deterioration or structural valve deterioration using very clearly defined criteria. So we now at least have good definitions that we can use and apply, and these largely echo definitions combined with clinical events. Sushil Kadali from our group has taken these definitions. We've done probably the most intense propensity-matched analysis with Philippe Pibero, looking at 5-year outcomes in intermediate risk patients, comparing surgery and TAVR. And when we look at hemodynamic valve deterioration and we compare the two techniques, we don't see much of a difference. When we look at a bioprosthetic valve failure incorporating clinical endpoints, we also don't see much of a difference. So at least up until this point, through 5 years with the most rigorous definitions, the durability of these tissue valves looks to be fairly comparable to surgery. And if you look from 5 to 8 years with both the balloon expandable, the self-expanding valves with these kinds of definitions, structural valve deterioration is extremely low. and bioprosthetic valve failure is also extremely low. We need more data, clearly, and we are accumulating data, but at least now there are no major considerations about durability. There are some issues, because some of these valves will fail, about what is the safety and durability of doing a TAVR in TAVR procedure, and if you have a TAVR in place and you have to remove it, if you have to surgically explant it, what is the safety of that? And there are recent data talking to these issues. This very large retrospective registry that was published by Uri Landis, that we were part of, indicated that it's quite possible to redo TAVR in TAVR, that we can improve symptoms and hemodynamics, low incidence of procedural complications. There are some tips and tricks that we can at some point talk about, and we're now just beginning to do prospective studies, but this will be a big area in the future. How do you deal with a failed TAVR device? Do you surgically explant it? Do you put another TAV in it? And how do you choose which device to use, and how do you do the implant? I will say that there are some recent experiences with surgical explantation of failed TAVR devices. This is from a CMS database. It's a large report that came out last year in JACC of 227 patients. The 30-day mortality was quite high, 13%. And this is from the STS database, 782 patients, where again, the early mortality was 13.9% of surgical explantation of these TAVR devices. Now, yes, these were the earlier devices. They were in higher risk patients, so there may be some comorbid factors that contribute to mortality, but we still need to understand that it may not be so easy to explant these devices, and we need to develop some better techniques and better data in the future. Another important future issue is when you treat younger patients with TAVR, especially if they have concomitant coronary disease, the issue of coronary access is becoming a real concern. There's been a lot written recently about this. We are developing techniques where we can access the coronaries with standard diagnostic catheters and trying to understand some of the ways to do that technically. But I will tell you, it's not the same for each of the devices. And this was an interesting study called the ReAccess study that was recently published by Barbante from Italy, where he looked at a significant number of cases. And you can see the short frame balloon expandable device is much easier to gain access to the coronaries than the longer frame self-expanding device that covers the coronary ostia by a factor of, it's about a 20% failure rate in the longer self-expanding device. And that needs to be considered, certainly, when you start implanting these devices in younger patients. Another issue that we're trying to deal with, which is become an important issue, is how do we interpret echo-derived valve gradients? And is there a discordance between the echo-derived gradients in either clinical outcomes or the true invasive hemodynamic gradients? Well, the first thing I'll say is that echo-derived gradients were really developed to be able to diagnose stenosis. And if you compare in stenotic native valves, echo mean gradients and invasive hemodynamic mean gradients, you see a pretty good concordance. But if you put a TAVR device in and you're not dealing with a stenosis any longer, and you look at the invasive mean gradient versus the echo mean gradient, the relationship is not so strong. And in fact, there is a great deal of discordance, which can be problematic. So when we developed invasive hemodynamics, we're measuring a pressure difference. It's fairly direct and very clear across the stenosis. When we derive a gradient from an echo, we're not looking at pressure anymore. We're looking at flow velocity and deriving what we think is a peak and mean pressure gradient from that. And we're learning that flow velocity is very dependent upon flow patterns, how laminar the flow is or turbulent the flow is. So we're seeing now that the echo can overestimate pressure gradients in valves that have laminar flow, paradoxically, which is interesting. So we need to be taking these things into consideration when we just get an echo and we see a gradient and try to make clinical decisions. In fact, if we see a stark elevation in gradient, we need to look for things like hypoattenuated valve leaflet thickening, and we also need to check the gradient and make sure it correlates with invasive hemodynamics before you, in those patients, decide to either treat the valve or do a surgery to replace the valve. So this issue of discordance has become important. Another important issue from the very beginning of conduction disturbances. We were always worried about new pacemakers, but I'm going to raise the issue that even more important than new pacemakers is the appearance of new left bundle branch block. This is work done by another one of my colleagues, Tamim Nazif at Columbia. We looked at about 3,000 patients very carefully from the earlier partner series that had long-term follow-up. And you can see that about 10% had new pacemakers. Just under 10% had new left bundle branch block, and about 80% did not have any conduction abnormalities after the procedure. But the most important predictor of late clinical outcome from a conduction standpoint was not new pacemakers, but was left bundle branch block. And it was dramatically associated with an increased frequency of mortality, cardiovascular mortality, rehospitalization, and a drop in ejection fraction. So this is not a trivial observation. And if you convert these into Kaplan-Meier curves, you can see that over time, the presence of having a new left bundle branch block is importantly associated with a significant change in all-cause mortality by 3 years. So this is something that we're looking at very carefully now. Another unknown issue that we're struggling with is the optimal antithrombotic pharmacotherapy after TAVR. And this is both antiplatelet and antithrombotic meds. There have been some recent studies, the popular trial that was presented at the ESC meeting and published in New England Journal of Medicine. It was an underpowered study, but did suggest that aspirin alone was certainly as reasonable as aspirin and 3 months of clopidogrel. In fact, the bleeding was much less. Non-procedural bleeding was less. Almost any endpoint you looked at was actually favored by having a single rather than a double antiplatelet therapy. So now our norm is not to use dual antiplatelet therapy unless a patient also has had a recent drug-eluting stent, for instance. And many people have wondered if antithrombotic agents, and particularly some of the newer drugs, the NOACs or DOACs, might have an advantage over antiplatelet therapy. And the Atlantis trial was just presented at the ACC looking at apixaban, both in patients that have indications for oral anticoagulation, like atrial fibrillation, or no indication for oral anticoagulation, where they were compared in a dual randomized format to either Coumadin, a vitamin K antagonist, or antiplatelet therapy. And the results showed not much difference. And it was a robust study with a strong primary endpoint, not showing much difference. The only difference really was that they had a subset where they looked at CT valve leaflet thrombosis, and it was lower with apixaban compared with antiplatelet therapy. But there have been no changes in clinical outcomes. So from this and other trials, there is no primary recommendation to use antithrombotic therapy in TAVR as a preferred pharmacologic regimen. AS does not occur by itself. It is in the setting of concomitant diseases. You're all familiar with this, and many studies in the future will help to define how we treat AS in the setting of concomitant diseases. This is the largest randomized trial ever done in the TAVR space. It's called the Complete TAVR Study. It's organized through our colleagues in Canada. I'm on the executive steering committee. This is a randomization to complete revascularization versus just medical therapy in patients that have severe aortic stenosis receiving TAVR and concomitant coronary disease. This is a fascinating trial that is just beginning, but it will help us to understand how aggressively we need to treat the concomitant coronary disease, which is present in as many as 3/4 of patients with aortic stenosis, as you're doing the TAVR procedure. We've also completed enrollment in another fascinating study called Watch TAVR, which is aortic stenosis and atrial fibrillation, because 40% of patients with AS can have atrial fibrillation. And we did a very interesting study looking at putting the Watchman device in with TAVR versus just medical therapy, and we should have those results in the next year. As you know, bicuspid aortic valve disease has been a conundrum for us. The typical standard therapy is surgery, but more and more, and up to as many as 70% of patients over the age of 65 with bicuspid disease are now being treated with TAVR, and there are no randomized trials. There are many different kinds of bicuspid lesions, and we're not going to get into some of the specifics. We've learned from some excellent work done by Raj Bakar and his group at Cedars that there are some morphologic determinants of poor clinical outcomes not to do TAVR in bicuspid disease. So, for instance, a calcified raphe or excessive leaflet calcium. But this is just the beginning. We need to do much more CT phenotyping to identify other anatomic risk factors. And there are some low-risk bicuspid registries that have just been presented and reported, both 30-day and one-year outcome. First, with the self-expanding Evolute platform by John Forrest, showing excellent early results in a selected group of bicuspids who are low risk, with excellent hemodynamics and very little in the way of paravalvular regurgitation, which is something that we worried about. And more recently, from the Partners series, again, the SAPIEN 3 valve in low-risk bicuspid patients with excellent clinical results up to a year. And again, very little in the way of paravalvular regurgitation. So there is encouraging data, but more to come with bicuspids in the future. And finally, how do we manage some of the other categories of AS patients? The severe AS with symptoms, without symptoms, and the symptomatic moderate AS patients. And we call this upstream TAVR treatment. Right now, we're treating patients in the green zone, patients with severe AS and symptoms in various risk strata. We've begun to do new work in patients that have severe AS but no symptoms, and moderate AS with symptoms or other at-risk predictors in new clinical trials. We call this the upstream treatment of TAVR. This is currently not being done with surgery, but we think a low-risk procedure like TAVR might be an interesting alternative to treat sooner rather than active surveillance. So this is something that we are exploring now in multiple clinical trials. Certainly, there are interesting data in the literature. Most recently, this meta-analysis looking at asymptomatic severe AS, indicating that early surgery may be favored. These are 9 studies suggesting in each one that the earlier treatment in these non-randomized trials might have some benefits from the standpoint of major outcomes. So we designed the early TAVR study several years ago. We've now enrolled over 800 patients. The enrollment target now is 900, which should be completed in the next several months. And these are stress test normal patients with severe aortic stenosis and no symptoms. And they're randomized to either transfemoral TAVR or clinical surveillance with a 2-year composite clinical endpoint. And again, we'll have these results before too long. But this is a substantial population of the severe AS patients. And what about moderate AS? That's become now the big talk. Everybody is talking about moderate aortic stenosis. And a lot of it's derived from this echocardiographic survey study that was done in Australia by Jeff Strange, published a couple of years ago, showing that the moderate AS patients untreated had the same mortality, basically, as the severe AS patients, indicating that maybe this is not so benign and we should be treating sooner. So we began a study called UNLOAD to treat moderate AS and heart failure, a randomized trial looking at upstream or earlier treatment with TAVR versus optimal heart failure therapy alone. And we're about halfway enrolled in this study. And we're about to begin another much larger study called the PROGRESS trial, which is looking at-risk moderate AS, not just patients with heart failure, but patients that have valve-related symptoms, atrial fibrillation, a reduced stroke volume index, diastolic dysfunction, many markers that have been shown to be associated with increased risk in moderate AS. This will be the future of AS treatment, whether or not we should be treating upstream these patients sooner rather than simply waiting, as was originally proposed by Brownwald and Ross in the earliest recommendations on how to manage patients with severe aortic stenosis. With AS, we're dealing with a life journey. and often in younger patients. And now we're dealing with multiple sequential procedures. If you're over the age of 80, you're only going to have a single procedure likely. But if you're 65, you may have two, or if you're in your 50s, you may have three. So we need to be thinking about whether or not we're starting with either surgery or TAVR. A lot of this depends on valve durability. A lot of it depends on age, which is often used as a surrogate for life expectancy. The key clinical issues are to be able to provide optimal clinical benefits for our patients at any age. I believe we should limit the number of open surgical procedures to hopefully no more than one during the course of a patient's lifetime, and also to respect patient preferences, because that is more and more of a consideration. And we have begun to devise strategies where a TAVR first strategy may become the future preferred pathway for many younger AS patients. So I've tried to do in a short time, give you a very comprehensive survey of not only the good things about TAVR, but some of the evidence gaps and some of the ways that I think we're going to be able to approach TAVR in the future by having thoughtful clinicians, good clinical data, evolving technology that would allow us to treat the most patients creatively with a transcatheter, less invasive therapy that allows a minimalist approach and early discharge as opposed to open surgery. So with that, I'm going to stop here. And of course, if there's time, I'm glad to take any questions.
Great, great. Of course, Mari, the pandemic has never changed your excellence of presentations. Maybe we have a couple of panelists and time at the very end. So while a couple of panelists prepare the question, let me ask you a very simple question. I think we arrived to a plateau of excellence in interventional cardiology in the world of coronary artery disease. How far are we from a plateau of excellence in TAVR?
Well, that's a great question. I have to say I'm very proud of the way TAVR was developed, the way these sites were trained, the concept of the heart team. If you look at the TVT registry, Jorge, we've already gotten to that plateau of excellence. We can achieve excellent results with few complications, and the case numbers required to be able to do that at a center usually is either 50 or 100 cases a year. So I do believe that centers that have proper training and that have a sufficient case volume and subscribe to the heart team approach have already achieved a level of excellence where they should expect to have good results with low complications.
Maybe a couple of questions. I hate to choose a panelist, but please, whoever opens up the microphone, go ahead, and we have an opportunity to have Mari here.
Maybe.
Any questions?
Yes, Jorge, please.
Okay, I have two short questions. Hello, Mari. One is about a young patient, about 65 years old, but with a small annulus. Do you think that right now we should take TAVR instead of SAVR? Because after surgery, the residual gradient may be 30 or 40. So it's better to put first a TAVI now, at present. This is the first question.
This is not an easy question. So you put together a young patient and somebody who has a small annulus. With a small annulus, particularly with some of the balloon expandable valves, that the likelihood of achieving an optimal valve area might be less. So first, if I were to do TAVR, I might consider the valve that has the best hemodynamics, and that would be a supraannular valve, and those are generally self-expanding valves. There is a study right now being done to be able to look at this, balloon expandable versus self-expanding in small annulus patients. But you've also added the young age. So, at 65, and if it's a small annulus, particularly if there are effaced sinuses and any other negative anatomic features, I probably would favor surgery. In the future, we may have different valves that allow us to be able to achieve better results, but the combination of a small annulus and a young age, at least presently, I would probably favor surgery.
Thank you. The second one is about the learning. for interventional cardiologists that are starting the program, do you recommend to start with a more complicated, clinical complicated patient or with a low risk patient? Because here it looks like the opposite that in other subjects, interventional procedures.
Yeah, that's another great question. In the beginning, we started with the high-risk patients because we were worried. We were worried that in the low-risk patients, since surgery is so good, that we didn't have a technique that would be comparable. I would say that, frankly, I think that the high-risk comorbid patients with complex anatomy should not be done as the early cases. I think the early cases should be low-risk cases, but generally, I would say low-risk patients that are a little bit older. I wouldn't suggest that you do a low-risk 65, 70-year-old patient. There are many low-risk patients that are still in their 80s, and that would be, the perfect phenotype that you would want to gain some early experiences, because the procedures will be straightforward. You can generally use a transfemoral approach. You can expect to have good results. To me, that would be a better approach than taking very complex and high-risk cases first.
Una pregunta, Aníbal.
Thank you, Martin, for the answer. Matthias, please, for the sake of time, I would like to move forward in the program to leave some time at the end for more questions, because we have to respect the time. So I would like to introduce at this time Dr. Juan Granada, a very good friend also of SOLACI and CACI, and a supporter of our societies, who will present us about the future developments in transcatheter mitral valve replacement. Juan, thanks you for joining us.
Aníbal, thank you again for the invitation and for giving us the opportunity to be part of a session at SOLACI. You've been great friends over the years, and I really appreciate the fact that you always keep us in mind, and we keep collaborating on multiple fronts. As Marty did, what I try to do with this talk is to provide high-level perspectives of the direction where this field is going, instead of just showing a potpourri of devices and technologies, because I really think it's important to make emphasis in some of the most important opportunities and challenges in this field. This is my disclosure slide. I'm a co-founder of one of the PMVR technologies right now being under development. So when we talk about innovation in this field, one of the first things that we really need to talk about is what is available, what the challenges are, and what the main barriers to essentially develop these technologies are going to be. And I really think it's important to say from the very beginning that in a way, mitral intervention is started in a different playing field compared to high-risk aortic stenosis patients. And right now, surgery is the standard of care in patients with severe symptomatic mitral regurgitation. But procedural indication is highly variable and depends on clinical risk, anatomical considerations, and technical expertise. I like this paper because it comes from Cleveland Clinic, and it shows kind of the profile of the patients that undergo mitral intervention in big tertiary care centers. And if you see in this a group that included, close to 3,000 of patients, most of the patients underwent mitral valve repair. The patients that underwent mitral valve repair were, predominantly young men with a mean age of 56 years old, in good functional status. Most of them actually had posterior mitral valve prolapse with normal ejection fractions. If you go on the replacement side of things, patients are a little bit older, around 75 years of age, but it's still in good functional status, good ejection fraction. And if you see the factors associated with the election of replacement versus repair, predominantly older age, as I said before, and mitral valve calcification, but most importantly, surgical preference, essentially determine the election of the procedure. So if you actually look at the type of patients operated in tertiary care centers, there is some level of selection bias towards repair, and patient selection is influenced by patients' demographics, valve anatomy, comorbid conditions, and most importantly, also surgical expertise. The reality is a big proportion of patients with MR, high-risk patients with MR, are treated medically, especially in centers that do not really have high level of surgical expertise. This is another paper that I really like a lot because it shows the natural history of severe MR in the real world. Included 1,000 patients with severe MR seen between 2000 and 2008. 74% of the patients were FMR, 21% DMR. As it actually typically happens, DMR patients underwent surgery. In the FMR group, most of these patients were treated medically. And if you see the natural history of the patients that were not treated, essentially the outcome is not very good. 50% mortality at 5 years, and 90% of the patients rehospitalized throughout the follow-up period. So these patients do not really do very well, and this is a common occurrence when we encounter high-risk patients with mitral regurgitations that are essentially rejected from surgical procedures. So the high-risk MR population represents a big opportunity for catheter-based innovation. The presence of severe MR and heart failure is highly prevalent in the elderly, and this specific patient population is frequently rejected from surgery, not represented in surgical clinical trials, and frequently rehospitalized, adding significant financial burden to the healthcare systems. So catheter-based technologies may improve procedural outcomes in these high-risk patients, and this is where the impact of mitral valve intervention can really improve procedural, peri-procedural outcomes, and actually ideally long-term outcomes as well, making potentially a good impact on the healthcare system as well. This is a paper that is quoted very frequently because the outcomes that compare mitral valve repair versus replacement was published in the New England Journal 2014. And I'm going to talk about the outcomes of the paper. I really want to talk about the 30-day outcomes of the paper, where you actually see the cumulative rate of complications in highly selected patients in great surgical centers approach 35 to 40%. And you see that actually some of these outcomes, renal failure, bleeding, sepsis, respiratory failure, could potentially be decreased with the use of catheter-based techniques in a high-risk population. The second factor to take into consideration is the introduction of MitraClip. And TEER has demonstrated beneficial outcomes in prohibitive high-risk primary MR and selected secondary MR patients, what we call coapt eligible. The reality is several other important MR patient categories have not been really studied. An optimal MR reduction with TEER remains challenging in patients with complex anatomies. One of these clear examples that we see every day is mitral annular calcification, calcification extending to the leaflets, commissural fusion with mitral regurgitation, and these patients are not really infrequent. So several anatomical abnormalities make TEER less desirable, suboptimal, or actually contraindicated in a great majority of patients as well. The second issue is, and we learned this from the surgeons, that suboptimal results result in poor clinical outcomes. And if you look at the MitraClip data and other repair data, unless you really end up with optimal result, the clinical outcomes and long-term are actually not satisfactory. And this is going to be even more important when we use or try to use repair technologies in high-risk anatomies as well. Finally, transcatheter mitral valve replacement may provide an opportunity to improve MR reduction and clinical outcomes in this complex patient population. But let's see what the challenges are and what the data essentially showing us until now. The value proposition of this field is clear. It's ease of implantation. It's agnostic to the etiology of MR, primary or secondary. There's a reliable elimination of MR. and ideally less recurrence of MR over time. The question is if we're going to be able to achieve the same level of technical success and also the same safety profile as the surgical procedures or minimally invasive procedures implemented to date. One big limitation we have right now is all these technologies were designed with some philosophical principles, and they differ in terms of structure, architecture, level of anchoring, and mechanisms of anchoring as well. And there is a high variability on the mitral morphology and surrounding structures. And these are actually some of the things that we started to really learn from CT data: aberrant septal anatomy, septal bulges, severe MACs, subannular anatomical development abnormalities, and so forth, including the device interaction like patients having TAVR. Then TMVR designs, have limited ability to cover all potential architectural variations seen in MR patients. So unlike TAVR, the development of a universal device tool, like one design fits all, may be challenging, and we're going to have to accept that some devices may be better for certain anatomies and some devices better for actually others. So what have we learned to date based on clinical data using TMVR apical systems, in which approximately 1,000 patients have been treated to date in observational studies? And we have two programs that right now I think have most of the data accumulated to date at long term. One is the Intrepid program, using a self-expanding soft frame that is deployed top-down from the atrium first and then pulling down to the ventricle. More than 300 patients have been treated to date with 5 years follow-up on the earliest patients that treated. And the Tendyne system, that is a system that is tethered to the apex and anchored to the apex, secured to the apex, that got CE mark last year and has treated also several hundred of patients as well. The first thing is decreasing MR severity is actually clear. You see the Intrepid data here, post-procedural, MR was pretty much 100% success. And if you see at 2 years in a paired echo data, you see the percentage of non and trace mild MR is very, very high. So highly successful technology in abolishing, reducing significantly the level of MR. The same Tendyne data showing the same results at 2 years, with MR elimination achieved in 99% of the patients at 30 days. And you see very good results at 2 years as well. What about mortality? One thing that is interesting is the high mortality rate, because the population is studied in these observational studies are very, very sick. And you see a mortality rate that is very similar between both programs, around 37.8% in Intrepid and 39% in the Tendyne program at 2 years. What about rehospitalization? This is data from the Tendyne program, in which they were able to show approximately 47% reduction in heart failure hospitalizations, events, patients per year, essentially showing a clinical impact as well. And in terms of quality of life and functional status, you see that improvement in functional capacity in the patients that actually had paired assessments was maintained over time up to 2 years in both studies, Intrepid and also Tendyne as well. But everybody wants to see a transition to transseptal technologies. I mean, number one is less invasive, avoids interaction with chest cavity, avoids a surgical procedure, and intuitively is going to have less complications. But there are significant technical challenges to get there. Most of the devices right now are around 36 French or larger. There's a significant valve fatigue issues when you compress a valve of this size into smaller catheters, and the navigability and coaxiality challenges in devices that are this big are not really significant technological problems to solve. There are also the potential issue of vascular and septal injury with these devices of this size that have some people still, concerned and actually observing the evolution of these technologies. So the transition to these transapical systems, to transseptal systems, will require important engineering modifications in size, possibly valve design and anchoring mechanisms. So right now, the field of the transseptal TMVR has divided in two concepts. The ones that are using anchoring, what I call the two-step approach, and the best example is the M3 Sapien device, in which a docking station is deployed subannularly, and then a dedicated valve is put inside of these annulus. They have achieved already a feasibility proof of concept with very good procedural results, very good 30-day data, and short-term and mid-term clinical outcomes. And I think this is an exciting opportunity because it also allows the reduction of the size more rapidly than single-time approaches. And also the transapical system are moving into the transseptal world with already a handful of implants for several systems. We had a phenomenal live case presented at TVT with Intrepid system, in which right now, in a very reproducible way, this system is being used in more than a dozen of patients with very good clinical results. And this is the example of one of the implants in which the device goes top down, having very good technical and clinical results in a minimal invasive approach. The other program that we are involved is the Abbott program with Cephea that is also studying EFS and including Canadian centers very soon with the implantation of a fully transseptal device with a single step approach without the need of a cinching device or docking stations as well. The study is going to start later this month. So the future of the TMVR field, I guess everybody agrees that the final goal is to achieve a transseptal TMVR delivery. But in order to be able to achieve this, I really see multiple, or at least 4 requirements need to be fulfilled. First, we need to adapt the design to fit multiple anatomical variations, try to cover as many architectures as we possibly can with a single device. The device has to perform in real-world anatomy, especially in patients with MAC, being able to pack large sizes in small catheters, which is more a technical problem than a clinical problem. And the evolution of imaging, planning, and guidance has to move at the same pace to be able to perform these procedures in a safe manner. The programs are actually moving slower than TAVR, and the development pipelines are perhaps actually moving slower. As I presented, the transseptal system just started to get early feasibility data, but I think the data of the transapical systems is going to be essential to develop large clinical studies in the future with transseptal systems. So in conclusion, catheter-based mitral replacement is today one of the most exciting and potentially promising fields in interventional innovation. Unlike TAVR-specific device attributes will influence patterns of technology use, clinical outcomes, and physician adoption. The successful development of this field depends on a proper, thoughtful, and stepwise validation approach, including clear definition of the target population, refinement of the technology and imaging and co-registration tools, and lessons learned from the ongoing transapical studies will result in new technological improvements and trial design strategies that will hopefully contribute to the further development of this field. Thank you very much for your attention again and invitation to give this talk.
Great. Maybe some questions from the panelists, and then we'll have time for the next speaker.
Jorge, this is Enrique from Brazil.
Yes, how are you?
Thank you very much for the kind invitation, and that was really great. Well, it's always to hear from you. Marty is always very, enthusiastic for us. And mitral space, programs. And one of the things is patient selection. Sometimes you have a good idea, a good device, and after, end up with a 2 or 3 for, numerous reasons. Do you feel that with these new devices that you just presented with some iterations, we can, foresee in the near future to improve that aspect and have more patients, being able to receive such procedures. Even for the valving MAC, for instance, up to 30 to 40% of the patients might be excluded due to the new LVOT and other reasons. So how do you feel about that?
Ricky, nice to see you again. And you said it, and I said it on my talk. One of the biggest issues we have right now is the mismatch between anatomical and architectural findings and valve design and requirements, especially when it comes down to potential for LVOT obstruction or when patient has significant MAC as well. I really think of this exclusion are based on companies wanting to be very careful about patient selection and make sure that the right patients are included. But some are really true concerns related to potential limitations that technologies may have. So as I said, I really think that the transapical studies are going to teach us very meaningful lessons, and especially to the companies, to see if further design refinements are needed to be able to essentially increase the potential to cover a wider patient population. But your concerns and your comments are valid. That right now is one of the biggest limitations we have in these trials. And Marty is very involved in this field as well. So Marty, feel free to comment. Marty is deeply involved and the PI of one of the largest studies in this field. So.
Yo tengo una pregunta, Aníbal, si hay tiempo.
Yeah, go ahead. Go ahead if you have.
Yeah, we're struck with the fact that there are a lot of screen failures with the TMVR technology now, and but Juan's right. We need to do this incrementally. We need to be thoughtful. We need to be careful. 2 years ago, we didn't even know how to measure the neo-LVOT. Now we've gone through a whole series of studies to understand what truly needs to be measured, and the devices need to adapt to the anatomy. So I think that this evolves more in the way of device iteration than what we experienced with TAVR. So it's taking longer. But ultimately, I think we will develop the right technology to be able to achieve successful and safe transeptal TMVR with the predictable and complete elimination of MR, which may be important in many of the patient categories.
Matthias,
Maybe you have one more question, or yes, somebody was going to ask a question. I think Barbara Gelata or Matthias.
No, my question is, you know that with mitral clips, we have a difference between the mitra and coapt in heart failure patients. So mitra show sicker patients in heart failure, more ventricular low EF, but coapt show more MR than ventricular dysfunction. So don't you think in the mitra type of patient would be easier to close the annulus like Carrie Young is doing, or this kind of devices that can decrease the size of the annulus in order to decrease the heart failure in those patients, and easier to implant?
So annular based technologies, have been tried by many companies before on the mitral side of things, and technologically speaking or procedurally speaking, I mean, is not easier than MitraClip. I mean, technically speaking, their imaging, intense, and the thing is being able to change the annulus to a level that can produce the same level of annuloplasty the surgeons get is actually quite challenging. I really think there is a lot of potential for repair technologies in the mitral space yet. I think there potential for improvement and potential for development, new repair technologies, especially annular-based technologies. But it is not really as simple as it seems. For multiple reasons, because access, because lack of tissue to be able to really anchor whatever you're going to anchor and actually cinch the annulus, But I agree with you. If you ask me, what are the technologies that I really think would be more promising, I would actually say annular based. But it's still, it needs to be proven. A lot of technologies are trying to do that using different mechanisms with mixed results.
Great. I think there is one question from Matthias, and then we have to move on to the next presentation.
Okay, thank you, Jorge. I have one question. The question is, what is the principal barrier to do not go as fast as in the TAVR field with the development of these devices? Is the first size, is the type of anatomy, is the pandemic situation, but really, as Juan said, the velocity of development of the technology was slower than the TAVR devices. So I will ask this.
What do you want to answer that you've been exposed in designing and redesigning and redesigning?
Well, it's a very good question. It certainly was not by intent. Initially, there were over $2 billion that were invested in acquisitions of new transcatheter mitral valve replacement technologies. I would start with the disease. It's not one disease. It's multiple diseases with multiple disease variations. So you're not dealing with a single morphologic entity, and you're dealing with, certainly in secondary MR, with a lot of underlying myocardial disease. You're dealing with anatomic considerations like MAC, which are very problematic. It's a very different anatomic substrate. So I think the disease complexity contributes to how slowly it's taken us to get going forward. That's one. And a second is that initially it was thought that we could apply a transapical technique and achieve good results that would be lasting and durable and safe. And it's been more difficult than we would have imagined. These are dilated, many times thin ventricles that are dysfunctional, and a transapical approach is simply not going to be the ideal access. So it means going transeptal, which means further miniaturization, which means complexity in terms of redesign, which means the kind of anchoring systems that predictably can allow these to be deployed in a correct location. There are many technical and anatomic challenges. So it's simply taken longer, I think, to get to the vision that Juan suggested. But I think we'll get there. I think we're much closer. We're right at an inflection point now to start seeing pivotal clinical trials beginning and more EFS studies starting. So I think over the next 2 to 5 years, you're going to see much more rapid development in the mitral space.
Okay, I think in the interest of time, thank you for the question. That was very good and a good answer. Maybe we should move on to an interesting field in interventional heart failure. Dr. Dan Burkhoff will give his minutes, and after this, we'll have time for the discussion with the rest of the panelists who were not able to ask questions yet. Thank you, Dan, for being with us. Microphone, please.
Thank you, Jorge, and thanks for the invitation to participate in this symposium. This is my first participation in this forum. And I'm going to talk to you about a very complex topic of interventional heart failure. And these are just a few disclosures. So what is interventional heart failure? Well, as a field of study, interventional heart failure we think of as the development and investigation of procedures and implantable devices used for diagnosing, monitoring, and treating patients with all forms of heart failure. And it spans low EF, high EF, acute heart failure, cardiogenic shock, and of course, chronic heart failure. Now, unlike the situation in structural heart disease where we're predominantly talking about one target, we're talking about the aortic valve or the mitral valve or the tricuspid valve. When we talk about heart failure, there are many, many different targets that one could go after. And for that reason, it's relevant to understand what we refer to as the vicious cycle of heart failure and LV remodeling and where different therapies fall into the therapeutic paradigms. So just by way of very quick review, this is the vicious cycle of heart failure, which starts with myocyte loss or weakness, which reduces LV pump function, reduces cardiac output and blood pressure, and that then leads to a host of activation of sympathetic adaptive mechanisms that involve the baroreflexes, the renal RAS systems, elevation of cytokines, elevations of wall stress in the myocardium. These all lead to elevations of neurohormones, sodium and water retention, elevation of ANP and BNP, and a systemic inflammatory response. Now, in the short term, these mechanisms increase afterload, preload heart rate and contractility, and are intended to restore blood pressure and cardiac output back towards normal values. And this is, in the short term, this can be adaptive. However, when these feedback mechanisms fail to normalize cardiac output and blood pressure, and these systems persist, it becomes a maladaptive process, and that results in remodeling, which involves hypertrophy of the muscle, fibrosis, dilation of the chamber, mitral regurgitation, tricuspid regurgitation, dyssynchrony, arrhythmias. The inflammatory response and these elevated stresses lead to apoptosis and further loss of myocytes. And these two combined further contribute to this vicious cycle where there's further weakening of the heart. So this is the vicious cycle where heart failure begets heart failure. On the physiological basis, what happens is that there's an acute reduction in contractility. That results in this neurohormonal activation, which tries to restore blood pressure and cardiac output. And again, when this fails to normalize hemodynamics, and there's chronic neurohormonal activation, we have this remodeling process where the heart structure is such that the end diastolic pressure volume relationship and the end systolic pressure volume relationships are shifted way to the right. And this is what causes reductions in ejection fraction and blood pressure. And again, this is a progressive process. So the goal of heart failure therapy is actually to reverse this process of remodeling. We've referred to that as reverse remodeling, where we try to take the large heart, remodeled heart, reverse all these processes, and get the heart back towards a more normal structure and function. And in fact, what we can see is if we look at the various drug targets that have been successful, we look at diuretics and now SGLT2 inhibitors that address salt and water retention. We have ACEs and ARBs that address the activation of the RAS system. We have beta blockers that address the activation of the sympathetic nervous system. We have aldosterone inhibitors, again, targeting the RAS system. We have neprilysin inhibitors that address the ANP and BNP. And most recently, there are also myofilament activators that try to increase the contractility safely of the myocardium. And pretty much what we've learned from the drug therapies is that medical therapies that reduce LV size, that is that reverse remodel, are generally associated with improved clinical outcomes, specifically in this case mortality, but not only mortality, but also reductions in heart failure hospitalizations. So following the lead from drugs, there still, despite the success of drugs, there still is a relatively high mortality and high morbidity in heart failure, and devices are now have been developed and are being developed that are trying to do the same thing, to reverse remodel the failing heart and actually interrupt this positive feedback system that results in progressive remodeling. So, for example, we have left ventricular assist devices that actually take over for the work of the heart and directly improve the cardiac output and blood pressure and reduce the wall stress. We have a lot of investigational devices that are addressing renal hyperperfusion and acute and chronic retention of salt and water. We have renal denervation that's, again, also addressing sympathetic activation and renal hypoperfusion. We have intraatrial shunts that are addressing especially the acute increases in preload that occur in these patients during exercise. And we have a host of devices like we've already heard about mitral valve replacement repair. There's also a huge number of tricuspid programs. We have CRT that's addressing the synchrony, and ICDs which address the arrhythmias. In addition, there are a number of devices that are trying to address directly this issue of remodeling, taking the large heart and making it smaller. And there are a number of therapies that look at directly improving the contractility of the myocardium, either through cell therapy, gene therapy, or electrical stimulation via cardiac contractility modulation. And finally, we have baroreceptor stimulation devices and also splenic denervation devices that are addressing the sympathetic activation and what they do to the neurohormonal milieu and to the hemodynamics. So if we look at interventional heart failure kind of very broadly, there are many classes of devices that involve monitoring either invasive or non-invasively the hemodynamic status that are being used to help optimize medical therapy. We have devices for acute decompensated heart failure and chronic retention of fluids. We have implantable pulse generator classes. We have the renal denervation. We have intra-atrial shunts. We have mechanical circulatory support, both temporary and durable. We have all the structural heart disease devices, mitral, tricuspid, and aortic that you've already heard about. And we have the LV reshaping devices. Now, there are already a number of devices that are approved or cleared by the FDA, and there are a larger number of devices that are available outside of the US, but a lot of these have met with variable adoption in both the United States and outside of the United States for various reasons. Nevertheless, this continues to be an area of very, very active research and development. So I just wanted to highlight just a few things, three classes of devices, the devices for decompensated heart failure, intra-atrial shunts, and LV reshaping as kind of prototypical device classes that are addressing part of the cascade of progressive heart failure. First is for decompensated heart failure. And this is really, there are currently 7 classes of devices that are under investigation to improve renal perfusion and urine output to deal with volume overload. And we developed this acronym DRIPS that kind of classifies these classes of devices as dilators. These are devices that dilate the venous bed to try to reduce the filling pressures on the heart. Removers, these are devices that directly remove fluid from the body, like aquapheresis or dialysis. Inotropes, which try to increase the cardiac contractility to improve the perfusion of the kidneys. Interstitial devices, this is mainly devices that work on the lymphatic drainage to enhance lymphatic drainage. Pushers are devices that increase the pressure head of the kidney to improve renal perfusion. And pullers are devices that work in the renal vein to reduce the central venous pressure and by that way improve the perfusion. And then selective devices are devices that selectively infuse drugs into the renal arteries to induce renal vasodilation and again to improve urine output via improved renal perfusion. So just to highlight a few of these devices and concepts that are under development. This is a concept of splanchnic nerve denervation. The splanchnic bed holds a lot of volume in the blood volume of the circulation, and in heart failure, the splanchnic bed can constrict and raise the pressures throughout systemically. There's a concept of using a greater splanchnic nerve ablation to reduce pressures and dilate the venous capacitance, increase the venous capacitance of the splanchnic bed. And here at the bottom, you see here the pulmonary capillary wedge pressure of a series of patients prior to a device in red, where you have the pulmonary wedge pressure at rest, and then during exercise, and then following a splanchnic nerve ablation, you see here that there's about almost a 10 millimeter drop in pressure across the board, not only at rest, but during exercise. And over this 12-month observation period, these patients have a marked improvement in their New York Heart classification and also in their quality of life as indexed by the Minnesota Living with Heart Failure questionnaire. So this is one of these concepts. Here we see on the left here the pushers. These are pumps that are placed percutaneously that pump blood from the thoracic aorta to the abdominal aorta in hopes of, with the intention of increasing the renal pressure, renal artery pressure to improve GFR. At the bottom, you have pullers. These are devices that reduce the pressure in the renal vein, again, to increase the pressure gradient for perfusion and to improve renal perfusion and therefore urine output to get rid of more salt and water. And on the right side here, we see the concept of decompressing the thoracic duct, which by reducing the outlet pressure in the region where the thoracic duct enters the subclavian vein, there's the goal of improving the removal of interstitial fluid from the tissue and getting it back into the circulation so that it can improve, again, renal function and be eliminated through the urine. So these are several concepts. These are all, of course, are focusing here on the devices that are that would be considered interventional devices that would be placed by interventional cardiologists. Most of these devices are currently being developed as acute devices, but all of them, most of them do have the goal of transitioning to chronic devices that would be for chronic implants. Intraatrial shunts have received a lot of attention lately, and the rationale for these is that there's a common pathophysiological finding in most forms of chronic heart failure that wedge pressure increases dramatically during exercise. And you see here, again, what I kind of showed already, that in patients with heart failure, when you exercise them, their wedge pressure goes up very quickly. This is 1 minute of exercise. Wedge pressure is going up to 30 millimeters of mercury on average, and then increasing further at peak exercise and coming down after recovery. So there's something about this extra added sympathetic activation that occurs early with the onset of exercise that really is contributing hugely to these patients' symptoms. And the black here, you see control. These are patients without heart failure, and you see there's relatively little change in wedge pressure in a normal cohort in response to exercise. So this is really what intraatrial shunts are trying to get at, is this dramatic rise in filling pressures that occurs. And the concept was advanced in the early 2010s that implanting an intraatrial shunt would allow for a pop-off valve, in essence, that would reduce the wedge pressure during exercise. And this field we launched very early on, before there were clinical data, looking at what would be the effect using cardiovascular simulations, what would be the effect on both pulmonary wedge pressure and right atrial pressure if we had a shunt in place, and also what kind of a shunt would we want. So this just shows the shunt diameter as a function of, this shows the left atrial and right atrial pressures as a function of shunt diameter in a simulation of a patient during exercise. And we can see as we increase the shunt diameter, the wedge pressure indeed drops and the CVP goes up only a very small amount. But after you get to about 8 millimeter diameter, you've kind of reached the maximum amount of reduction in the pressure gradient between the right and left that you'd hope to see. So as a result of these, there have been several devices that have been developed. These are just 4 of the current devices. 3 of these actually leave a device behind. There are new concepts which are using ablation techniques or cutting techniques, excision techniques, to create a durable communication between the right and left atrium in the intraatrial septum. And right now, the best data we have in terms of the hemodynamic effects was from the Corvia study, the Reduce LAP HF1 study, where we looked at exercise hemodynamics in a double-blind placebo, a double-blind sham procedure-controlled study. In control patients, we see at baseline in 1 month really no difference in the wedge pressure during exercise, whereas in the IASD patients, there was about a 3 to 4 millimeter reduction at each level of exertion here. So this is right now the level of evidence that we have for this device. The Corvia study has just completed a pivotal study, the LAP HF2 study, a double-blind randomized study that whose results will be available this fall within the next few months. So we'll see if there is a clinical benefit associated with these changes in hemodynamics. Now, what about heart failure with reduced ejection fraction? More specifically, targeting reverse remodeling. Well, I've already mentioned that the goal of therapies is to reduce the volume of the heart, and there are several device-based therapies that are trying to mimic physically what drugs do biologically. So when we think about reverse remodeling, when we talk about drugs, they achieve reverse remodeling by biological means, by blocking certain pathways. But can devices do a similar thing and accomplish similar outcomes using physical means? So one such device is the BioVentrix device, which is intended for patients with large anterior septal infarcts and dense infarcts and aneurysms that actually excludes the infarcted region by implanting a series of anchors, one side of which sits on the right atrial side, on the right ventricular septal side, and on the other side is on the left ventricular free wall epicardial side. And by placing these two anchors and drawing them together, you can pull and exclude the infarcted region. So this device would clearly reduce the size, exclude the infarcted myocardium, resulting in a smaller chamber, which hopefully on the balance has a greater contractility. Another concept was the idea of implanting a device in the apex of the heart that would again exclude the infarcted region. This is called the parachute device. It's now being studied in another incarnation. But here you see pressure volume loops, black being baseline and blue after the procedure. And what you can see is that these pressure volume loops reveal, for the most part, a reduction in size of the ventricle, the end diastolic volume being smaller, but also, more importantly, an increase in the contractility indexed by an upward and leftward shift of the end systolic pressure volume point. So this is a proof of concept study showing that excluding aneurysmal, apical aneurysms can improve size and function. Again, we don't know yet about the clinical outcomes, but this is an intriguing concept. And finally, we've got a device called the Ancora device, which is a series of anchors that are implanted in the endocardium that are all connected by a cable that can be cinched and draw the lateral wall of the heart in, and therefore reduce the radius of curvature. The thing that was interesting about this, if you look at, this is just a case report, this is left ventricular end diastolic dimension here in red, and what you see is that following the procedure, there's only a little bit of a change in the size of the ventricle, the end diastolic dimensions, but over time, this process progresses, and telling us that once you reduce this wall stress on the heart, you interrupt that positive feedback cycle, that deleterious positive feedback cycle, interrupt that process, and actually the heart on its own can invoke mechanisms that will further reduce the heart size. So in summary, we've just reviewed the field of study of interventional heart failure, which is development of all of these investigational devices. But going along with that, there's also an emerging professional discipline of interventional heart failure. And this is a group of clinicians that are getting formal training in both interventional cardiology and in heart failure, because now you can imagine, first of all, that if the heart failure patient is kind of at the center of a lot of the technologies all the technologies that I've talked about, and even when you start getting at the mitral and tricuspid fields, the patient kind of visits, and all of these disciplines are physicians and nurses and physician assistants from all of these fields are involved. And currently, it's really the heart failure cardiologist that's kind of at the core of coordinating this care. So there are a number of people that are now getting dual trained, not only in heart failure, but interventional and maybe to a lesser extent in structural disease, but cardiac intensivists and electrophysiologists. And these people are now emerging as a profession of interventional cardiologists. So the field is not as mature. It's been around maybe for longer than structural heart disease, but in the end is not as mature as structural heart disease at this point. mainly, I think, because there are so many different targets that one can go after. There's not been a concerted effort in one single target. And as a result, we have a lot of different approaches, a lot of activity in heart failure. And in fact, at CRF, we're now creating a new meeting called THT for Technologies in Heart Failure Therapeutics. The first of this meeting will be held on February 1st through 3rd in New York City. Provided the pandemic does not get worse, it will be an in-person and also live broadcasted meeting from the Marriott Marquis in New York City. So thank you again for the invitation to present, and I will stop here.
Thank you so much, Dan, for this amazing presentation. We have time for two short questions, 2 short answers, please, before Dr. Velarde closes. And I think to privilege the 2 panelists that have not participated, Dr. Leiva or Dr. Hurtado, please, 1 short question each.
Yes, I have a question for Dr. Leon. I'm very interested in what's about paravalvular leak. That is one of the main problems of the TVR. In the next future, how can we lower the rate of paravalvular leak?
Well, first, there's no question. In fact, we pointed out the paravalvular leak was an early consideration and a concern for us. Particularly, we demonstrated that either moderate or severe paravalvular leak was associated with an increase in all-cause mortality if you follow these patients longer. But I will say that the devices have evolved, and the current generation of devices, moderate or severe paravalvular leak occurs usually in 1, 2, or 3% of cases. And even mild PVL is now being reduced by some of the additional device modifications, including external cuffs and wraps and a variety of things. So whereas paravalvular leak certainly was a concern for most of the modern current generation TAVR systems, it appears to be much less of a concern. Even in bicuspid disease, where the calcification can be severe and very eccentric, in the early studies that have been done, the severity of paravalvular leak was surprisingly low. And when compared in propensity matched cases with tricuspid valves, was no greater in bicuspid than tricuspid valves. So to me, that's more of a problem of the past than the present or future.
Dr. Hurtado, just 1 short and last question, please.
Thank you. Maybe how do you see the future of mitral clip or TER therapy in this kind of patients in the near future?
To whom of these speakers, please? Dr. Hurtado, the question was to Dr. Granada or to whom of them? Just 1 question, one answer.
Dr. Granada, maybe how do you see the future of mitral clip or TER in the near future for mitral valve disease?
For mitral valve disease. No, I think that, I mean, the data is clear. The procedure is being highly standardized, which is important. Is now in the hands of many physicians, so it is actually reproducible. One of the things that I believe that should be improved is the development of more refined algorithms to predict success. I mean, you know that sometimes is unpredictable. You put a clip, the improvement is marginal. You put the second clip, the improvement is slightly better, but not optimal. And I really think that further modifications of the technology could potentially really help to achieve, better resolution of MR reduction. But I really think it's going to be, a clinical judgment and actually also anatomical indications. Now, the question in terms of actually which one is going to be better, one versus the other, time will tell. And I really think only data will be able to solve this question. But I really think at the present time is a solid technology with actually solid indications when the anatomy permits.
Okay, thank you, Juan, for the answer, and the session has been outstanding. I would like to invite Jorge to close the session.
Great. Okay. First of all, thank you to all panelists, all speakers. Has been a tremendous talk. I should have one word of gratitude specifically to Mari because it's more than 30 years. And plus that you came with a plane to our meeting that we had very early. Remember there was a J&J plane and you came to our meeting with the first answer we were implanting. And ever since, you were a tremendous support to myself, to Argentina, Brazil, all Latin America, and this is consistent with a very open mind, with eager to learn what's going on around the world. This specific meeting is very generous in giving us up to date in what's going on. So it's a personal gratitude really to so many years of support. And good luck with this pandemic, and I hope the life keeps on going. I don't know when, but whenever it restarts, we'll be there. Thank you again to all of you.
Thank you all, and please, the audience, keep tuned for the next session. Bye-bye.
Thank you.
We are on live.
Good. Hi, Alfred.
Yes.
Hello, very nice to that you be able to be here the first time of CRT on live in SOLACI-CACI meeting. Is our pleasure to see you and your team join us. Thank you.
Well, thank you for the invitation. We're very excited to be here this morning. I'd like to introduce the team, Dr. Itzik Ben-Dur to my left and Dr. Haider Hashem. We have one of our fellows, Giorgio, and we've got a lot of people in-house here that are going to make this a successful procedure. We are short on time, so we'd like to proceed directly with the presentation. Giorgio, can you bring up the slides?
Thank you, Dr. Sattler. Good morning, everyone. We have an 82-year-old female, past medical history significant for hypertension, hyperlipidemia, diabetic, CKD with a baseline creatinine of 1.4, coming in with chest pain, found to have an NSTEMI, peak high sensitivity troponin of 3,300 and referred for cardiac catheterization. Next slide, please. And I'll just go through the films. Next slide.
So what you see is a ostial LAD lesion. There is some disease in the left main. And in the next run, you'll see an occluded right. But focus on the right panel. You can see that ostial LAD.
Next slide, please.
And here's the occluded right.
And next slide, please.
Is it possible to increase the image?
Mostly inferior wall hypokinesis or akinesis.
And next slide. Next slide, please.
Yeah, so in summary, we have an 82-year-old with a non-STEMI, a heavily calcified 90% ostial LAD with an occluded right.
Okay.
So suggestions on management.
We would like to see your, what is your plan?
So we have also Dr. Sharma on the call and wonder what he thinks. But the question is, do we need support for this case? That's number one. You have an occluded right. You're going to do procedure to this ostial LAD. Samin, what was your thought about it?
So I think, clearly it looks like a calcified, and this is a high risk
group. Go back
group.
3 slides.
Yeah. So this is definitely a high risk group, which can develop complication in the cath lab, although it's not very severe LV dysfunction. But what we learn nowadays that using LV support takes us through the procedure at ease and let us do the job what we're supposed to do and not in a haste, like quick balloon dilatation or cut short of the
intervention. Can we go back 3 slides, please?
And clearly we want to do imaging here to identify what type of calcified lesion we have and to tailor the right device, because we have now several devices that we can choose.
Yes.
Exactly.
Another question, Ron, if we do femoral or radial, this is another. this option.
Yeah. So now everybody is pushing to radial, but you know, I'm more conservative here, so I would use femoral.
Who this one panel will select radial for this case? I raise my hand in favor to femoral, 100%.
Yeah, that's in me too.
Oh, nice to see you.
Finally. Yeah, I think the key message that we feel is we want to take care of the lesion and not get distracted by support and other things that make it more complicated than it needs to be. So with that in mind, she does have peripheral vascular disease, Ron, so that Impella support wouldn't be an option. We can use a balloon pump if we need to, and we have access to that immediately. But we thought that we would do this without support. And a lot of it depends on the imaging that we obtain to determine the treatment modality. But maybe as Hader can show us the OCT.
Before the OCT, let me just show you what we did. So, and either we show the OCT.
Yes, I'm ready.
We are femoral and we are 8 French, so we have a lot of support and a lot of options. And let me show you. Can you show? You can see the screen. So the first picture probably. Let me just play it. Sorry. Here you can see. So probably this is the first mistake. You see, there is more left main than we think so, because as soon as we put this EBU 3.5 guide, there was dumping on the pressure.
Yes.
So it's not only ostial LAD. So either BN took out the guide, did sidles, and put back the guide with sidles. We tried to cross with the OCT. OCT didn't cross. So we took a small balloon, only 2O compliant, to get the space for the OCT. And then that's all. We are here, and either we did OCT, you can describe.
So good morning, everyone. So I'm just going to go over it. Can we show the OCT, please, to the meeting?
And maybe you'll share with us what's the hemodynamics right now of the patient, because that's very important, not to start with the blood pressure.
So the blood pressure is about 180 over 80. So we have a lot of pressure
with
support.
the guide out. When the guide coming in, it's dropping, but the guide is out, even with the silence.
The fraction of this patient is 45. So I think we do have some reserve, you know, when you consider about any additional support like balloon pump or Impella. So I think we can do it without any MCS device.
Why
Perfect.
you can try. Please, you can try. Why did you select OCT instead IBUS? Because this lady has 1.4 creatinine. Maybe IBUS would be a better option than OCT.
So that's true. Thank you for the question. So I'm going to address it in 2 aspects. I will get to the renal function in a second. But with the why IVUS versus OCT, there's definitely a superiority for OCT, not to define the presence of calcium. It's more so to describe the features or characteristics of calcium. And most importantly, what we've been dealing with is not superficial calcium that we can see. It's the thickness and deep calcium, and that's better seen by OCT based on multiple literature. With IVUS, you'll be able to see the calcium. You could see the shadowing behind it, but it's hard to define how thick of a nodule or how thick of a calcium plate you have around the artery. So for that reason, I do prefer in my practice using OCT, not to identify calcium. It's more so to understand calcium better than I do with IVUS. So that's number 1 question. Number 2 concern, which is always a problem with me using OCT almost all the time in the lab, is CKD and kidney function. I have developed when I do the OCT pullbacks, I do manual pullbacks, which allows me the second I identify contrast moving by the camera or the sensor, I trigger the pullback myself, and that will save you time and also save you contrast, because you don't have to wait for the automated machine to pull for you, which is usually 4 to 5 cc's of extra contrast before the pullback initiated. So that's number 1. In this case, we are in the ostial LAD,
which means that I don't need to do a full run. Despite the fact I used to still see my guy down here in the panel, I could have stopped with the injection because I'm very proximal. The minute I see, the second I see contrast washing out, I'll trigger pullback. This pullback was done with 6.2 cc's of contrast only. Now, have I done normal saline? Yes, I have done it. The only difference you need to do is to change the setting on your OCT machine to tell them that the machine that the contrast media is, that the media is not contrast, is saline, and you can still do it safely. Ziad Ali and his colleague demonstrated that very safely. So I hope I answered your question. I'm going to take you now through the run for the second time. Sorry, yes.
One question. When you also the OCT will help you to define exactly the spot lesion and determine what kind of stent, the length of the stent that you're going to use. Instead of using a very long stent, you're going to be very focal into the lesion.
Correct. Yeah,
that's true. And that's the beauty of imaging. Absolutely correct. So I'm just going to try to take you down this way. I'm distal. This is the D. This is the P. So I'm distal, pulling back into the LAD. This frame is probably an ideal frame to show. This is the down here. You have contrast or blood swirl because the lesion is too tight, and you create some flow turbulence. That's why you see this. However, you can easily identify that this is the intima, and then right there, I'm going to mark it with, this is the calcium. This is how calcium will look like on OCT. The difference here, it's low attenuation, well demarcated. You could see behind it, as opposed to IBIS eyes. So if you have your IBIS goggles, please take them off because there's a difference here. Now I'm drawing this kidney shape. This is the calcium. This is a calcified nodule on this side. Now, obviously there is more calcium here, but the image is interrupted by the wire artifact, which is this cone-shaped artifact from the wire. If I want to define this, I'm going to say this is at least 270 arch of calcium, starts from here all the way out. I have some preserved architect of the vessel wall. I have intima, media, and adventitia, but this is definitely thick calcium, and I can measure the thickness for you in a second. So this calcium from here to the end is 0.74 of a millimeter. 0.5 millimeter and above is defined in all trials and registries to be a thick calcium. But again, this is a 270 arch. Now, if you drive back all the way proximal, there's all features of plaque here. There is some normal tissue. There is thick fibrous. There is some intimal disruption here, most likely from our balloon. I'm coming all the way back to the lesion. This is where the lesion, this area here is a calcified nodule protruding into the lesion. And that will play part of delivery of equipment down the artery. The wire is biasing away from it. So that's also can help you with identifying with a atherectomy device you will use if you want to use a atherectomy device. And then this is all fibrous plaque on this side of town.
So how far away from the left main?
So we're not far away. So there is the plaque extended back to the left main. This is now left main. This is an intimal disruption or a medial dissection that we created iatrogenically by the balloon, the predil balloon, to deliver the OCT. There is a calcified nodule here. There is wire here, and this is fibrolipidic plaque. Now this is the lipid, which is a sand washing through the shore. It is high attenuation. You cannot see adventitia behind it, and it's all granular. So this is fibrocalcific lipidic plaque. Has all the features for an NSTEMI because it's lipidic, probably vulnerable in certain area, but definitely calcified artery.
So Haider, based on this, which device are you planning to use? Because I mean, I have to watch the time as well. So
I'm sorry, I apologize. Yes. So the luminal area I'm getting here at the tightest is 2.86. So that will take us to what device you want to use. I'll ask the panel.
The other question, if you need device, because it's 270, we can do both option device. Let's ask the panel what they think.
You can have balloon, you can have a CSI orbital, or you can do directional, or you can do IVL shockwaves. I mean, what would be your first, second choice?
Yeah, well, I mean, again, there is a 270-degree calcium, right? I mean, 180 is kind of cut off from those which we have mentioned, and I wasn't sure what is the thickness, more than 0.5 millimeter and one more than 180-degree calcium angle or arc, really, and this little longer lesion, I prefer, particularly it's kind of getting to the ostial left main. It's not necessarily ostial. Aorto-ostial, we know we don't have a good result with orbital. In this particular case, not using the support device. And if you want to use an IVL, knowing that balloon has to be left inflated for longer period of time with RCA total. So I will be a little concerned. So my first strategy would be use a rotational atherectomy with the 7 French 1.75 bar. Even if the lumen is good, we all know they cut in the eccentric area and will let subsequent balloon dilatation with the cutting balloon or flextome or scoring balloon.
So one question, you have a 175 there, but you have 2-point-something lumen. So how effective it's going to be still ablating, because it looks like it's going to fly through.
Yeah, that is a very good point. So it always happens. So you can change the wire position. Key is that we need to just cut that calcific 270 arc, create 1 or 2 fissure in that 270 arc, and then the subsequent balloon will expand it.
So do you think it's better to use an extra support rotowire as opposed to a floppy?
That's, I would say, for that purpose, yes.
Yeah.
But I think, I think in this case, she's hemodynamically stable. If we do shockwave, it will. I can leave the circ wire across, and it will be relatively facilitate the procedure to be simpler instead of exchanging to rotowire. Shockwave we might work also. Do you agree, Loel?
Yeah, no, I do.
I think so. Yeah.
That's the appeal,
So can you tell us the
Dr.
diameter of
Sharma,
the-
that's the appeal to us on this type of a lesion where you've got a bifurcation in the left main, that the shock wave will give us, we have a controlled inflation time. We have protection down the side branch.
Yep.
And, it has an ideal substrate to be effectively treated with a single, a short number of pulses. So I think that's what we'd like to do.
So either measure diameter of the LED trio. So we take 3 or 12 shockwave,
Okay.
correct?
Yeah.
So for how long would you inflate the balloon on the shock wave?
Sure.
For how long? To try the.
True. We'll explain once we get the balloon in. We'll go over the how we did it in Disrupt CAD3 trial. We enrolled patients in our institution. The way it's recommended to use IVL is to use 1-to-1 balloon, and then you go up to 4 atmospheres. Each catheter or each balloon comes with 80-second total of treatment time, and this is divided into 10 seconds each, which means you have 8 allocated episodes. The recommended is to at least do 2 treatments, total of 20 seconds on each lesion. You inflate the balloon for 4 atmospheres. And then after you deploy your treatment, you go up to 6 atmospheres. Now, there are different iteration of clinical practices now. I think the 4 atmosphere is a good goal because you want to avoid barotrauma. You just want to deliver. You want to deliver and then 10 seconds is each treatment. Now there's beauty. You control the amount of pulses you are doing because we're going to hold a button on the table to deliver the shocks. If you feel that there is a compromise clinically, you can stop inflating. You deflate, don't give the full treatment. Not recommended because you want to have the 10 seconds in or the 10 pulses in. But if you see compromise, you can stop. So that's what we're going to try to do.
For the audience to be able to see, can you put us on the side and put hemodynamics and fluoro live so you can see the blood pressure when we do exactly, and you can see the balloon if it's crossing. I think it will cross, Lowell, but if it's not crossing, it's a different scenario. Because just reminding you, the OCT didn't cross initially.
Yeah, one thing.
Can I do a question?
One nice thing about the OCT is about the shockwave that usually there is no issue of distal embolization, which could be a problem later on, and no dissectors. I mean, the results of the CAD trial I will show you later on were almost like
want to explain to do?
And the known complication that you would worry.
From a teaching point, definitely ostial lesions are not a contraindication for shockwave. It's the same experience to us. we do shockwave in osteal lesion. So that is a very important teaching point, because the duration of the inflation is not more than 10 seconds.
Yeah, and you can control it. So that's
yeah.
I think this patient yes. I'm Jorge Leguizamón. I think this patient has lesion, osteal lesion, but then left main lesion. I think it's important to see the ostium of left circumflex artery. I don't know at this moment. By angiography, maybe normally. What's your opinion about both ostium, LAD and left circumflex ostium?
Is there something under this head?
Talking about osteal circ.
Yeah.
Is the osteal circ with disease also, or is free of disease?
So we're going to show you the angio. If you need imaging, we'll do it after. But this is here. It's look good.
Yeah, looks clean.
Yeah, I'm sure there's disease, but it's not like an obstructive disease. So I think you can go and work easily on the LAD and try to avoid stenting the circumflex, osteal circumflex, because those cases come back again and again as restenosis.
So you can see the balloon coming out. I'm going to engage the guide because the guide is out. I can tell you by the blood pressure. So I'm trying to engage the guide better. And now we're trying to cross with the balloon.
So it has some difficulty. Maybe take a deep breath.
I'm going to engage the guide more, okay?
Yeah, Ron, I just took a deep breath. I don't know if that helps.
I can tell you it's not easy.
Ron,
I'm shaking it.
May I ask you something, Dr. Fernandez from Buenos Aires? What about
we can't do probably non-compliant. Can I have a 2.5? Give me a 2.5, 15 non-compliant balloon.
For OCT,
okay?
Yeah.
And the second one is in France, they're using, in cases like this, in moderate ventricular function, using levosimendan as a pharmacological support instead of mechanical.
I have the one.
So maybe I will answer you. The pharmacology support is very appealing.
Okay.
I think that the key issue is to start with the blood pressure over 120 systolic or map of.
Just engage your guide a little.
And then if you need for a short period of time to give norepi, Levophed, just to get you through the procedure, it's usually, and then you're going to continue with the pharmacology support after the procedure. So let's give you like the few minutes that you need enough blood pressure to carry the procedure. So we use it quite a lot, and it saves us a lot of money because otherwise you have to plug NPS devices.
Ron, as you saw, the balloon did not cross, even that we have 8 French, a very good support. So we're going to do 2.5 non-compliant balloon to open the space for the shockwave.
Yeah, and the other option is to use a smaller shockwave balloon. Did you consider that, or you don't think it's going to help?
So that's a good question. Is the profile much different on all the balloons? No, it actually is the same, Ron.
It's the same catheter, it's different balloon. I think most of the problem we're facing here is the lack of compliance and the nodularity of the calcium. There's an angulation that we're probably underestimating by angiogram.
And Giorgio said that he doesn't want to pay for 2 balloons, only 1. So.
We go by what the fellow says.
The big nodule that it's, that's where it's
protruding.
Yeah. Big nodule.
So,
yeah, it's a nodule that makes it difficult to cross.
I need to engage the guy before.
Yes, please.
This device is important, the possibility to use a second wire during the
you see the acoustic. So you can see the non-compliant balloon look expanded. There is big angulation, which
I'm not
better
sure
not
it's
for
completely expanded anyway.
Yeah, there's the nodule still there.
Right now.
So you can tell you that POBA was not alone is not a good choice for this case.
Yeah.
In many cases, you have to do combination devices like we call it atherectomy and lithotripsy, so that
Look at the pressure,
combination
120 now.
may require in some of those lesions. Like we had a case yesterday.
We're going up with
he had
litho.
high and followed by lithotripsy.
In what percentage of cases do you think that you would need to use the combination of the atherectomy devices?
Not many, but it does occur. I would say
Guide is
roughly
deep.
50%.
Yes, I leave it here.
I mean, what is your experience using combination devices?
Well, I mean, actually, we have all cases. I mean, again, our ideal experience is not much yet. We are about like 25 cases. One of the big reason in, at least in United States, using the atherectomy with the IVL, knowing that all are for the is the DRG. Because what happens with the IVL, if you do, the cost of the device and everything is not, we don't have the code yet. So all cases we are done, a majority with the rotational atherectomy, some with the orbital atherectomy combination. So all cases we had small burr, rotablation 1.5, and then followed by IVL. So what is basically taken away the second burr out.
And that's what you would have done in this case, you think?
Yes.
You know, sometimes if I take the circuit out, it will cross.
Yeah.
So it's not crossing, but sometimes the wire is entangled. But I'm not sure because the non-compliant balloon cross. But you see, my opinion, either if we take the circ wire, I can put it back, it will cross. You want to try it?
You think that's...
I think so. I'm taking out the circ wire.
It's not likely because you wouldn't have been able to cross with a balloon. So I don't think that's the issue.
No, but it's stuck in the guide. I'm telling you, it's the circ wire blocking me.
So
let me take it out.
But the balloon wouldn't have gone though.
If you put a body wire,
already tested the past.
We can, but my opinion, we take the circ wire out. I can put it back. It's easy.
Please raise the hands when the panel want to ask questions to the operators.
Perfect. Disengage. That's fine. You're enough?
Yeah, pass the Austin.
Okay, so true. So we took the IVUS, the circ wire out, and that helped getting the shock wave. Yeah, we're across.
Yeah.
Can I have the inflator, please?
Good point.
Maybe you can make the add some neck to the floor so we can see better.
Yes.
We are maximum one.
Okay.
I can see now.
So that's okay. We see now the hemodynamics that we can see also the.
Now it's interesting to see if the blood pressure will drop because we are occluding the left main and there is no RCA.
So the shockwave balloon also require 50-50 contrast solution and then also requires double negative. You don't want to have air in the balloon when you do this. So that's also very important to kind of notice because you have to remember that ultrasound enemy is air. It's better with fluid. So I'm going to go up now to 4. Flora?
Okay.
I'm going up on floor. You see my hands. I'm going to 4. And then... And I'm going to deploy now.
I think I'm missing a little bit
this
time.
I think you need to go further down.
I feel it
go further down. Okay. So we're going to go in a little bit more.
Now I'm better. I do want a little bit more. One more. Much better now.
Okay. I think we crossed the hostel of the LAD, and I'm going back up again.
I don't think so.
Now we are much better, no?
Yeah, this is 4. And you can see it's not expanding.
I think it's a bubble.
It's a bubble. I'll take it out. I'll double flush again.
You didn't apply the energy yet. Are you waiting until?
I did not. Yeah, no. I have. I'm just trying. We're positioning the balloon and
it seems like we have to advance a little more.
I can. The pressure went down from 150 to 120, but it's okay.
There we go.
But now we see the bend, which is good.
Okay. So now we're gonna do. So this is the handle, and then it has only one button right there. Here.
Just go ahead.
I'm just going to deploy.
And I'm going to see now. You see the intention on the balloon. We can start levo, please.
You might show the if you want to show the shockwave console.
Yeah, but you see the blood pressure either.
Yes. So the blood pressure dropped.
Yeah. So that is exactly the point I made. Particularly, we are not using leaving the balloon for.
Yeah, he's coming. He's recovering.
It recovered, but remember, this could be the potential of the trouble to start. So that is where I said that using combination may help.
That's us.
Or
it's okay. Let it just get some blood.
Let me take the guide out.
Yeah,
okay, we need to recover. I took everything out. The pressure is better when we take everything out.
We did one run. Okay.
Now it's inflated balloon. Hopefully it will cross again.
Are you able to see the pressures? Yeah.
Okay, we're going to cross again. You ready?
Yeah.
Yeah, let her recover a little bit. That's all.
Yeah, she felt it.
So this is what I suggest. I know that everybody is anxious to see this, but maybe we'll get to one talk and then you'll record everything and then you'll come back to us and then we'll continue the case after that. Is that okay?
1 second, I'm going to cross.
Yeah, I'm just.
We're going to cross again on with the second shockwave pulses. The good thing it's moving. It crossed. You can go up.
What's your guide? What's your guide?
Guide is out, but I'm okay. I can put it there.
Okay, this is 4 now.
Either is delivering the second
So Hyder,
pulses.
there you have air in the distal segment. So can we have a negative syringe? A 20 cc syringe? I'll just pull it down more for you. Yeah, I'll take it. Good.
Go ahead.
Blood pressure is still okay. I mean, just give her a infusion of levo. That will take.
She's on.
Okay, that's.
She's on, but we're going. Let's go up because we can do it 10 seconds only. You can go up. Check out the balloon. Yeah, but the guide is out, so it's the balloon causing it.
So we'll have a 4.
Yeah, just deliver the shock and
deploying
we
the
take
shock
it out.
now.
But it's more expanded, the balloon now.
It's definitely more expanded. You see it.
I can see it, you can see it. It's definitely much better.
And we're done.
Okay, let me take it out. Yeah, let me take it out.
Yeah, I will take the balloon out and then.
Yeah, we're doing it.
And I'm taking the guide out also.
So do you have to take it to 6 after you do the 4? Hyder? We did that in the trial.
We did that in the trial. I haven't been doing that in practice, to be honest with you.
So the 4, the 10 pulses, and then you're off.
We do more. We do
I think we're good.
I think
we're good. Do OCT now.
Well, you might want to take a look at it
So
first.
be careful.
Yeah, take this one.
She felt it.
So we're going to, you are still on or you left us? We're going to do imaging.
Yeah, we'll look at the imaging and after that
We do OCT. Either you can help us.
You want to take a picture here? Just
Okay.
to see
Small
what's going
puff.
on.
Please, I'm going to be the guide back. So let me take the 1 second, I know.
And the
We'll
hemodynamic.
give you a picture and OCT.
Hemodynamics is
all
perfect.
covered.
Either,
Yeah.
maybe we can get back the lever. Is small puff, either?
Yeah.
Yeah, we do picture now. You ready?
Yeah.
Wow, it looks good.
Like very good.
Much better. So you'll do an OCT and then.
The OCT now.
Okay, Ron, we'll turn it over to you and then we'll come back.
Perfect. Yeah, I think that was a very nice.
Looks incredible.
We're going to move to the first talk by Dr. Sharma, and he's going to from Mount Sinai. If there is one guy who is the most experienced in all the atherectomy devices and calcified lesions that I can imagine is Dr. Sharma, and he's going to talk about the different selection between primarily orbital to directional atherectomy in those cases. Dr. Sharma, if you can share your screen.
Oh, I didn't write it.
Are we muted then?
I'm not sure.
You're not muted. But
Okay, good. We just don't want to affect the broadcast.
you should be muted
Okay.
and we'll watch Dr. Sharma. If you can share the screen, Dr. Sharma.
Just 1 second. Let me.
We can
That's
start the OCT.
Okay.
Maybe we need to unshare the cat lab and then it will allow you to share.
Okay, share screen. Yeah, I think we're good.
It's coming, yeah.
You can see me. Okay, great. So this is exactly the all the advantage of the live cases. That is how we learn to see various technique, various ways to deal with the issues, and then take the message to your own practice. So what I'm going to do is next 15 minutes, I've been allotted to go through some of the data of basically of various atherectomy devices that how we are using in our practice. So basically, the some already has been discussed. The biggest thing which I say is the coronary calcification of the severe variety. Now you say why? Because we learned that mild, moderate calcium, we can take care of it. It's the severe which really gives the trouble. And that is very simple, dense radio opacities on both sides of the vessel wall. You don't need any fancy stuff. You see the tram track goes to the vessel. Of course, you do IVUS, which is 180 or 270 degrees. And then on OCT, more specific, gives you both length, depth, and of course, angle and arc of the calcium. So all those three techniques are there. And this is the score, OCT-based score, which we use and talk about the calcium angle, thickness, and length. And I'll talk about that a little later. There's only one paper actually which had looked into both angiography, OCT, and IVUS. Interesting that as you can see that some of the calcium spicule which can be detected by IVUS actually are missed by OCT. But anytime you have OCT positive, IVUS is almost positive all the time. So key is there is always this debate will continue. OCT better or IVUS better? I say from my point of view, IVUS better because we can easily understand what is happening to the calcium in these cases. Now we know the calcium gives the trouble. We cannot, cannot deliver the devices, don't open, expand, and of course cause the dissection, malposition, and all those are associated with short and long-term events. And we know the cases of rota regret that you try to do a balloon and many times you have created dissection and then you can't even do the atherectomy. But most of the time with a simple balloon, you can do a atherectomy without any problem and so. So calcium, which we spoke about, is the arc of calcium is directly or inversely proportional to the stent expansion. Longer the arc, lower the stent expansion, and say, well, I'll just do the balloon angioplasty. I'll go to high pressure. This is the old study with the bare metal, but taking a balloon to 12, 18, and 24 atmosphere, if you have severe calcium, your stent expansion is only in 71%. Now, taken all that, we know about 10% of our cases, between 8 to 12% of cases are severely calcified. But atherectomy actually now has gone in last few years, a little more in America, largely because of the atherectomy payment now, we have separate DRG code for it. And while rest of the world, the number is around 1 to 2% only. So key is about 5%, and that is about 60% rota, 40% orbital atherectomy and laser in 1 to 2%. And just to say, IVL has just come in the market and just approved, so we don't have the exact numbers of it. Now, this is just to say, we did the trial with Dr. Waxman, MACE study, took about 300 plus patients and see what is our practice in this day and age. This was a few years ago. And you see in the severely calcified, 1/3 are getting atherectomy. So still majority of the cases of severely calcific lesions in America being done with the non-atherectomy technique. Now, combining imaging and your plaque modification, particularly calcific lesion, and incorporating the LV support device, I put it in A-cube, assess by your imaging study. Now, I actually say that if there's the long calcific lesion angulated, don't do the imaging beforehand, and if we can see the tram track, because by advancing the catheter, one, they may not go, making even more trouble, rather lifting the plaque. So do the intervention, maybe atherectomy, and then you do the imaging if necessary, then alter the lesion, and then of course finally a position with a good stent expansion. The various devices which are available, we know with the non-balloon and balloon technology, laser, rotation atherectomy, orbital, and the IVL is the new kid on the block, all have their different principle, but in some is the high pressure non-compliant balloon dilatation. There is a balloon called Open NC, not available in United States. I'm sure maybe available in Brazil and Argentina and other places. India, definitely. Then we do the atherotomy by using Flextome, Wolverine, cutting balloon, angiosculpt, chocolate balloon. Then laser, rotation atherectomy, orbital, or shockwave for a severely calcific lesion. Although we use, some people do use laser for severely calcific, but it really doesn't work that much. So just quickly, rotation atherectomy working on the differential cutting principle with the diamond coated chips. And now we have the better Rota Pro system, which is concise, everything on the table, much easier to use. What has shown is that once you have a severely calcific lesion and don't use the atherectomy, rotation atherectomy, about 16% of cases, you have a trouble, 15 to 16%. Same was shown when they compare against the cutting balloon, that 16% of cases, if you don't use the rotation atherectomy in severely calcific lesion, is kind of give you trouble during the procedure. We also know, we call a rota regret, that particularly rotate registry, that if you don't start these cases as the atherectomy to begin with and use a bailout rota, they have a higher complication. So very important that once you have a severely calcific lesion, you plan your strategy beforehand. We wrote down with the various speakers, the cardiovascular intervention about various techniques of rotational atherectomy, kind of consensus, very complex subject, but came up with the overall how to do, how to set up for the rota, who should do it, what are the optimal rotational atherectomy technique. Then the second device, which is a little easier setup, is the orbital atherectomy, which is a 0.014, a 0.012 wire compared to 0.009 of the rotational atherectomy. It's easy setup, easy to start, and ablation is dependent on the speed. Higher the speed, it causes more 80,000, 120,000. It causes more ascending of the plaque. And they have shown in the orbital trial that overall good outcome, and but has shown also that lower TLR and TVR. So you see that orbital, any of the rotational atherectomy trial at 1 or 2 years, the TLR, TVR occurred in almost about 30-35% of cases. In orbital atherectomy trial is around 10%. Now these are the individual complications. So if you can see, dissection of course occur in some cases, perforation about 1.8%, slow flow extremely low. And that is the important difference, which I'll show you some comparative, that the slow flow occurs less because of small particulate debris, and it never closes the lesion because it's eccentric. So and rotating, so it never closes the lesion, so it causes less slow flow, although maybe slightly higher perforation rate. There is a major ongoing trial called ECLIPSE, which is going to give data that whether orbital atherectomy followed by stenting is better than your conventional angioplasty, rotational atherectomy not allowed in the trial, and see outcome at 1 year of the target vessel failure. This is the first of the atherectomy trial, which will show us whether the long-term MACE of 1+ year is better by using the orbital atherectomy. So if we sum up two of them, orbital atherectomy and rotational atherectomy, the basically, as you can see, the minor differences, but overall purpose is both are very effective technique and require additional learning. So compared to the IVL, which I'll talk briefly, that there is truly like no learning. You don't have a little learning curve compared to atherectomy techniques required. Ease of use, I have mentioned about the setup, and so although the Rota Pro setup is a little better now, then slow flow, no flow, I mentioned that clearly the lower incidence of no flow and slow flow with the orbital compared to rotational atherectomy, and these are actually from the orbital trial, the rotational atherectomy, and as you can see here, orbit is the OA, and rotational atherectomy, the perforation is slightly higher with the orbital, and of course slow flow is significantly lower with the orbital atherectomy trial. Now plaque modification, this one paper did show that by using orbital atherectomy, you have a better plaque modification and better lumen, even it's a 1.25 bar. And so we actually published our data of comparing orbital versus rotational atherectomy using OCT. And basically what we found is that orbital caused a more deep dissection, but by causing it, it has a better apposition of the stent struts. So malapposed struts were significantly lower with the orbital atherectomy, and of course the stent expansion was better with the orbital. We use only 80,000 RPM, not 120, because 120 is associated with some higher perforation. So we actually published our data of comparing rotational with the orbital atherectomy for 1 year data, and we basically found in nutshell what had been shown before, that dissection was slightly lower with the rotational, and more importantly, the perforation is lower with the rotational atherectomy in our group compared to orbital atherectomy. Rest of the complications, actually slow flow, was similar in our study. But what we found also, what I have shown, that lower TLR with the orbital atherectomy, of course, there was a higher death rate in the rotational atherectomy group, and largely because of the patient selection, there were more complex patients. Despite adjustment, we have a trend towards higher death rate with the orbital atherectomy, but there is no direct comparison trial going on at present to answer this question. But orbital atherectomy, despite a very small device, 1.25 at 80,000 or 120,000, can give you a lumen of up to 1.7 to 1.9 millimeter. This is the case actually we did for CRT for Dr. Waxman a few years ago. And this particular case, bad LV, about very significant left main disease. And you see that tram track calcium. So you don't need any imaging baseline, because once you have this kind of superficial calcium, right coronary has a stent in the past. So this is the orbital atherectomy. So large vessel, we can go with the 120. So we did 180, then 120, followed by balloon dilatation, and of course the stent or the mid LED. Then combine, we didn't have IVL that time. So this is the case, we'll use the IVL at present with the 4O. It's the 4O flextome, followed by a stent, and then post dilatation with the part of the proximal area, and use impella because of the LV dysfunction in this particular case, because severe LV dysfunction. So question always comes, if you have to choice rotational versus orbital, where would you use it? I think majority cases you can use any. But clearly in the aorto-ostial lesion and angulated lesion, the rotational atherectomy will be better. And of course, unexpanded stent. Second, orbital, ease of setup, hemodynamic instability, multiple lesions, one device will do the job. Then the laser, which basically works on various photothermal, chemical, and photomechanical, is available. And of course, it is given by catheter size, which are different. Small, you can sometimes go to the bigger one, 0.9 to 1.4, and go to an increased energy. And if you're doing a instant restenosis unexpanded, you do with a contrast, otherwise do the saline. And there has been a reasonable data, although used, as I mentioned, in less than 1% of cases. Then, of course, the new kid on the block, which everybody is very much excited with the shock wave, lithoplasty, creating a minor cracks into the calcific spicule by the shock wave. Just same principle they have for the renal stones. And so, and overall, you combine the disrupt CAD studies, the procedural success is quite good, very important and reassuring. And look at the bottom, dissection and perforation actually is nil. So device, of course, 50-60% time you have to pre-dilate before getting the device in, but perforation very low, so also the dissection. So just sum it up. So basically what we perform, what we are saying, that if you have severe calcium, go with the orbital rotational atherectomy in the large vessel, maybe go with IVL, or combine synergy. Synergy means a small burr followed by IVL. And of course, the low ejection fraction, use impella. If you have moderate calcium, you can decide whether you need to go with the atherectomy strategy or go with directly with the balloon non-atherectomy strategy. IVUS OCT will definitely help. And of course, we also know that where strategy failure, you can always, the atherectomy cases can be converted into if atherectomy for some reason don't want to use it or does not go, you can always try the non-atherectomy or non-atherectomy cases, you use the rotational atherectomy. So just to sum up now, how do we do it? How do we selection? Angiographic, you get mild to moderate. I think good. Non-atherectomy, use a non-compliant balloon, scoring or cutting balloon. If failure, then you go to your atherectomy strategy. If moderate to severe calcium, whether you want to do IVUS or OCT, your choice. I know a lot of people do it quite a bit, but we learn that once you have a calcium arc of more than 180, thickness more than 0.5, length of more than 5 millimeter, those are troublesome cases. So those cases should have atherectomy. Now, the end could have IVL. So there, if there's a calcific nodule, that's where the IVL would not work and atherectomy will be better. And many times I am saying that synergy, device synergy, whether it's a laser, orbital, rotational atherectomy is the way to go. So just to sum up, if you have deep calcium, use a non-compliant balloon, scoring and cutting balloon. If you have superficial calcium, then use any rotational, orbital, laser, lithotripsy, large vessel. I think the lithotripsy IVL will be the way to go. But if you have nodular calcium, we learned that the IVL will not work in this situation, and you probably perform rotational atherectomy. Orbital is very good if there is a totally circular calcium, because otherwise it does cause some deep dissection. With that note, I'm going to stop here. This is actually my last slide to show at Mount Sinai of the about 320, 350 coronary cases we do. Atherectomy is used in about 22% of cases. 80% is rotational atherectomy, and about some orbital and laser atherectomy as shown here. We have the calcific aid app, and of course the monthly webcast, which a lot of people watch, and really thank everyone for it. And I'll end up here exactly in 15 minutes. Thank you.
Thank you, thank you, Dr. Sharma. Very comprehensive review on all the options. I'm going to take you immediately to the cath lab just to see where are they standing, and then I'm going to ask Dr. Rodriguez if we have another at least 10 more minutes to give Dr. Garcia to talk about imaging of calcified lesions. So maybe I'll go quickly to the cath lab.
Hi, Ron. Thank you. We'll show you quickly what we did. So when you left us, you remember we did the shock wave, and we did 2 pulses. It didn't cross, so we need to do non-compliant balloon, and then we were able to cross with the shock wave. After the shock wave, we did an OCT run. And either can you show them the OCT run after the shock wave?
So I'm just going to stop it at a frame to highlight what shockwave effect is on calcium. If you guys remember the calcium, we measured the nodule, the thick nodule on the exact same spot. If you pay attention to this exact where my magnifying glass is, this is a crack in calcium, and that's what the shockwave did. So it did not move the calcium anywhere. There's no debris going down, but it's almost like a tectonic plate shift. It's almost like the continent separating in the ice age. This is exactly what's happening. We separated this from this with a crack, and this will allow better expansion when we put a stent.
So we felt comfortable.
Yes. I'm sorry. Yes, here we go.
Here, that's what I want to see. That's exactly.
Yeah, this is the crack. Yeah, I kind of stopped it on this frame. Obviously, the crack is in different frames, but this is probably the spot where you want to see it.
So after the OCT, we felt comfortable on to go with the stent. We took a 3.0 by 15 drug-eluting stent. It was crossing fine. You remember the balloon didn't cross, but the stent crossed fine after the shock wave. And we were positioning in the stent. We went high pressure. And then we did post-dilatation to the left main with 375.
We don't see the angio. Show us the
angio. You cannot see the angio?
Here the angio. This is the pot. This is the
stent going up. And this is the dilatation of the left main with 375. And we decided to do IVUS in the end. Either can you tell why we decided IVUS and not OCT?
So to answer some of the questions about OCT versus IVUS, we still have some limitation with osteal disease. We were thinking that the left main might have something osteally. For that reason, I decided to go with IVUS. Have I done osteal with OCT? Yes, if you put a guide extension in. But in this circumstance, we elected just to go with IVUS. So I'm going to show you the IVUS now. Can we show the IVUS out, please? So this is a combination of two imaging modalities. We kind of applied what we wanted to apply in this case. This is the tightest area where this is exactly at the bend, and I'm getting an MSA of 7.37 squared millimeter. And I'm going to take you back to where the proximal edge of the stent is, into the left main.
I'm doing last picture.
Right there. So this stent is in the aneurysmal portion of the left main. And then here we go, we're coming out, and this is the left main now. So I measured the left main minimum luminal area. I'm getting 7.13. So I think we're done here with this. We have a good deployment of the stent. You can see the angiogram. Can we show the angiogram now?
I just did the picture now.
We don't want to take more time of Dr. Garcia's presentation.
IVUS looks good. Angio looks good.
And patient hemodynamically stable with a little bit.
She's right.
No levo right now, right? No.
No, she's off levo. No, we're done. Levo, we use levo only for the inflation time.
Yeah, that was exactly my point. We don't necessarily have to put mechanical support. You can do a transition support pharmacology, and you get through those cases. You need it only for a few more minutes. Dr. Rodriguez, can we take 10 minutes to get Dr. Garcia to give the talk? I'll pass my talk, but I want him to give he has a very good imaging talk.
Well, she has a loop.
Okay.
I forgot.
You want Supercore?
No, she has a big loop. I forgot.
Okay. Dr. Garcia will give us the talk of imaging.
Thank you, Ron. Thank you. It's my pleasure, Alfredo, to be with you here in SOLACI-CACI. I actually deleted some of the slides just not to be redundant and repetitive with respect to the previous talk. We know 1 out of 5 patients have these lesions, and this is our study. That's why I decided to keep the slide. It's just published last week. So we compare OCT with angio, and you can see here that actually OCT is detecting 69 out of the 75 lesions have calcium, and angio only detected 30. So less than half, which is 43% of the lesions by angio are detected with calcium when OCT detects important calcification. So the issue then becomes which imaging modality should we use to characterize with these limitations of invasive angiography. What we have readily available, as we've been discussing, is IVUS and OCT. In this slide, we compare, or the publication compare OCT IVUS against histology. You can see the sensitivity and specificities are about the same. So we could conclude they are doing the same tricks in terms of detection of calcium. These are the definitions by the consensus of OCT. Calcium on OCT appears as these signal poor heterogeneous regions with sharply delineated border, while the IVUS consensus tell us that the IVUS shows calcium as bright echoes with this acoustic shadowing. And that's what you need to remember when you're looking at these cases by OCT or by IVUS. So let us discuss head-to-head the merits of OCT versus IVUS. We've been discussing, and Haider mentioned it, OCT gives us the full extension of calcium, the area, the thickness, the arc of calcium, while IVUS only tell us the arc of calcium, but never the deep or the thickness of the calcium. One thing we all have to consider, because we seem to forget that there are different types of calcified plaques. Not all calcified plaques are the same. So in this report of 2020, we have here a nice histology coronary study showing sheath calcification. This is how it looks on a CT, micro CT in this case. So these are the typical lesions that would be treated in coronary artery disease, somewhat less frequent, but still there is this nodular calcification. And of course, we have different considerations for treating this. And this is how it looks on the micro CT. And finally, these bulky late fibroatheromas that have a mix of necrotic core and calcium, they would have mostly calcium in the depth of the plaques, but sometimes also superficial plaques. So consider the fact that there are different types of calcified plaques, and maybe we should not put all in one basket. Let me go back to the discussion of the imaging. And we have discussed IVUS versus OCT merits. Another point I want you to all consider is that when you are using IVUS for the characterization of calcium, you have to think of the technology that you are using. At the top, I'm showing two images acquired with a 40 megahertz IVUS catheter. At the bottom, the same patient was imaging at the same procedure with a 20 megahertz catheter in the same coronary spot. You can see here that the arc of calcium by the 40 megahertz catheter tells you that half of the circumference is containing calcium. Well, by the 20 megahertz catheter, you may get the impression that the calcification is somewhat less and is only limited to this quadrant of the coronary artery. So those are the things that we have to keep in mind. And so for the reasons I mentioned here regarding the distribution, the thickness, the area of calcium that OCT characterizes very clearly, and by the limitations that we have on the IVUS, and I'm showing you here as well other issues with IVUS on the right, I would have slightly preference for using OCT in calcified procedures. And from here onwards, my presentation focuses on OCT imaging for calcified lesions. And one important thing to consider, despite that OCT looks perfect to everyone, and even our technicians, fellow colleagues are able to interpret those OCT images, we are humans and we are limited. I asked this morning my 9-year-old boy, how many legs do you see in this elephant? And he said 6. And I said, you are correct, because I don't know how many I see too many. And we're limited. And that's the reason why IVUS is very inefficient in the cath lab, and OCT is becoming the tool to use, because these solutions, this Ultron software, characterize the presence of calcium in terms of its arc. Automatically, once you are done with the acquisition of OCT, it will tell you in every single slide, you can see at the bottom here, where there is calcium, they can tell you the extension of the arc of the calcium and the thickness of that calcification. This is not the only solution. So we have this other software, the OCT Plus software, which not only tells you about the presence of calcium, but also the other fibrous and lipid tissue types automatically, also in few seconds after the run of the OCT is completed. So having said that, we all have to remind, and we have talked little about this, that's why I kept this slide, that the calcification has consequences for the devices that we're using. So we are peeling off those coatings, and that increases the TLR rate. And more importantly, we've been discussing how these calcified lesions end up being with a stent under expansion, malapposition. We have an increased number of complications that we need to prevent if possible, and eventually that would help us to reduce the increased rate of stent thrombosis that we see in these patients. This slide was shown before, but it gives a nice preamble to my next slide. That's why I kept it. So you need to remember that the stent expansion 100% is perfect, and that's what we all have to aim for. And we see that there is an inverse correlation with the degree of arc of calcium on this axis, and you need to therefore break this calcium, break these arcs to make it smaller and to achieve a higher stent expansion rate. We have discussed this just for everyone to remember. This scoring system based on OCT for me is the 5s. So 50% or more of the circumference, you get 2 points, 0.5 or more of the thickness, you get 1 point, and a length of more than 5 millimeters, you get 1 point. And we have seen this has implications for the procedural success of the stenting, and therefore we have to keep that in mind. So there are many algorithms, and Dr. Sharma presented two, and there are many more, and the literature is plugged with all these. And so I had to make my homework and pick the one that would be the simpler, the easier to adopt, but also to remember. And I thought that Carlo Di Mario did a good job putting together this algorithm. So when you have mild calcification, you attempt to do your predilation. If it works, you don't have suboptimal balloon expansion, then you proceed with the stenting. If it doesn't work, then you may be going into here with the lithotripsy as the option after this balloon predilation. But we're not interested about mild calcifications, because the real issue comes when dealing with moderate to severe calcification. So let's focus on this. So the scoring system we reviewed in the previous slide is going to guide us through the procedure. So if you have 1 to 2 points, so there is calcification, but it's not so critical. So you may attempt to do just plain balloon calcification. And I want to remind everyone in the audience, the pre-calc study shows in the comparison of rotational versus just balloon, scoring balloon or other devices alike, achieve 80% success rate. So rotational and just scoring balloons achieve the same 80% rate of expansion, and they are comparable. So we only really need to take care of that 20% that does not respond to those devices. And that therefore we have these other solutions. So if we don't get a good result, we proceed with lithotripsy. And if this doesn't work, of course, you always have the alternative to go into rotational and orbital. So if you have a higher scoring point, 3 to 5, you go straight to lithotripsy. You may skip these other devices, and if it doesn't work, then your solution may become rotational or orbital. Of course, here on the right-hand side, we have those situations, and it was about to be the case in our particular live case, that the lesion was uncrossable. You may go straight with these solutions, and eventually the combination of those, as Dr. Sharma was proposing. So with that, I'd just like to show this last example, very close to what we have seen. This is severe calcification, more than 50% of the circumference, more than 0.5. You see the cracks induced by the lithotripsy. You see how nice the stent is expanded and apposed, as showing here at the bottom of the slide. So in conclusion, we all have to remember calcium, particularly moderate to severe, affect the success of PCI. We have to think of doing a precise and accurate calcium detection, which would be informing our clinical decisions. I would say OCT is much better than angiography, but it would be similar to that of IBUS for the detection, but not for the full characterization of IBUS. And I would think that OCT image interpretation with these new softwares, Ultron and OCT Plus, is easier, is faster, is automatic, and it correlates with procedure outcomes. And with that, I'd like to thank you all.
Thank you, Hector. Can I make a comment, Ron?
Absolutely.
Yeah, if I understood you, Hector, in your algorithm, if you, and in the presence of moderate and severe calcification, you go first with IVL and only go to orbital atherectomy and rotablation only if you fail it with IVL. Is that right?
Yeah, so in the moderate to severe calcification, if your scoring based on OCT is 1 to 2, so very low scoring, you may go first with non-compliant balloons and scoring balloons. Again, in the pre-calc study, the scoring balloon compared to rotational atherectomy in the OCT sub-study, they achieve the same stent expansion. So you don't need to be expensive from the get-go. Try the other solutions you have at hand, which is non-compliant balloon, scoring balloon, based on data. This is not based on anecdotal cases. So once you have moderate to severe with high scoring, you may want to go to lithotripsy because then the calcification is really heavy and you may not be able to modify it as much. So the algorithm says go straight to lithotripsy. And really the rotational and the orbital become the alternative for that 20% of the patients that are not going to be successful with the non-compliant scoring or the lithotripsy balloon. So I think in this algorithm, they are becoming kind of the bailout technologies.
But one thing we have to remember that the cost of the lithotripsy is very expensive. So many of us actually not following that algorithm. We will try maybe first rotational or orbital. If it works, great. You save $4,700. If it doesn't work, you go with the IVL. So that's called rotatripsy or orbitatripsy. We have all those combinations. I think those algorithms are flux. And there's a lot of considerations. Sometimes these are economic considerations. Yeah. But what we showed you today is that this is a very tough case, the one that we showed you, because it was ostial, it was left main, it was done without support, it was uncrossable lesion in the first place, and yet we was able to do it with predilatation, lithotripsy, getting a very good result, overcoming the challenges of support. And the tripsy did the job without showing so much except for this very large crack that this can be done. And I know I'm not going to have time to give my talk, but my final slide was why this is a game changer. Because it's safe. That's, I think, the biggest thing. You don't have perforations with lithotripsy. You don't have dissections. You don't have distal embolization. This is a feature that gives you much more confidence. It does the job as well. And we saw it in the CAD trial. We saw it in other trials. And we see it day to day, like the case of today. So you have an effective therapy, maybe the same effectiveness as you see with the other devices, but the safety profile gives us that ease of use that cannot be beat the other atherectomy devices. And that's, I think, why I call it a game changer. So with that, Alfredo, we are available to any time and more talks. But I think our time is up, and I want to respect your time and to thank everybody for including us. Our CRT 2022 would be in-person meeting. We project that there will be past the pandemic. It's February 26th, for God's sake. You should all come and celebrate with us 25 years of CRT and get off the pandemic.
Thank you.
Juan Pablo has a question, right?
Yes, can I have a little question, please? Regarding when you want to post-dilate a recently implanted stent, a drug-eluting stent, there is some data that shows that the lithotripsy can cause disruption of the polymer. So there is some data that told us that we want to apply less than 20 pulses. What's your opinion about that?
So I'll take it. This is off-label use in the US, and the company doesn't promote it. But as a matter of fact, this is the only device that works when you have an unexpanded stent. Yeah. So I accept that there is a polymer changes, but you know, you have restenotic tissue already. So who cares about the polymer? You really need to get expansion, and you don't do it with rotational much. You don't do it with orbital at all. And laser, it's also, it is maybe on the labeling, but the way that we do it with contrast is also off-label. So again, sometimes you have to do off-label. Off-label doesn't mean that you're not allowed to do it. You have to do whatever is good for the patient. And we have seen many cases that this is the only device that helps when you have an underexpanded stent. So again, it is off-label. Probably it's not going to be on the labeling, but you should know that this is a tool that works. And so far, we have not seen any reports of any adverse events related to that. And I'll let Dr. Sharma to corroborate or contrast what I just said.
No, but very good point. I think his question was a little different also. He wanted acute. So you put a stent and you didn't prepare the lesion well, and now you put a stent. Now we know laser, rotational, all will be bad. They won't work. I think that case, again, as Dr. Waxman pointed out, so my company has the data that IVL definitely caused disruption of the polymer and the drug. So therefore, in that particular case, if we require that multiple pulses were done, freshly implanted stent, maybe you have to think about, we don't have a drug-coated balloon, but at least maybe in short area, put another drug-coated stent inside there. But chronic, long-term, when patient come back with an unexpanded stent at the future, that's where the other techniques, rotational or laser, actually, laser is the one everybody uses first with the contrast sometimes. And the rotational, we have published that, orbital also rarely. There, we actually have done cases now. A few cases, we did a rotational atherectomy, 1.75 bar, unexpanded stent still didn't open. Then we did IVL 3.5, it opened up. So I think combination in the unexpanded stent in the future, yes, but at that time, many of those cases we are restenting anyway. So that is perfectly fine at that time. Acutely is the big issue when you have, so basically is that why that happened? Because we didn't take care of the lesion to begin with. So if you would have used IVL before, you probably would not need it past post.
And no imaging, yeah. You didn't do imaging in the first place.
Yeah.
Any comments?
Commentary.
Panelists?
Yes.
What about
Yes, please. Raise the hand. Raise the hand. Okay, Dr. Leguizamo.
I'd like to go to one comment about trifurcation. Trifurcation of unprotected left main. When before trifurcation is 1-1-1-4-1.
Yeah.
Is really a situation and challenging situation for us. What is the potential of really application with IVL in this particular obstruction?
Yeah, so question is with the trifurcation once you have, is the calcific.
Yeah.
Yeah. So
Trifurcation.
Yeah, trifurcation
of left main.
Yeah, and the left main. So key is one, preparing the lesion. So one of the advantage of the IVL is that you can leave the wires in the side branches. So that's good. You can leave it actually in the laser also, and we know with the cutting balloon you can leave, but orbital, rotational, you cannot leave the side wire. Second, after you have prepared the lesion, of course, the same balloon you can use to the 2 or 3 branches. But I always say, and we have done few of our CC's live cases, consider trifurcation as a bifurcation. You decide what one vessel you could sacrifice. Sacrifice basically means we don't want to close it, but you are okay. Come with a suboptimal result. As long as it has a blood flow, not completely closed, and you take care of the 2 major vessels, whether you use a DK crush or mini crush and so. But yes, preparatory point of view in a calcific lesion using IVL with a trifurcation is completely fine. The areas which are diseased, but very likely you'll have to pre-dilate just like done today before getting the IVL there. But in final stent procedure, it should be considered as a bifurcation, thinking that once you start working with a 3, there are data Colombo published almost 15 years ago, when put a 3 balloon, 3 stents, use a 9 to 10 French guide, 35% event rate. So clearly say, after adequate preparation, can make your trifurcation to bifurcation and come up with a great results.
That's great. That's great.
Intermediate branch is too big, it's too long. The approach is the same.
Yes. Yeah, I mean, that's usually the trifurcation will be. You know, when the ramus is very big, main circ is moderate size. It's so rare. I haven't seen, I mean, either circ is very big, let's say circ is 3.5, ramus will be 2.5. If the ramus is 3.5, invariably your circ will be 2.5 only. So that is what those trifurcation LED always is a 3+. So key is that there you, based on the size of the vessel, area it supplies, you decide you want to keep the circ or you want to keep the ramus along with the LED.
Okay. Another comment from Dr. Fernandez Pereira, Patricia, Dr. Yes.
I would like to ask to
Only 1 minute.
Hector Garcia to if he know if he use right now Dextran as a instead of construct media to see on OCT on those cases that we have many patients that we cannot go with the contrast media like chronic kidney disease.
Yes.
Or other media to see with the OCT. What is his experience?
Yes.
Thank
I
you.
don't know if you can hear me, but my answer is yes. Can you hear me?
Yes, I can hear you.
I hear very well.
You can do it also with saline. So
with saline, with half and half, with Dextran, anything is good other than contrast media. Yes, you can try it. The quality is very close.
It's still good.
It's just the calibration of the system that you have to change in the console, that you are switching to other than contrast media, but the image quality would be very comparable.
A short comment, Alfredo.
Patricia first.
Thank you.
Patricia, she is raising the hands. Yeah.
In this ROP 3, you had 6.8 pre-procedural myocardial infarction. Are you concerned about this? What are the reasons and what is the prognosis of these patients?
Yes, so very good point. So remember 6.7 is still low because all the orbital trial, rotational, they all non-QA was almost 10%. So this is part and partial of doing the calcific lesion. So it comes out with a non-QA of up to 10%, I think completely fine. But also the question comes, does it translate into a long-term adverse outcome? An answer based on the orbital trial said no, because a small amount of this is a part getting your lesion better, and it will even translate into a better lumen and lower long-term outcome, better outcome. So a little bit of non-QMI at the time of intervention, up to 10%. Most of the studies have shown no, and 6.7 actually is much better than our atherectomy trial.
It is the lowest rate of procedure.
Yeah.
Yes.
Yes, depends.
Short comment.
Also, the definition of myocardial infarction, no?
Yeah, and it's a non-Q during the peri-procedure. You really have to be high to have an impact on the long.
Yeah. I fully agree with you. Yes. Jorge, your last comment?
My last comment is instant restenosis. We have experience with rotablation, but since 1991. Since that moment at nowadays, the most relevant complication is bar attrapment. Bar attrapment into the stent, especially in calcified and recurrent obstruction. This is a situation that I think may be treated with IVL with success. What is your opinion, Seni?
Yeah, so just to answer the question of the bar, bar entrapment is a real. So in our circulation paper, they wanted us to write a full paragraph that what are the cases where the bar entrapment occurs and what you do. So clearly it's all technique related. Now many of these angulated cases, the IVL may or may not go. But question is, let's talk about the bar entrapment. It always occurs in the unexpanded stent. Your bar has gone and now cannot come back. So same, a small bar, gradual advancement will prevent it. But if it happens, we actually have a case in of 2018 August in the CCC live. We have the whole live case. The bar got stuck and could not bring it out. And what basically is then in those cases, you cut the rotablation, the bar, and you pull back the Teflon sheath, and then you can advance your guide liner up to the level, and then you pull, and then it comes out. Clearly, we don't want to have that situation. And whether those cases could, IVL could be done, if it could be done, that's a great thing. But many of the in-stent restenosis cases, we have been using particularly long lesions. IVL may not be useful for multiple long lesions, because then you are talking about 2 or 3 stents. I mean, the IVL runs or balloons to be used, and rotablation helps us that way. But burr entrapment could happen, and we have the nice description of about this technique. But more important is that using a small burr, slow advancement, and if it happens, just cut the burr, advance the guide liner, and then pull it. 99% time it will happen, it will be able to come out, and the patient doesn't need to go for surgery.
Yeah, but one thing that is important is to do imaging for every in-stent restenosis, because if you do see that this is an underexpanded stent, I would never use rotational atherectomy or on those cases. And IVL, again, although it is off-label, this probably would be the best device for underexpanded stent. But you need to know it when you have imaging. Even brachytherapy not going to help if you have an underexpanded stent. And we've seen that. So I think it's a combination therapy. You may do IVL, and following that, you do drug-coated balloon, or put even another stent if you have a large lumen. But don't use rotational atherectomy on underexpanded stent.
Okay. Ron, we are on time. Can you give your final words?
Yeah, so my final words is that this has been an honor for us, the CRT team, plus Dr. Sharma, who I consider to be part of our team, even though he's from Mount Sinai, to give you a very nice review of how to treat calcified lesions. This is really remaining a challenge, and we underestimate what we can do for calcified lesions to optimize the results. So if we know how to use the tools, including imaging and all the atherectomy devices, and now the IVL, we're going to get much, much better results, less restenosis, and more durability of the outcome. So I do thank you, Dr. Rodriguez, and the team of SOLACI to allow us to participate in this prestige meeting. And I do hope to see all of you at CRT 2022, February 26. It's going to be no pandemic, in-person meeting only. That's what we're going to do, in-person meeting only. See how much optimistic, and I'm in Washington, so I'm close to Biden, and we know something that he doesn't know. Anyway, thank you very much.
Okay,
bye-bye. Thank you very much. I mean, Ron, Hector, people in
Good afternoon, everyone. First of all, in this wonderful Congress, second day of SOLACI-CACI 2021, here we'll be dealing with structural and fortunately we've been able to come to share a lot of conclusions and ideas. Today we'll have several presentations on different issues that will focus on the specialty and daily routine practice. Alfredo Matías Rodríguez Granillo, Carlos Giuliani, Juan Scaglia from Los Arcos Hospital, José Amadeo Álvarez from Almeda Alemán Hospital, and Carlos Miguel Fava. The talks are recorded, and we'll have some time for questions and answers after each talk. Let's begin so we can finish on time with Dr. Carlos Miguel Fava. Good afternoon, everyone. My name is Carlos Giuliani, part of the cardiologist interventionalist cardiology. I will discuss the efficacy and safety of aortic percutaneous valve implantation with a cups overlap technique. My disclosures. We know that alterations in conduction disturbances that require pacemakers and PPM is a frequent complication in the development of new techniques and regarding implantation. With this data, this complication is less and less frequent. With a high implantation with cuffs overlap techniques, this was developed in order to decrease this complication. The objective was, the purpose of the study is to evaluate whether this cusp overlap technique is useful to reduce the rate of pacemaker requirement rate in patients subjected to TAVR with self-expandable valves. To do this, we analyzed a group of patients between 2017 and 2019 in 2 centers where both techniques were performed, standard coplanar techniques and the cups overlap techniques were performed. A stratified analysis was performed regarding pacemakers post-implantation, CT scan, and the implant position. All of the procedures were performed by the same group of operators with experience who performed a descriptive and comparative analysis using EpiInfo 2000. Baseline characteristics of our patients, we can see that both groups were similar, quite homogeneous. With the cups overlap technique, 15 patients, and with the coplanar technique, 50 patients. Mainly in the coplanar technique, mainly male, as opposed to cusp overlap. Average age in both groups between 79 and 80 years old, with a high intermediate risk, without significant differences. History of previous pacemaker in 6.6% in cusp overlap technique and 6% in coplanar technique, conventional technique. And we had 0% of patients with a blockage of right branch compared to the conventional technique, and the left branch 6.6% with 20% both non-significant. The procedures were performed 100% of the cases in both groups transfemorally with pseudoanalgesics predominantly in both groups, as opposed to the conventional technique, 26% general anesthesia was used. The results, we had a technical success with both techniques 100%, and in the conventional technique group, there was 1 death after 30 days compared with the over-cusp technique without significant differences, and we had a greater leak, moderate and severe with the conventional technique compared with the cusp overlap technique, and we did not observe hospital mortality or stroke or vascular complications. As regards conduction disturbances, results were excellent comparing the conventional technique and prior to removing previous pacemakers. 41 patients with a conventional technique presented with a rate of pacemaker requirement of 25% compared with the new cusp overlap technique, which was 0%. we had left branch blockage, and compared with the conventional technique, 17% significant, and a left 7% left blockage, and 0% in the conventional technique. Combining endpoints, we obtained 7% with the overlap cusp technique, with a P completely significant. Conclusions, we could say that using cusp overlap technique for device implantation in TAVR with self-expandable valves, repositionable, achieved a high success rate with low pacemaker rates, being a very safe technique. We need a larger number of patients for better validation of data, and also to be able to extrapolate possible benefits of this technique for future TAVR implantations. Thank you. Very nice presentation. Do you think that these are consecutive patients? And what about the learning curve that had to do with the previous patients? If there is an incidence factor, we could actually measure the real effectiveness of the technique and also the operator's skills. Good afternoon, everyone. This was an initial experience with 15 patients that in 2019, 2020. Currently, we have over 50 patients with this technique, and we believe that this technique requires operator experience, but it is very reproducible technique. And with the initial experience, what we noticed is that the pacemaker rate was significant. Now with this 50 patients we have, and previously we had 15, we have over 50, 5.8% of pacemaker rate, and we were able to extrapolate together with Favoloda Foundation, and we were able to extrapolate similar results, and operators' experience is essential, and I believe that this technique is absolutely reproducible. Any questions from the panel? Good afternoon. Congratulations on your presentation first. My question, one of the advantages of this technique is a high implant as much as possible, and this is related with the non-coronary sinus and the membrane sector. So in this case, you did not measure the post-implant assessment. You did not measure the depth of the valves, because this is related with the risk of pacemaker. I mean, just to certify the conclusions that you draw, because it's a high implant, 3-4 millimeters high. This, I mean, we performed CT assessments, but with the previous patients, we did not have any measurements. And there are other papers in the literature, other studies that compare this depth and distance, but we did not consider that at that time. Now, prospectively, we are randomizing patients, and based on this, to be able to compare both techniques. Dr. Bacara, question? Go ahead. The criteria for pacemaker indication a year ago in JAC, the TAVR pacemaker indications were published where not only interventionists but physiologists, the curve, it was quite loose. I mean, to quite a unnecessary fears, basically. Probably now you begin to use the cusp overlap technique with these new recommendations. The fact of using recommendations, the pacemaker indication drops. Do you think that could have affected the figures somehow? Absolutely. At the beginning, I think that we just placed the pacemaker more on a preventive basis, but then the patients did, I mean, they were temporary conduction disturbances, but pacemaker, I mean, we implanted pre and post, and I mean, we consider that in order to come up with a pre-selection, and after the implantation of the prostheses, we assess whether these conduction disturbances, in the case of the left branch complication, then we assess the duration, and if this surpasses 160 milliseconds, generally we wait for 48 hours, and then if it persists, then a pacemaker is implanted. In these patients that we treated, and in order to have a more homogeneous groups, we excluded these previous patients when we used, I mean, initially where valves with implantations were deeper and these pacemakers were implanted. We excluded these patients. That's why 2019, and we also, I mean, we included the patients with a new overcusp technique to avoid bias in these kinds of patients, these groups of patients. Thank you. Second presentation, Dr. Rodriguez Granillo. My name is Matias Rodriguez Canillo, and I will talk about incidence of infectious endocarditis long-term after a percutaneous implantation of prosthetic aortic valve. No conflicts of interest. We know that for a long time now, the surgical aortic valve replacement are considered high risk for patients who have infectious endocarditis, but we don't have much evidence on infectious endocarditis. Particularly in the long term, the information we have is limited. We have report cases and registries. So we don't have information on our region. The objective of the registry is to know the long-term incidence of IE, the microbiological profile and clinical results in order to improve strategies for management. When we designed this study, we began in December 2009, March 2020. Three Argentine centers were involved, 122 patients, conversations with the chief doctor, the physician. The long-term results, these are the baseline characteristics and procedure, 102 patients, 82 years of age, half of them male, the year score 13.5 on average. At the start of TAVR, patients had prohibitive or high risk for conventional surgery. Self-expandable valves were used in 54% of the cases. The femoral approach and patients, 5.4% had a previous pacemaker, and the average hospitalization time 5.4 days.
Infecciosa, de las cuales uno de los pacientes tuvo endocarditis temprana y 2 pacientes tardía. El microorganismo aislado más comúnmente fue el estafilococo epidermidis y el enterococo facalis en el otro caso. De la resolución fue por tratamiento antibiótico en el 100% de las casos recibieron el tratamiento antibiótico. Un paciente requirió reemplazo valvular y hubo un paciente que ovitó, que no fue el paciente que se reemplazó la válvula, que fue exitoso en este caso. La conclusión de nuestro registro es que la incidencia de endocarditis endocarditis infecciosa protésica en nuestra población es baja, similar a los reportes presentados en otros países. La estrategia de profilaxis y tratamiento deben dirigirse a gérmenes habituales para endocarditis en nuestro medio. Como discusión de este registro, es interesante evaluar la incidencia similar a los registros internacionales de 5.8 a 5 años de seguimiento, 0.7 a 3.4% por año, o 0.3 a 3.4% por año. Nosotros tenemos 2% aproximadamente. Los métodos diagnósticos sería interesante hacer una evaluación un poco más en profundidad de este grupo de pacientes, ya que se reconoce que el PET y la tomografía no está correctamente evaluado en estos pacientes y que el 32% de los pacientes tienen ET negativo, no se evidencia la válvula ni la presencia de los gérmenes habituales, según el EIRA 3, que es un registro argentino de endocarditis, mostró que los gérmenes son los habituales, el enterococo y el estafilococo los más habituales en las válvulas protésicas. Disculpen, y que esto hay que tener en cuenta que son procedimientos híbridos en laboratorios de cateterismo cardíaco que difieren del quirófano convencional. La preparación, el tratamiento y el seguimiento de este grupo de pacientes es pacientes similares a los coronarios, ¿sí? No pensemos que son pacientes que reciben muchas veces disección de arterias importantes, que no se utiliza angiosil en nuestro medio, o por lo menos muy escasamente debido a los altos costos. La profilaxis antibiótica no está claramente estipulada, sobre todo al principio de este registro, la profilaxis antibiótica no estaba claramente indicada. El riesgo propio de los pacientes al tener Euroscore alto son pacientes con altas comorbilidades que fueron mejorando a lo largo del tiempo, y que en este grupo de pacientes no se remueve la válvula antigua como en la cirugía convencional, y además hay lesión macro y microscópica del endotelio nativo adyacente a la válvula, que provoca una predisposición a tener territorio fértil para que se depositen los gérmenes. Muchísimas gracias por su atención.
Bueno, muy bien la presentación. Vamos a averiguar algunas preguntas ahora, ya que tenemos tiempo. Pablo Lamena.
Sí, gracias, Jorge. Bueno, Matías, gracias por la presentación. Muy buena. Quiero hacerte una pregunta relacionada a algo que mencionaste, pero me gustaría que expandas un poco, que tiene que ver con el acceso percutáneo versus quirúrgico, porque los gérmenes que mencionaste pueden estar relacionados a la...
Germs could be, the Staphylococcus and the Streptococcus could be associated. And I remember one case of myocarditis. In this case, there was no percutaneous. Or were you able to compare and analyze it in a comparative way? And if not, would you have been able to do it? And is there anything in the library in the literature? Yes, that analysis would be interesting. What we saw was that there were no differences regarding the access type, whether it was percutaneous or surgical. There are only a few patients, and even though there are only 3, that's all the population that we have in a consecutive record. It would be interesting to do it perhaps with a larger population. There we would have more data. And regarding evidence, I found nothing. Okay, thank you, Matias. One quick question regarding what Pablo said. Matias, the germs that you most have were Staphylos, And it's comparable with what happens with the surgical valves. If you look at the trials, the most common genes in TAVI, for instance, endocarditis in TAVI, is the Streptococcus and Enterococcus. And that's in relation with what Pablo is saying. And I think they had some femoral accesses, transapical, right? Yes, that is correct. Especially at the beginning, there were more transapicals. Then everything was femoral. And there were 2 of the 3 patients went to the long term. It was a late endocarditis, and it had nothing to do with the access, but with the procedures or usual infections, or with other procedures maybe. That's why I think it's important, these type of patients that have percutaneous valve, to think about prophylaxis when they are going to be submitted to a surgery. For instance, some dental surgery or any kind of instruments, we need to think about prophylaxis in these type of patients. That's what we saw. Yes, sometimes we don't consider that. We just consider them as, well, it's because they have a stent. Any other questions? Let me remind you that you can write your questions in the chat, and then I'll take them, and if someone wants to do it that way, that's fine too. So let's now talk to the third, let's go to the third presentation. Juan Scaglia, good morning everybody. First, thanks for the invitation to present this case in the SOLACI Congress. I'm going to talk about an acute aortic syndrome in a patient with a aortic coarctation. This patient is 46 years old. He comes spontaneously to the ward of the hospital with an acute abdominal pain, a few hours of evolution, with interscapular irradiation. He tells us that before, when he was 18, he had surgery due to aortic coarctation. And he didn't know the kind of surgery he had performed, but he was asymptomatic up to the time when he had this severe pain when he came to the ward. He came with hypertension, 220/100 systolic. And in the physical exam, he had a systolic murmur at thoracic level. Initially, he did a medical treatment, fentanyl, labetalol, and we asked for an MRI, an urgent MRI, multi-sectional. And in the MRI, what we see in the coronary, the original aortic coarctation, and it was a bypass subcardio aortic, bypassing the coarctation. So we see an aortic dissection in the LAD. In the image that we see underneath, we find the dissection flap. With this diagnosis, what we did after was to do an angiography. We go through the left radial artery, and we find what we already saw in the CT scan. The LAD, we injected, we approached the LAD, and we see the aortic bypass. He had multiple collateral circulation towards the false lumen of the LAD, distal to the coarctation. We had a multidisciplinary Athenaeum, and to see what was the best way to approach this. He was asymptomatic, and we assessed risks and comorbidities. We concluded that the best treatment was to do it endovascularly. That way, we programmed endovascularly and endoprothesis at thoracic level. We used a device with a 2 times delivery covering the aortic segment and to complete all the aneurysm false lumen. The aortic coarctation had a gradient of 100 despite the bypass that he already had in his previous surgery. So we post-dilated with a coda balloon, and the transcoarctation gradient was eliminated. After that, in the same procedure, what we did was to embolize all the collateral circulation that filled the false lumen, and through the right radial artery, we did embolization with an agent, liquid agent type onyx. And in the angiography, when we continue with collateral circulation to the false lumen, we did through left LAD, radial, sorry, the left radial artery. The right one we had was through the encephalic trunk main. We negotiated the closing and distal to the prothesis through the false lumen. We did embolization of the 2 efferences that we had with 2 devices. We placed 2 plugs, with 2 plugs. You can see the 2 plugs there. And the main, through the axis, the radial left axis, and with the subclavic aortic axis, we embolize with a plug of 8 millimeters. We did a test immediately after we freed the devices, and we delivered the devices where we see a successful occlusion of the lateral opening and the occlusion of the bypass subclavicle aortic. The patient is discharged. His evolution is asymptomatic after 1 month, and 1 month later he comes back to the ward with another abdominal pain. And we request for a new CT scan to see the evolution of the previous treatment, and we see another distal occlusion that compromise both arteries, iliac arteries. There you can see the reconstruction. We were lucky enough that all the vessels and the kidney arteries were born there in the actual lumen, and what we did was to extend the treatment in the dissection with 2 aortic uncovered stents. On the previous thoracic image, we reached up to the bifurcation of both iliac arteries. Then we continued to the 2 iliac arteries with 2 self-expandable stents. He shows improvement. 72 hours later, he's discharged. And 1 year later, we had a CT scan, follow-up and control, where we see a good evolution of the first treatment with complete review of the false lumen of the thoracic aortic descending aortic, and with good permeability in the 2 iliac arteries without incidence in any of the endolip type. So that's it. Thank you very much. We don't see him connected, but if we have a few minutes, if someone wants to say something about this presentation, for me, this case is pretty good in terms of example. When there is a dissection, an aortic dissection, in this case it was coarctation, but it was a pure dissection. In our treatment, we are doing late to what it should be. There is nothing in the literature that has opinions that supports this, and sometimes I've thought about it, and the answer has been that we need to sit down and work, but it's risky. We do the same in this type of clients, and it was in the only instances in which we had plastic movement of the aortic, and compared to those that we treat the patients chronically, and then we end up having aneurysms, difficult to approach, multiple lesions, and sometimes it creates retention. I always see that the problems ahead are more and more serious. So if we can attack these problems early, it could be great if we could prove it with a large group of patients. I don't know what you think. I totally agree. We are always very aggressive with that, and we try to treat these patients early. There is a new device, Castor, that puts a chimney in the subclavic, and that helps us give us more room for anchoring. And as you said, it doesn't leave us those sequels and dilations that we don't usually see. And from the technical standpoint, it's not something that is that complex. I don't think any center could do it, and geographically, it's not that complex.
Siente completamente diferente.
That this is a completely different patient. This is an aortic cuspid with a dissection. Juan said that the grading was 100, and there was this aneurysm, and then the dissection. It was a mix of all things. So the patient was quite complex. I agree with you, Jorge. Patients having these dissections, we want to be broader, not only to include the entry tier, because the interesting point in this patient is the old concept of petit code, of placing the endoprotheses and then tent all of the sections because the subclavian is blocked. Juan is not here, but I don't know if they monitored and this patient, I think, is one of the indications in this patient. And the other thing is the endoprothesis was anchored on the coarction. So the endoprothesis is not does not have the radial strength as a stent, for example. So you should probably expand it with a stent. An interesting case, of course. Unfortunately, the presenter is absent. Let's continue with the next presentation. Good afternoon, everyone. My name is Jose Alvarez, and I'll present this percutaneous case on aortic valve. I have no conflicts of interest regarding this topic. Just a quick overview on aortic homographs. They are more physiological than conventional valves. There's less mismatch with the support valves. They're relatively resistant to infections, even though this is being questioned lately, and there's no need of anticoagulation. On the other hand, more demanding surgical technique. There are some differences in homograft and the native root diameters. they require a coronary artery reimplantation, and the wall of the homograft tends to calcify. In fact, there are some series of studies at 10 years. Only 25% of homografts are free from becoming dysfunctional. Surgical reintervention in aortic homograft failure is challenging and is associated with an increased preoperative risk. And this is stated in all risks. An average 30-day mortality rate is higher than with conventional biological valves. There's some evidence, though, on percutaneous aortic valve implantation, as this is not conventional therapy or surgery. Then there were only 22 cases of TVRs placed in homografts. There's 17 cases, mortality 30 days, 0%. 3 instances of device migration, which is one of the issues, and 1 case of embolization. This is another series of studies that only has 6 cases. This is a 64-year-old patient. In February 2009, he had a bioprosthesis 25. 2 months later, the patient had to be reoperated, and he was placed a homograft number 25. And a year after that, and we closed the Gerbotis defect, as you'll see on the images. 10 years later, remember the chart I showed before, the patient is hospitalized with heart failure class 3. The electrocardiogram showed that the graft was severely deteriorated with severe aortic regurgitation and moderate aortic stenosis. The left ventricle was severely impaired and moderate mitral regurgitation. The patient had 2 surgeries, so the best treatment was endovascular valve implantation. This is the CT image. This is the calcification eggshell type that comprises the Valsalva walls, aortic walls. On the right, you can see the left coronary artery implanted in the non-coronary coronal sinus, and here the implanter in the defect. Average diameter 25 homograft. They said it was 29. There's no severe classification of the leaflets. There is classification of the cuspus valsalva and the aortic walls. This is our analysis. The diameter was smaller, 24, 28, approximately. And again, let me say, homograft number 25. And one of the issues was that the height. I mean, the height of coronaries is quite small. Core lab was 0.5 millimeters, and for us, the distance was larger. The issue in this case is to identify the annulus, because there's no annulus in the suture of the homograft. So the patient has a 25 homograft and the diameter of 29, left coronary artery. The takeoff is non-coronary sinus, aneurysm in the LVOT, and severe calcification of the ascending aorta of the STJ. So we decided to implant coronary protection, and so we just placed the guide wires inside the coronary. We did not implant balloons or stents. A very slow deployment. See how difficult it is to identify the aortic annulus. This is one of the issues. I mean, it can't be seen clearly. This is the valve totally released, totally expanded. There's very little material on the leaflets. So despite the fact that coronaries are low. And as a conclusion of this talk, TAVRs for failing aortic homographs may be a feasible and safe alternative technique. One of the challenges, or the main challenges, we're dealing with an aortic regurgitation or failure, eggshell type calcification of the annulus that can lead to some frailty and lack of extensive leaflet calcification. So there's little support for the prostheses to be implanted, and it is very difficult to identify a landing zone. Proper prosthesis selection is important, sizing. In general, they say that an oversizing is needed, and it's very important also the depth, the optimal implantation valve depth because of migration, because it's more frequent than with conventional aortic implantations. Thank you. Very nice case, Jose. It's not as frequent. I mean, homographs are implanted on young patients, and we don't have these kind of patients much. This is a different type of case. It's an adult patient, and the question I have is about the height of the aortic and here the conduction system, I mean, it's an area that is difficult to access, I mean, surgically. So do you think that, I mean, implanting them lower, I mean, could help? Or, I mean, did you intend to do it? Hello, Jorge and everyone. First of all, thank you for the opportunity for presenting this case. We did it in 2018, and the patient, I saw him a month ago, and he is perfect, class 1. And well, he had to pay for his own valves, so he's suing the health insurance company. So the height was the biggest challenge. The surgeon did not want to touch the patient again. The patient was class 4, dilated. So we began to ask for, I mean, who had experience on homographs and TAVRs. So we did not find much. We found something in the literature. Your question about the height is the biggest challenge, I believe, in these kind of patients, because there's no defined annulus. And so we looked for a 34 valve. We believed it was fit for this annulus, and we delivered it very, very slowly. And so if it's placed a little high, then so I don't have a very clear response, actually. This is just really adds up to cases. I mean, it's just it improves case history. Jose, congratulations, very nice case. We did a very similar case, but with a lot of calcium and stenosis. I mean, it's a different whole story. It's a different story because the risk is lower. But we also used a self-expandable, and as you say, there's no limitation, or there's no, I mean, annulus are not defined, clearly defined. And as you said, we tend to be more, a little deeper in the implantation, 60-40. This is exactly what we did, and then the patient ended up with a pacemaker. But these patients, as you said, improved wonderfully. Our patient had ascites and 30% fraction level. he had 2 surgeries, but he responded really, really well. Congratulations. And these are quite challenging cases. What valve did you use? And Evolut 34, Evolut 34, because the other thing is oversizing. In your case, you did not have much oversizing. Your perimeter was 92. So 30%, 35% oversizing. In that case, did you think about using a self-expandable? No. We were quite frightened. The severe classification of the sinus, this eggshell type of calcification, is kind of, we were kind of frightened about it. We have some more time, so if you have any questions. Congratulations, because it's an outstanding and challenging case, and the ostium of the coronaries was the big concern. The diameter of the vessel osteums also helped. I mean, not having problems. Very, very nice case. Congratulations. Are you? Do you play systematically stents, or do you perform protections? I mean, in the cases without protection, we had a case with a very low height, 4 millimeters, but the ostium was huge. And so we did this with Rodrigo, and he said, it will be fine. And that was it. We used a Sapiens, and since the ostium was so big, I think it was 910, but the consensus is to protect it with a guide wire or wires or a stent. What I always measure is the size of the sinus to be able to know whether we can protect it or not, because this actually allows us. So in this case, even the diameter was not enough, but placing a self-expandable valve would have been it actually opens a little bit more. I don't know if you agree with this. In this case, with a low implantation, if it's a very high implantation with a lot of oversizing, but if it's a deep implantation, it's very difficult to compromise the coronaries. We generally stratify the risk. It's very high, we place a stent in a coronary, and then a pullback. If it's moderate or low, just a wire. And if it's very, very low, I mean nothing. A comment, this is for Jose, the case is wonderful. You have to be very attentive. He emphasized on the slow release of the valve, because it's relatively easy. And losing the position, even though the guide wire is in the coronary and then you release a stent, I mean, it's quite difficult, although impossible. Having the wire in the osteums is really cautious, and that's why the slow expansion, I think it's very important. And then the stents could be forward or not, and if you can pull the MAC or not, or leaving a small stent is not really a big issue. I mean, you can move the stents forward or save them in the middle segments. That would not imply a big compromise. The basilica technique could be an interesting option. Initially, it's something that is quite challenging, but yesterday in the PCR session, This was discussed compared with Chimney stenting. Chimney stenting is more natural for most of them. In the long term, it's not so good, and so having the basilica technique in the toolbox is good for these kind of challenging cases. Let's continue with the next presentation.
We could talk about this for hours, but we have to respect the time. Carlos Fava, the floor is yours. Left thrombosis after TAVR has been defined through CT scans as a as a halt, or as a ham. And what we did see was that the cardiac output and blood resistance time was very low in 3 of them, and this is going to be affected according to the leaflet. The non-coronary leaflets are the ones that have the most probability to generate thrombosis, and as we see in this graph, according to the colors, the more red in the non-coronary valve leaflet, the probability is higher, but not so much in those coronary leaflets, because the flow would generate through the coronary arteries that flow to not produce thrombosis. So to further investigate, we decided to go with 504 patients. We analyzed them from 2 centers, one in Slovenia and the other one in Argentina. All patients underwent echo Doppler evaluation after 1, 6, and 12 months after TAVR. The leaflet thrombosis was expected when the echo Doppler gradient exceeded the 20 mercury millimeters, and they were confirmed with a CT scan. We found 6 patients, out of which 2 were male, average age 82. 4 of them were hypertense. 1 was diabetic. 3 had AMI. 1 had a PCI before. 2 had CABG. 1 had PPMI. The LVEF was conservative. AVA was about 0.70. All of them were accessed femorally, and we had 1 patient was valve in valve. Medium gradient post-implantation of the valve was 9, and 1 patient only had mild regurgitation. Regarding the valves that we used, 3 of them were Evolut or Evolut R, 2 were E-Sapiens XT, and 1 was a portical valve. What we found in the thrombosis was that 2 patients came back 30 days after, 1 patient 120 days later, and 1 180 days, and the last one 540 days, much later. We all did the CT scan. They all had halt. 1 patient had ham, and 1 had RELM. So we did patients with anticoagulation, with Coumadin, an inhibitor of K vitamin, for 3 months, and then we did another CT scan, and all of them had a complete resolution. In 1 patient, thrombosis occurred again and received again anticoagulation for 3 months, and we were able to solve it. This is one of the examples where we see the leaflet thrombosis, and after 3 months, the way it turned out. We followed up all of them. The mean time was 26, between 12 and 60, because it's a small group. There were no events, and there were no strokes, which was in some cases strokes are associated with this complication. The limitations of this analysis is that, well, it's a retrospective analysis of 2 centers with few patients. They was not randomized, and there are only a few patients, as I said before, to have some conclusion. So the conclusion is that the incidence of leaflet thrombosis was low and successfully resolved by anticoagulation treatment. and it is necessary to have more research in which is the best, to know which is the best prevalence and what is the best strategy for the treatment. Thank you very much. Thank you, Carlos. Very nice presentation. I wanted to ask you if in those 500 patients, did you do CT scan to all of them with follow-up? Is that correct? Good afternoon. Thank you for the chance to be here. In fact, here when we talk about 504 patients, we started with the complete series. We started with high-risk patients up to the current ones, and we follow them with echocardiograms. At the beginning, we need to find this phenomena, and then perhaps the number that we have could be a little bad and not well valued. But I follow all the patients with echocardiograms in our center, and we follow them up with echocardiograms. We only do CT scans when we find that the gradients are higher. That's a reality. We found out of those 5 were ours, and those were followed up with CT scans until it was solved. But then we didn't do any CT scans afterwards, only echocardiograms. Okay, I wanted to know, in the halt, and that does not end up in thrombosis, does anybody know doing CT scans in this kind of patients that have a halt? We don't know what that is going to show us or what to do in those cases. So it appears, and I want to find out if in Argentina or in a collaborative case, people who can follow it up with CT scans can give us some information about it. I think it's a good option to do it collaboratively. We already have 2 experiences of doing collaborative studies, one in people who are 80 years old, and the one that Carlos Giuliani published in the capsule lab in the cath lab with versus 101 with the conventional strategy. We had good results. From the work point of view, I think it was good. I think it could be a good option, to work together. Yeah, with a double alteration maybe. Yeah, those who have atrium fibrillation, in those cases we use anticoagulation and an aggregate, at least for 3 months. Carlos? Congratulations for those records. It's always nice to have information about these patients. What I feel, I don't know if it's the same for everybody, if you will agree, but it's like a phenomenon that at the beginning, I was scared at the beginning. I said, well, we have to anticoagulate all the valves with the first records. They talk about 10, 20, up to 30% of the valves, especially the ones with expandable balloons. But when you go out there to try to see them, they're not that frequent. I don't know what happens to you, but we cannot find them that frequently. Yeah. Yes, just like Carlos showed, the frequency is pretty low, and the variability in the presentation, maybe they have halt without ham. They solved most of them, but one of them was recurrent. So it's we're still not that well informed about what type of pathology this is. And you also showed, Carlos, that these patients did not have any clinical consequences. They had no stroke, no infarction. No, and not only they did not have those, but they normalized their gradient. The hemodynamic function of the valve was preserved despite they had it. So I think that is a very good piece of information, and the prevalence in the different analysis is pretty low. The stroke prevalence is pretty low. Carlos, I have a question. Did any of these questions that had the leaflet thrombosis required post-dilation after the implantation? And if you think this could be related to the thrombosis in the long term? I don't remember that, but yes. What's published is that sometimes the post-dilation of the valve could damage, and that could generate thrombosis, result in a thrombosis. Now we are pre-dilating much more than post-dilating. Initially, they said that pre-dilation had to be related with stroke, so we didn't pre-dilate, we post-dilated more. And now we are doing the other way around. We are doing post-dilation has decreased. I don't know if it's 10% even. Yes, we pre-dilate first, and then we try not to touch the valve that we're going to place. And we had 2 thromboses, one aortic and one with an evolute. For me, I don't know if that's so true, because patients after 2, 3, or 4 months of having it placed, so thrombosis should appear earlier, but in the follow-up through a CT scan, we do the follow-up with an echocardiogram, but when we saw the gradient, we had to do a CT scan, and sometimes we don't see clinical issues. We still don't know how to solve all this. We have an economic problem, basically. Another question? Yes. Regarding what you said, Dr. Vaccaro, when we use the echocardiogram as the first image, we have some bias there, which is a gradient. We have a problem. If we did a CT scan, we would find more thrombosis that had no implications, hemodynamic implications on the valve. And that is concerning, especially when we move forward with younger patients. If this thrombosis, this thickening of the leaflets could deteriorate them in the long run, and they can shorten the use life of those valves. We expect them to be 10 years and more of life. I think that it's not that clear yet what clinical implications are there in the long term. If we are only treating a finding, that we do CT scans and we find that, and we are scared to leave it that way. But at the same time, on the other side of the scale, we have to put the anticoagulation. The bleeding risk is there. The trend is not to anti-aggregate. It's just aspirin. And we are thinking to aggregate an anticoagulant like a K vitamin inhibitor, that if it had a high surgical risk, it could come with a high bleeding risk as well. And bleeding is very dangerous. I think the world doesn't know this. When we find out that with the great follow-up, the implications that it may have, then we will have a clearer understanding for what the risks of bleedings are and these findings. All right, we have 24 minutes more in this session, so we could talk about the topics that were discussed before, or if there are any other questions, particularly regarding the case that Jose presented. When I remember a case in which we put a stent and the valve went down, and it was well aligned with the valve frame. My question is, if it's the flow is too complicated and we free the stent, and the stent is outside the valve frame, if to canalize again, to try to use the cannula again within the frame of the valve, so that the stent can be within the lumen of the valve, or to leave it the way it is. What is your? I don't know if the question is clear. So the idea is not to lose the positioning, the placing, and to do a kissing balloon, inflating in the coronary ostium, stenosteum, a short kissing balloon so that everything falls back into place. I don't know if that's what you meant, doctor. No, what I meant is the stent would be leaning on the frame of the valve frame. Oh, that's a chimney effect. If it would be more convenient, or maybe we would try to align it with the septum of the valve. So recanalize outside the valve and go inside again and try to
compleja y como si
canalate again, as if you try to do a crashing. No, so that the valve did not outgrow the stent, because when you free the valve, the ways are outside, and if the native valves or leaflets are there, even though we put the stent, it may happen that the stent it falls outside the valve frame, and we should try to cannulate that again, but to try to open the ostium more. Sorry, I think what you mean is if we place the stent not as in a chimney way, because it will depend on the type of prosthesis. We are talking about closed cellar, self-expandable. If it's a neo, then it's going to be outside at the height of the upper coronary. But if it's closed, I think one device that can be used is IAGS. To advance with an IAGS to see where the stent is. If it's too crushed near the ostium, then as you, Jorge, said, we recanalize and we open the stent towards inside the prosthesis, because it's true, if you leave a crushed stent in the near the ostium, there is valve in valve that were placed with stent, and the restenosis rate is really high because the stent is all turned around, and sometimes you have to place a second stent. I think it could be an intravascular image, and if it's well expanded, to leave it the way it is, and if it's too collapsed, recanalize inside the valve, as you said, and that's what I would do. Anybody else has any questions? I have a question for Carlos. Carlos, I wanted to ask you, because when the gradients increase, they don't necessarily increase a lot. You said that there was one of a 10 millimeters mercury millimeters cut. Did you take that cut, or did you suspect that there were patients that could have leaflet thrombosis with a lower increase? It was more than 20 or more than 10 of initial gradient at the end of the procedure. And another piece of information that I didn't find any literature about is how much the speed increases. Under 2, when the gradient increases, we also relate it to the speed that is usually above 2.3, 2.4. That's what we use, but in fact, what it's described is the gradient. And based on these findings, nowadays, do you anticoagulate your patients? No, only those who have atrium fibrillation. Yeah, so not outside what's usually prescribed. No. Okay. Yeah, it is a problem because we treat patients nowadays, at least in the institution where I am, I have patients that are very high risk, bleeding risk, and anticoagulating those is much, the risk of anticoagulating those is much higher. Yeah, bleeding usually we pay, as one of the other doctors said. And in patients that are over 80 years old with a double alteration, there is always problems with them. When they come to check themselves, they have hematomas in their hands because they get They, the simplest bump and they get hematoma. So they're not event-free, as event-free as they appear to be. How long do you have them anticoagulated? For 3 months. We do it together with the hematology department. The hematology department is the one that manages the anticoagulation, and we are in continuous communication with them. And according to the information that we have from them, we suspend anticoagulation. We did it 3 months also, but after 1 month, the gradient descended quite a lot. We had to continue with anticoagulation. But I found really no literature that says 1 month, 2 months. It's random, really. When we talked with hematologists in the hospital, we decided to do it 3 months, and we didn't have any echocardiograms in the middle. We did an echocardiogram at the end after 3 months. Carlos, when you recorded it, did you check if there was any predisposition of the other patients, varied or multivariate, that could orient us? 6 patients. No, we didn't do it. No, that's the reality. Very little population, very small population. With regards to what Jorge said about CT scans, from the financial standpoint, in the CT scans in these patients, on average, it would be impossible. Rach Makar presented these cases, and he recommended doing CT scans after 30 days and repeat another 1 year later, because this type of phenomenon could be even 24 hours after implantation of the valve. So it could be 24 hours, 3 months later. It depends. It changes all the time, and it's impossible for us to do a CT scan follow-up. Many of these patients have kidney failure, so we have to check the kidney function. And as you said, to do it, with an echocardiogram, and if there is an increase in the gradient, we suspect, and then we do the CT scan.
When did you repeat the CT scan for these patients? No, we didn't do that, just an echo. Because most of them are, as you said, are 80 years old or 70 years old, and a lot of them have cardiovascular factors, and they are P60 or lower, and the presence has shown that they're not likely to have greater events, so we rather be more conservative, and not repeat CT scans. About the coarction case, and what you said about the stent and the endoprotheses, there's a risk of rupture, so here I think the idea would be to have a prosthesis outside or a large stent, and that could imply a very high risk. Maybe it will be a chronic coarction. So I believe probably that could create a significant gradient, or probably placing a stent inside would be a possibility, but knowing that patients have died, for being aggressive. I agree, Jorge, and this patient has a dissection. These patients, you want to be conservative when choosing the prosthesis diameter, so as not to perform a significant oversizing, just 1:1 ratio. I agree that this is sort of a broken aortic, You don't have to expand it. This is a different kind of physiopathology or pathology, and if you want to expand it, you will be performing more, you'll do more damage. It is actually below the coaxium, and if you break that, I mean, you'll be breaking the aortic artery. And we've seen cases where the aortic artery, was disrupted or broken, and there was 100% mortality, 100 gradient. So the correct surgery would be the dissection of the coaxial. I mean, they left the coaxial on site and they performed a bypass. So probably the cover stents would be useful, would be an interesting or valid alternative. Yeah, but if you consider the diameter, it's pretty much the same thing. So to respect the diameter is important. Jose, regarding the implantation technique, in these cases, particularly in these patients with angiogram and pop-up risk, you perform an implantation with a pacemaker, or you use mark pacing, or 100, 110, 120. You're on mute. This is a 2018 case, so I don't remember if we use a pacemaking, but at this time, yes, we do this systematically. I think all of us, because it provides more stability. I think it's much better. And as regards coaxial, Jorge said something at the beginning. I think we need to rethink the treatment of these kind of dissections, I'm sorry, and be more aggressive initially. I think that in the long-term evolution of patients will have better results. And so the results are terrible when they develop aneurysm. So I think it would be saving quite. I mean, it's just a hypothesis, but we should probably think in that direction. Do you have any experiences with the COOP device for dissections? Has anybody used it? It has a sort of an uncovered stand, and so the concept, balloon release, and to in Argentina, it was brought into Argentina, this technique. I never used it. I don't know if somebody used it. The concept seemed to be quite aggressive, but no experience here. I agree with what you said, Jose, to be more aggressive with these patients, to treat the aortic artery more extensively. The thing is when to do it, because in the long term, these patients will remodel the aortic artery. This has been proven already. And today we're treating patients. I mean, this patient is completely different type of patient, but patients that have an uncomplicated, sometimes you wait for 20, 15 days, 20 days, so the wall of the artery becomes more stable, and then the patient is treated, unless it's a very complicated type of patient that has some, complication that has to be treated urgently. But otherwise, I mean, waiting 15, 20 days. I agree. Ischemic complications in acute patients with a proximal dissection that would resolve because this drastic remodeling of the aortic artery, the rest would just widen the axes, and the patients, in fact, have not have any. It's proof that patients have to spend more on follow-ups and rehospitalizations, and the problem keeps occurring. A question to Matías. What antibiotics do you use with TAVI procedures? Because I think that this should be changed because of the germs we've encountered and infectious myocarditis. Oftentimes we protect against Staphylo, and then we have Streptococcus or Enterococcus.
Hacemos amoxiclavulánico de base, 3 gramos, pero la realidad es que sí, uno después empieza a evaluar. Por eso está bueno justamente hacer estos registros.
It's good to, to develop these registries, to have a look at the cases and act upon the cases that we gather. Do you use similar regimes just to? How about you, Marcelo? A few months ago, we used clavulanic, but at the start, cephalosporin, and we had 2 patients with endocarditis of the mitral valve. 2 patients, actually. And we shifted to that regime, and so we send patients over to the dentist. So we want to treat them as much as possible, and then we recommend patients in the follow-up whether you're going to have some intervention procedure so as to provide, the proper antibiotics. What do you use, Pablo? Cephalosporin, based on what is used in cardiac surgeries, but based on the different kinds of series, we should reconsider for TAVI patients. To my view, there isn't any difference between surgeries and TAVI, and we use cephalosporin or Benco. There's a recent recommendation by a European group, and they recommend clavulanic and vancomycin. We had the opportunity then to share experiences from different parts of the country, and we have many other questions, but if we agree, then I'd like to wrap up and thank you all for your presentations, the panel members. Thank you for your time, and thank you to the society for this opportunity. And at least meeting this way can actually help us, continue working together and share information. Thank you for your time again, and thank you for your contributions.
Okay, muchísimas gracias.
Good afternoon. We're going to start now with this oral presentation session, Coronary II. And before we start, first I'd like to thank the steering committee for this kind invitation. It's a pleasure to participate in the SOLACI-CACI event once more. And of course, its president, warm regards to Damonte, Alfredo Rodriguez, and the secretary, Ezequiel Rivero. And today I have the pleasure to share this session with distinguished panelists and friends that I'm going to name. Dr. Alberto Garriga Perez from the Phoenix Hospital in Chile, Dr. Juan Jose Fernandez from Trinidad Hospital in Palermo, Dr. and great friend Pedro Gallardo Galeas from Tucumán, Maximiliano Giraudo, I don't know if he is already connected, Dr. Jose Abelardo Lopez from Venezuela, who works in the Clinical University Hospital of Caracas, Jorge Murad from Buenos Aires, and Cesar Lopardo, who also works with Dr. Rodriguez and the Otamendi's hospital. We're going to start with this session and the presentation, of course, of all the works that have been selected. And we're going to have the first one. I have the honor and the pleasure to present to you Camila Gallardo, fellow of the cardiology interventionist cardiologist in Buenos Aires of the Otamendi Hospital. She's going to talk about the first work, use of colchicine in patients submitted to angioplastic with stent, assessment on tolerance and efficacy of the ORCA registry. Camila, the floor is yours. Hello, everybody. Thanks for the invitation. I'm Camila Gallardo, fellow of the Otamendi Hospital in Buenos Aires. First of all, I wanted to thank the opportunity to participate in this Congress. Now, I'd like to talk about the efficacy and outcomes of colchicine for the prevention of restenosis in patients undergoing PCI with BMS. First, these are my disclosures. As we know, in the past years, the role of inflammation has been paid quite a lot of attention thanks to the randomized clinical trials that demonstrated that the chronic use of colchicine, for example, in patients with coronary disease, had good outcomes. This is associated to some adverse events, such as infectious and gastrointestinal inconveniences. However, the use of the drug during short periods of time to prevent restenosis in patients who underwent PCI with conventional stents is not well known, and that was the objective of this registry. This registry is part of the ORCA trial at the beginning of last year in 3 centers in Buenos Aires and compares the colchicine plus BMS strategy versus the second-generation drug-eluting stents in patients undergoing PCI. As part of the ORCA trial, that is going to include 125 patients in each one of the treatments, we have all the patients that do not adhere to the protocol, the randomized protocols, but that anyway receive the drug under study to evaluate the adherence and tolerance in terms of adverse effects, drug discontinuation, doses reduction, and the clinical outcomes in terms of efficacy, including overall death, myocardial infarction, ischemic-driven target vessel revascularization. Colchicine were in 0.5 milligrams twice a day, was administered like that, 3 months from the moment of the PCI. And at the same time, we analyzed the angiographic baseline considerations and the inflammatory events such as the reactive when the angioplasty was performed and 1 month after. The baseline characteristics of these patients, 216 days after follow-up, 75 patients inside the registry, 80% of them were male, average age 68, 61% hypertense, 25% diabetic, 15% had previous infarction background, and some previous revascularization, 25% with 80% of the patients had acute coronary disease and STEMI. 55% of the patients had artery descending LAD. We treated a total of 98 lesions, average 1.6 simple stents implanted per patient. In terms of the clinical events, 2.7% of the total patients died during the procedure, one due to stroke, the other one due to COVID-19. 1.3 patients had revascularized PCR due to ischemia. In terms of adverse reactions, it was very low during the follow-up, mostly gastrointestinal effects like diarrhea in 14% of the patients, and that made us reduce the doses from 0.5 to 0.5 milligrams per day and not twice a day, and to suspend colchicine in 6.5% of the patients before the 3 months. We also checked the CRP and index with an average of 2, the 1 month CRP with a control number of 5. As we know, inflammation is well known associated with the pathogenesis of atherosclerosis, and recently different randomized clinical trials targeted the inflammatory pathway in cardiovascular disease showed promising results. In this case, colchicine was the drug that was studied in the early treatment within the first 3 days of myocardial infarction, and target vessel revascularization showed similar outcomes compared to DES without increasing hard clinical endpoints. Also, there was a meta-analysis of individual cases of randomized cases evaluated with oral administered drugs to prevent death, myocardial infarction, and revascularization. We showed, as I said, similar outcomes compared to DES. At the same time, it showed good results in terms of restenosis and revascularization of a vessel that was treated in diabetic patients treated with colchicine. Colchicine was administered in chronic patients. The other one, Logorcor or Colcor, did not show much incidence of adverse effects, probably due to the fact that the drug was administered for a shorter time. None of these trials showed less tolerance to colchicine, but they showed gastrointestinal complications, especially diarrhea that appeared after the drug was suspended. The use of colchicine was quite tolerated with a few adverse effects. The clinical implications of these registries is that colchicine is an accessible drug that can be used in acute coronary episodes for events for short periods of time with high tolerance and restenosis and hard clinical trials. So I leave you the query code to find the results of the ORCA trial. And now I'd like to thank you for your time. Camila, thank you very much. Excellent presentation. I wanted to ask the panelists if they have any questions at this point. We have 5 minutes for questions, and then we'll continue with the presentations, and we'll have more time for questions at the end. Any panelists has any questions? Camila, a question. Excellent presentation, very interesting, very current topic. The patients with systolic dysfunction, severe dysfunction, 40% were about 25%? Correct, yes. Lower than 40%, 25% of the patients, yes. But the study was not targeted to that type of patients. They were there like randomized. It was random with so many patients with severe dysfunction, or did you have a specific thing to treat them? No, in the registry we include patients with dysfunction with FMI 40%, but in the randomized trial we include the rest of the patients.
Porque escribí el
I'd like to clear something up because I wrote the protocol for this. In the ORCA trial protocol, the severe atrium dysfunction was a counterindication to enter the protocol. But in the registry is for the not that good candidates for the protocol. So perhaps that's why the number of patients with worse ejection fraction were made the cut. I have a question regarding, first, congratulate the speaker. And I have a question also. According to this, the recommendation, according to this job, would be then to administer colchicine to all patients with acute coronary failure, or to all patients. In the protocol, we give colchicine to patients who have PCIs with conventional stents, and we give them colchicine twice a day, 0.5 milligrams for 3 months. The 3 months after the angioplasty. But in the protocol that we're doing, it's only for the patients that are within the conventional stent. In that group, most of the patients start with infarction, whether it's supra or not supra. And then there are others who come with angina, stable angina, but most of them come in with PCI. Congratulations for your research. Doing research in Argentina is quite a thing here in this country, but my question is, why did you decide 3 months colchicine and not 6 months colchicine? Why did you decide to administer just 3 months? Most of the studies, the trials, Colco, Cantos, most of the trials had longer treatment protocols, and what we saw in this adverse effect were infectious adverse effects. Within the Colco trial, the one that studies colchicine per se, they didn't have any septic shock or severe inflammations, but some pneumonias that did not require hospitalization. And since it's a drug that acts in inflammations and stuff like that, the idea was to have small or short colchicine cycles to see if we were able to prevent adverse events, because diarrhea, we were able to tolerate it, but maybe the infectious events, more severe infectious events, can be reduced by having a shorter protocol with colchicine. That's why 3 months. In most of the trials, 6 months to 7 months, 1 year sometimes. Camila, I understand that then you are reporting 75 patients that you followed up for 7 months, a little bit more maybe, correct? Yes. Is that correct? Yes. Now, within these patients, you then had 15% of them with diarrhea. You had to reduce the dosage to 0.5 only once a day, and 6.6% of them suspended the colchicine after before 3 months. With these events, adverse events that you've had, were you able to have a favorable calculation? Because for 75%, these percentages are quite important, and this intolerance is the same. It's the same that is, you know, the other prior trials are showing the same results, the same outcomes. In general, intolerance to colchicine, we see that in patients the first week when they start the treatment, during the first week of treatment, which is mostly diarrhea. This percentage, 15%, about 15%, was reduced with the use of the diet that we recommended to each one of the patients, and to use an anti-diarrheic medication. Patient who started with diarrhea, they never had any other episodes or events, and they were able to complete the treatment, the 3-month treatment. If they were not able to control it with the diet and the doses, we decided to reduce the dosage once a day. And last but not least, if they did not tolerate it, then we suspended the drug. But what we saw in the records, it was not a great number. Most patients were able to complete the 3 months. 80% of them have a PCI. 56 of them had a multiple vessel disease. And I wanted to ask you, in the evolution, these patients that you point out, what they saw there is that mortality was only 2.7%, infarction 1.3%, 4% of DVR. But do you think that there will be an extension of the results due to the anti-inflammatory effect in these patients that already have PCI? The question that they asked before is, after 3 months, what happens after? Yes, that's what we are looking for. For now, patients, we haven't had any cardiovascular event death. We had a TVR of 4%, but the deaths that we had were non-cardiac episodes. One of them, which is included in the registry, it got infected with a severe COVID while he was hospitalized, and he died because of COVID. The other one was a stroke. Then we had no other cardiovascular deaths. TVR, very low, 4%. And this multiple vessel disease, how many of the patients were solved in this case? Or did you just treat a single vessel? No, we treated most of the lesions, but the lesions that were under the registry or the protocol were the lesions treated with BMS, sorry. And 1.8 vessels per patient, that's the average. And the stent that you use, the bare metal stent, is just one, or did you use other stents? Most of the ones we used were Walps, but there were some that within the registry used different bare metal stents, different brands. All right, I think we're going to leave the discussion here, and then maybe later, if we have any questions, we leave it to the end. And now we'll give the floor to the second presentation. Juan Ramon Miere, a very good friend from Otamendi Alfredo's group. They always have these very provocative things. Very long-term angiographic follow-up of a patient with chronic total occlusion treated with multiple bare metal stent implantation followed by oral rapamycin, an example of why this strategy should be open. Juan Ramon, the floor is yours. First, thanks for the invitation to this prestigious Congress.
This opportunity, I'd like to present a clinical case, angiographic follow-up long-term, over 6 years of evolution, a patient that with total occlusion treated with multiple conventional stents, BMS plus an oral immunosuppressor, and why this example would be something that could be replicated and not forgotten. No conflicts of interest. And in 2014, we published a randomized trial comparing BMS, rapamycin, oral rapamycin versus DES. And we were able to observe in the long term, over 5 years, that this strategy was not only, it was much better than the pharmacological strategy. Let me share this randomized trial with you, the largest one published between DS and BMS, second generation DS. Almost 70% of them, we could observe that mortality was similar and even a little higher than DS 6 years of evolution, and the primary endpoint did not show significant differences between both strategies. I'd like to say this latest meta-analysis published with the patients that were randomized with angioplasty or surgery, and we could observe that patients having stents were lower to bypass surgeries, to coronary surgeries. This is when we analyzed DS. But when we compared BMS with DS, and events were quite similar. The purpose of this presentation is to show you a long-term angiographic follow-up, 6 years, in a patient with high rate of intrastent restenosis treated with BMS plus rapamycin orally for 14 days. The patient is 67 years old with blood hypertension, hypercholesterol, and the angiography shows total occlusion of the right coronary artery. The syntax was 33, and the ERASI score, the one we use on a regular basis, it was 22, where we analyze more severe plaques, 2.5 above. The anterior artery is totally obstructed, and this circumflex has a moderate lesion in the mid-third. This is the LAD occlusion. The strategy was BMS and rapamycin. After the consent, the patient underwent canalization with a medium wire and several 1.5 and 1.0 support balloons, and 3 BMS were implanted. Rapamycin, he was given rapamycin for 2 weeks, and Completo was administered for 3 weeks. This is the angiographic assessment showing that it's an intermediate size vessel. The patient became asymptomatic at 6 years, the level of leukemia was 119, and a perfusion study where assessment showed a small interapical perfusion, so a new coronary angiography was performed. In this case, the coronary stents were patent and their collateral flow regarding the right coronary artery. Over in this section, you can see the LAD and the circumflex artery remained the same, with the same appearance. The QCA was quite similar to, at 6 years, was quite similar to the previous one, and we performed an Addison treatment, and we observed that the vascular vasoreactivity of this patient was fine. So we can conclude that BMS plus an immunosuppressor treatment such as rapamycin appears to be effective in the long term, even in these patients with high rate of in-stent restenosis, and patients treated with this strategy could be less likely to develop neoarteriosclerosis, which is a current concern of BMS, particularly in the long term. The patient is a high-risk patient, and we see that 6 years later, the patient did not have significant changes. In fact, this is a 7-year follow-up, and the patient is asymptomatic. Adenosine does not show that vasoreactivity is not altered. Thank you very much for your attention. Thank you, Juan, for this clinical case. Very interesting. So it's now open for questions. Juan, for how long did you administer rapamycin? Rapamycin for 2 weeks. 2 weeks. And clopidogrel, if the patient is stable, 3 months on a regular basis. The result is fantastic because if you think of a CTO, patency is really fantastic. When you think that the restenosis rate would be really high in these kind of patients. And rapamycin, let me ask you, do you begin with an initial dose and then is it the protocol was 6 milligrams and then 2 milligrams per day and 13 additional days. And this is one of the protocols of rapamycin, oral rapamycin, because this is ORAR3, which is cost effective, and it has over 500 patients who were all also included in a meta-analysis with and other groups that have also used rapamycin, and the meta-analysis was favorable. The problem with this medication is that it's expensive in Argentina. Well, all of the medications are probably more expensive than what we would actually expect. The case is very interesting because it is resolved through time in a really outstanding way, particularly with BMS. we would say we would wait for a long-term, I mean, a less favorable long-term result. But in this case, rapamycin plays a key role, the strategy and the follow-up. All of these three factors play a very important role. I mean, this is a key to success of these interventionalist approaches. Follow-up, I believe, is crucial because this patient, the first 5 years, he was perfect. Then in year number 6, he's had a lot of, he split up and, he changed his lifetime. And so he had hypertension, overweight, and then during that year in particular. Juan, let me ask you, the fact that you give rapamycin for only 2 weeks, is that based on BMS, where the restenosis rate occurred in the first 3 weeks? However, in this particular case, that has so many conditions to have a recurrent restenosing, and you use stents that are 3 to 225 with the length is 64 millimeters, and also the clopidogrel, because only 3 months for current standards, we've really made a lot of progress in terms of DAPT and identifying these kinds of patients that can have a high rate of thrombosis and restenosis. I'd like to hear, to have your comments on it. I believe that interventionalist cardiology has, the stent thrombosis and the physiopathology is completely different. In fact, the stent thrombosis phenomena was first reported in the European Cardiology Congress in 2016. Since the 3 or 4 first years of using DES, and since this is a stable patient, then we have, we can shorten the time of DAPT, since it's not an acute coronary syndrome. But I believe BMS, as they can, the patient does not have instant restenosis, those stents could last for life. And in the study that you presented, and you compared with the first generation DS, and in this study, it was a 5-year follow-up. What was the restenosis rate you had when you applied that strategy? Juan, are you there? So about the restenosis rate, 5 years. It was lower than 10% in the BMS 5-year follow-up, but we did have more major cardiovascular events in addition, with the DS. A question? In your study with rapamycin, oral rapamycin, and quite a large number of patients in the follow-up, which were the side effects with oral rapamycin in this series? Was it well tolerated? Were there any infections? Actually, we did not have any serious infections. Patients that the patients we managed, the most frequent adverse events are cold sores that account for 20 to 30%. Cold sores, and we treated that with lidocaine, and it was just 2 weeks, and then the patient, I mean, was not discontinued, but was one of the things that was more frequent. And then nausea, diarrhea, and the gastrointestinal, but not severe complications. We will now move on to the next presentation presented by César Ariel Lopardo. Actually, 2 studies. The first one, IFR versus IVUS relationship in intermediate lesions in the mid segments, distal segments, and lateral branches. And the second one, Cesar, could you present the 2 studies, and then we will have some time for discussion.
Cesar Opardo, I'm going to present a work called Relationship of IFR versus IVUS in intermediate lesions in proximal segments of the AC and TCI. The luminal minimum area of 4 square millimeters has shown a good relationship with the FFR, with significant results in smaller vessels. Another index, which is IFR, it's an index that can evaluate lesions in tandem as opposed to the FFR. This IFR can assess all the segment of a vessel in tandem and diffuse the IFR, and the FFR can evaluate intermediate lesions. The IFR can be evaluated in relation with the IFR in IVUS. The idea is to determine the differences in the relationship between IFR and IVUS. It's a design of single perspective cut, 56 patients, 33% of them were questioned in the medial segment, distal segments, and lateral segments. We considered intermediate lesion and stenosis of 30 to 70%, higher than 2 millimeters. And we used as a belt score to define segmentation. We excluded all patients that were questioned of LAD and proximal segments in the coronary arteries. We took as a normal value of 0.90 and a minimum luminal area higher to 4 square millimeters. We used the RJC and a percentage for variables categoric values. To define the relationship between IFR versus IVUS, we had a robust, linear, simple procedure. The procedure was done to do IFR and IVUS in distal and medial lateral arteries. We did IVUS and IFR by blending the images. This blending of images that SimVision gives us identifies lesions in particular, and we can identify where the pressure drops the most to evaluate the minimum luminal area. The statistics shows that we used As I said before, we use the DFR, simple, robust, linear approach. 76 years old was the average age. Before that, they had an angioplastic, 31%, PCI, 35%, STEMI, 8%. And as I said before, also patients were ambulatory patients. As a result of this work, the linear analysis showed a moderate association between IFR 90 versus IVUS in the luminal area, minimum area of 0.4 millimeters according to the corresponding segments. And as a conclusion, in medium segments, distals, and secondary vessels, the IFR shows a linear relationship, determining the IFR with IVUS with moderate certainty. Studies with more patients could show that the predictive relationship is better. Thank you very much. César Opardo, I am going to talk about now the relationship between IFR versus IVUS in intermediate lesions in the proximal segments. The minimum luminal area in IVUS showed a good morphometric sole luminal area, a direct relationship with the coronary, and the IVUS correlated with the SPEC, showing good sensitivity and specificity to discriminate the positive SPEC. We've also done several tests comparing IVUS with FFR, always taking this value of 4 millimeters squared in the minimum luminal area, and we identify a very good relationship with this FFR. Currently, the IFR is a new index that does not require endothelium and is capable of measuring the physiological relevance in PCI. Instead, in IFR, we related to the IVUS luminal area, we still need more data in its correlation. The goal is to define the relationship between IFR versus IVUS in intermediate lesions in the LAD and in the epicardic segment. So the design is prospective. The population were 56 patients referred for angiography and coronary angioplasty. These 56 patients, out of these 56 patients, 41 were asked in their questioned about their proximal segments. Intermediate lesions were defined in proximal segments when they presented stenosis between 30 and 70%, and in LAD, stenosis lower than 50%. Physiologically, we found that the IFR equal to 0.89 had a significant IVUS value of a minimum luminal area of minus 3.9 square millimeters. This in proximal segments, and at a level of LAD, we considered it as IVUS significant number of a minimum luminal area of smaller than 5.9 square millimeters. The procedure was to use IFR. We advanced the pressure up to 0.014. That's where the pressure sensor is in the proximal radio opaque area. When we get to the etal segment, we do the Pullman, and with this Phillips system, we can do the physiological map of all the coronary tree, and to identify the specific areas with diffusers, we can detect and use. For the IVUS, we use the registry IVUS versus angiography, where we identify a specific area, angiographic area, and see the type of lesions inside the IVUS. Once we have these three procedures, angiography, IVUS, and IFR, we blend it and we identify specifically the intermediate lesions, and we assess in that area what type of pressure it had. With regards to the statistics in the study, we use the continuous variables and standard values according to distribution to define the relationship between IFR versus IVUS. We did a robust, linear, simple process, and the population, 75% were males, average age 66, 79% hypertense, 20% diabetic, dyspnea 8%, 58%. These patients, 41% were STEMI, 8% were non-STEMI, and STEMI. And most of them were ambulatory patients. And the results were that the results that were considered were that the segments through the anatomic score syntax, number 1, 5, 6, and 11 are for the proximal segment, and the acute coronary syndrome. Those patients, the evaluation of the lesions, intermediate lesions, were evaluated once the acute disease was approached. The IVUS showed in the linear analysis a high association between IFR lower than 689 versus IVUS when the second segment corresponded a luminal minimum area of 0.9 or 5.9. That is for the left coronary main. So the conclusions are that in the coronary epicardiac arteries, the IFR versus IVUS shows linear relationship, a high linear relationship. Thank you very much. Thank you, Cesar, for your excellent work. Now I leave you to discuss with the panelists. I want to ask Alberto's opinion. What do you think about the findings of this IFR, both in intermediate lesions, proximal lesions, as in distal and branches? First, very interesting. The work is really interesting. I agree with the opinion of another panelist who said that it's difficult to do these type of things in Latin America due to the time and the financing. It's very hard to find, so congratulations. That's the first thing. Second, some questions with regards to, this is for all types of patients, I understood, disregarding whether they have lesions in different segments, or maybe you separate patients with proximal lesions or distal lesions that are focused. No. The inclusions were always intermediate lesions, despite the area, whether it's proximal or distal. But something that I did not say is that it excludes the lesions that is too distal due to the type of string of IFR. One sometimes cannot analyze it, but in the distal proximal segments, we analyze all of them. And in some cases, we analyzed focal lesions, single lesions, and in most of the cases, they are in tandem and diffuse lesions. Do you always use IFR? You never prefer, or when you have a doubt, you need to do FFR, or you say, okay, no IFR, and that's it? No, IFR always, directly. Especially because it's been proven that FFR, you could do it when there was a lesion, a focal lesion. When we have two lesions in the same vessel, it's difficult to use FFR as a technique. And if we make the decision to do IFR, then we just do it. Okay, and with the results, the idea would be, because sometimes you use one technique, sometimes you use another, sometimes you see a lesion and you think, okay, this is just one type of lesion. I'm going to treat this. I'm going to use ultrasound to do the treatment. And your idea is, okay, now that I have this background, I'm going to use ultrasound to do the double assessment at once. Yes, that was validated and it matched very much so, and that is what IVUS does in the distal section. And when the vessels are smaller, thinner, that's when IVUS loses strength, and there is a good relationship between IVUS and IFR in the proximal and in the main. In the assessment of patients with main, I'm sure IVUS, for reasons that have been validated enough, that's when you are going to have to treat the main, and you will have to do it with image-guided treatment and to start the strategy that you're using. That's one thing. The other thing, in these two series included patients with infarction at SRT levels, 8.3% in proximal segments and 8% in medial and distal segments or lateral segments. And we know that due to the microcirculation, to measure the IFR, it may not be exact. What can you say about that? Yes, it's not a strong evidence to do IFR. In these cases, there is not a strong evidence, but what we are assessing is the intermediate lesions. In the first studies that we did about these type of evaluations or assessments, they were used in severe lesions first. And these were intermediate lesions in which we got a lot of support from IVUS in order to define and to do something about it. In the angiographic way, you could not make a decision whether you postpone the angioplasty or if you made the decision to do the treatment. That was mostly the goal. Cesar, I have another question. This is a problem question, so we all learn. I have a use rate very, very low, 5% in my daily practice. My question is, you had unstable patients and then stable patients that were taking to programmed surgeries. In a functional test for an ischemia, circumflex ischemia, you have an IFR and FFR that are not good for treatment. So how did you decide then the treatment in those types of patients? In fact, if there is a positive functional test and an intermediate lesions, we would treat directly. In those cases, what we did was to study. Sometimes we found other lesions that did not match, and then we assessed. Except when there is an intermediate lesion between 30 and 50%, and that sometimes we don't dare to treat that if you have that ischemia. And we had good correlation, so we justified ourselves more maybe with the IFR. I asked that question because that's what happens in my daily practice. We compare the symptoms, the functional test, and then we decide to do the IFR. Yeah, sometimes there are patients, especially more now during the pandemic, that did not do a lot of functional tests lately. They did ECG and they came with the clinical tests. And we found with intermediate lesions, and then we evaluated and decided to do according to the IFR results, and then we do IVUS to continue with the support. In fact, that is the most, that's what we do in most cases. Intermediate lesions due to time restraints, I'm going to have to move forward with the next work. And then if we have time, we'll go back to these questions, all right? Except Pedro, if you have any questions that is rather short. In fact, something very clinical, like my friend Mac, a patient who has a lesion of a 50% of positive functional tests, normal ECG. In fact, those patients, I do angioplasty and I put a stent. Of course, a great teaching that I gave us, it taught us to implant a stent to avoid thrombosis. I had it, and currently I do it, but my advice, the advice that I would ask from you, what value of IFR you currently use in a catheter room? What do you mean value of use? How much do you use it? The use value, with always talking about intermediate lesions, okay? We postpone the angioplasty in 70% of the cases, and we have already become more aggressive in terms of the main, and we have postponed main angioplasties or revascularization based on the IFR. So it's very useful. At the beginning, it was a little difficult to make those decisions because we were not that used to doing that. And in the follow-up that we have, the patients did not have any events who were not successful with the treatment. At the beginning, we started using it more as a research technique, and now it's really valuable. We use it as another tool. Thank you, Cesar, for your excellent comments. And now we'll continue with the next work about new concepts to use rotational atherectomy in a postal right coronary artery chronic total occlusion with severe calcification. This is the work that will be presented by Marcelo Harada Ribeira from the Florianopolis group in Brazil, in Sao Paulo. Marcelo, the floor is yours.
Hi, my name is Marcelo Arada Ribeiro. I'm from Florianopolis. I'm affiliated with Research in Heart Institute in São Paulo, and I work as interventional cardiologist in Florianopolis, Brazil, in Bahia Sul Hospital, in SOS Cardio Hospital. And I will present a challenge case here, use of extraplaque rotational atherectomy in uncrossable ostial RCA-CTO lesion. Let's go. No disclosure. Clinical history: male, 78 years old, diabetes, dyslipidemia, hypertension, coronary artery disease, previous MI and CABG 10 years ago, and RCA PCI attempts another service 6 months before. Chronic kidney disease, peripheral artery disease, severe. The case presentation is a patient with angina CCS3, electrocardiogram showing inferior epicardial ischemia, EF 30%, with severe inferior hypokinesia, and the MIB showing severe enlarged inferior ischemia with a ischemic burden of 25%. And we have a JC2 score 4, and what calls our attention is the severe calcification in the ostium in the all coronary, on the all right coronary, and this is very tortuosity. And it was an uncrossable proximal cap case with the micros couldn't cross, balloons couldn't cross, IVUS, turnus, everything was not able to cross the CTO ostial lesion. And here we're going to show the angiogram. This is the left coronary artery. Everything is closed. LAD is closed. Circ is closed. RCA is closed. Here we are showing that there is a big septal ramus but sending not good collaterals, very thin collaterals, and this is the saphenous vein graft to LAD that was good, showing good collaterals for the PDA. And here's the saphenous vein graft to marginal ramus, showing collaterals for the PL. Here is the right coronary artery, totally occluded in the ostium, with a lot of calcium, a lot of tortuosity, a long lesion, and we decided to start the case. And as I said before, nothing passed, tornos, micro balloons, IVUS, nothing. Just the rotor wire that passed for the subintimal space in an uncle fashion. And we tried with rotablation. We used 1.5 bursts to try to modify the plaque and try to advance more the wire. Here is the rotablation being passed in the subintimal space, trying to modify the plaque, trying to break the calcium. And with this, we were able to advance more the wire until the mid part of the RCA. As you can see here, the wire is subintimal space, but that's okay. It's perfect for the reverse cuts. And we did the reverse cut here with a balloon 3.020 guideliner assisted. And here you can see the retrograde wire enter in the guideliner, and after this, and after entering the guideliner, as you can see here, the wire entering, the case was done. Then we put three stents in this coronary, all the PDA and PL open. And take home message is, PCI still face some challenges. One of the worst case scenarios is an uncrossable proximal cap. There is a lot of techniques to try to overcome this problem that are base, side base, AGR, AFTR, scratch and go, knuckle wire, Carlino technique. But if you can't cross with any device the proximal cap, you can do nothing. And the only way that we found in this case, it was a bailout strategy, was to put an rotablation in the subintimal extra plaque space to create the sections, modify the plaque, and make it able to advance the antegrade wire. Even if in the extra plaque space, it was important to make the reverse cut in retrograde technique to finish the case with success. Thanks for the attention.
Congratulations, Marcelo. Do you prefer speaking in English, or we can do it in Portuñol? Marcelo, do you hear me? Me parece que Marcelo parece que no está presente.
I think Marcelo is not online.
Marcelo?
Are you there, Marcelo?
No, desgraciadamente parece que no está.
Unfortunately, he's not present.
Bueno, entonces continuaríamos.
So we should continue with the last presentation. Who's the presenter is in the same group, so probably we could ask the questions to Luis. This is a group from Florianopolis. and it's about contouring the subadvential space, treatment of an uncrossable long chronic total occlusion using excimer laser atherectomy. Por favor.
Hi, my name is Dr. Danan. I'm from the Heart Institute in São Paulo and currently in Cleveland. And we are going to present this paper that was performed in Florianópolis, Brazil by Dr. Marcelo Arada Ribeiro. And the title is Conquering the Subadventitial Space, Treatment of an Uncrossable Long Chronic Total Occlusion using excimer laser atherectomy. I don't have any financial interest for this presentation. So the background is that although excimer laser atherectomy is a well-established method to treat intrastent stenosis and fibrous plaque and crossbone lesion by standard balloon dilatations, its use is rather controversial in CTOs, especially when applied out of the intimal plaque when the uncrossable segments ahead of the subintimal space. So I describe here a 68-year-old male with known diabetes, hypertension, and dyslipidemia that was referred for our center for exertional angina and positive stress myocardial scintigraphy, revealing severe reversible inferior myocardial hypoperfusion with an ischemic burden of 32%. The echo showed preserved left ventricular ejection fraction of 50% with moderate inferior hypokinesia. The angiogram revealed a non-significant diffuse disease of the left coronary system with a complex long proximal right coronary artery, CTO, a CTO score 4, and collaterals, Renthrop grade 2, and Werner classification CC1 from the septal branches. So here we can see this RCA with this chronic total occlusion type 4. So the procedure was done with a CTO PCI to the RCA that was then indicated and planned. So initially the integrated approach was attempted, but by using an anchoring balloon technique in the proximal part of the RCA and assisted by a turnpike LP microcatheter, a wire escalation from the soft feeder to the stiff Conquest Pro 12 was performed to penetrate the proximal cap and to reach the CTO mid portion. But due to the long CTO fibrotic plaque and distal cap ending into a bifurcation, a retrograde approach technique was applied without success, trying to cross the septal collaterals by a Sion black wire. Thereafter, a rescue integrate dissection reentry strategy was applied, so a pilot 200 was advanced into a knuckle fashion into a submental space, reaching the distal cap, and at that point, a Conquest Pro 12 was successfully re-entering the true lumen in the posterior lateral ramus. But however, no balloon was able to be advanced thereafter. Thus, laser with simultaneous saline flush injection with a frequency of 80 and a fluence of 80 was used successfully. So to design a workhorse wire was advanced into the posterior descending artery, followed by a non-compliant track balloon, 25 by 20, and the dilation followed by stenting was performed in support by extension guide wire guideline. So here you can see that when we could cross the CTO for the RCA using a knuckle technique, and here you can see the laser being applied to that CTO lesion. And after that, we could use a microcatheter to exchange the wire for a new one, and we implanted 3 drugulate stents with a good angiographic result. The intravascular ultrasound showed that the wire went through the subintimal space initially in both mid and distal RCA with appropriate debulking of the subintimal lesion, and then re-entering near the bifurcation with optimal stenting result. The patient was discharged on the next day successfully, and this is the final aspect of the coronary RCA, a huge coronary artery after the procedure with the CTO technique and the laser application and the 3 stents that were implanted. So this is a very didactic example of what happened to this case, exactly this case. So initially, we had this IVUS image showing that the IVUS scatter was in the subintimal space or extraplaque space, whatever you want to call this. So we can call it subintimal, but the more modern nomination is extraplaque space. So here you can see the IVUS scatter. And this is a very nice picture showing what happened after laser atherectomy, where you can see there's an opening in the connection between the true lumen and the subintimal space. And this is the final result after the deployment of the stent with a great lumen area, great lumen diameter, and a good expansion. So very direct. I was in the subintimal space after laser atherectomy and after the implant of this stent. So the discussion in this case, the absence of severe calcifications and the concern about the risk of the burn entrapment within the resistance zone could explain why the laser might have been chosen rather than rotation atherectomy. And to the best of our knowledge, this is the first reported case of intended use of laser within subintimal space or extraplaque space to overcome the uncrossability of the CTO lesion. And this maneuver had never been tried before and was safely and successfully performed with this CTO PCI attempt after the failure of other techniques, including the retrograde technique. We conclude that we report on a successfully recanalized RCA CTO treated with advanced techniques, including laser in the subadventitial space to overcome a CTO uncrossability. And the laser in the subadventitial space or extraplaque space should be considered only when other stresses have failed. However, it could be used as part of the armamentarium of the CTO operators. Thank you very much for your attention.
Thank you so much. Are you here in the panel, Dr. Dallan? Me parece de que no están ninguno de los dos que han presentado.
Unfortunately, neither of the two presenters are here. Just a comment, these two cases are extremely challenging. And both are bailout techniques, so they can be discussed. If they could do this in all groups, these kind of procedures, I would have loved to ask them how many cases they have done in CTO. I'm sure they have a lot of experience to have introduced these two techniques. The first one, having a subintimal dissection in case of a possible perforation. Well, it's a patient that, due to the characteristics that they showed, it was a patient that had already prior surgery. He had peripheral kidney failure. Any type of complication in these type of patients could be really deadly. And in the second case, treatment with the laser, excimer laser, we saw that technique in many courses, and in the instant restenosis, some hydrocalcic lesions, but the truth is that it's an exceptional technique, and they describe it as bailout. I'd like to hear other opinions from the panelists. I really don't know. I would have liked to do it with optimal access, because if not, they can do any other D-base or a support catheter prolongation. I think it's risky, especially going subintimal, but I don't know what the criteria is that they used in this type of procedure. I think it's more of a risk than a benefit. That would be the question. Honestly, it's the first time I hear that, subintimal with ELCA. I agree with you. I agree with you, especially in a right coronary artery, to have that kind of risk with the possibility of a coronary rupture. In both cases, it seems like a lot, rotablator as well as laser. But it would have been nice to see the cases that they have in CTO, because it must be important, because that's why they take those chances and they have started to take those risks. I want to ask Jose Abelardo Lopez in Venezuela, are you using this type of technology in CTO, in total complete occlusions? He's on mute. He's speaking on mute. Abelardo Lopez, can you hear me? Sorry, I was on mute. In Venezuela, what we have is microcatheters to treat CTOs, but in some centers we have rotablator. We don't have laser. I think here the important thing is, in the cases that they have where they have done this subintimal, what was the percentage of patients that did ruptured of the artery? That is an important piece of information in order to make a decision. I think, for me, it's very risky for the outcomes, the good outcomes that we might get in these type of patients. Pedro Gallardo, any comments? Yes. I think that's very important what my colleague just said, that the subintimal dissection, especially in the right coronary artery, I did something like that more than 40 years. I did subintimal dissection in a right coronary artery, and I solved it in the same OR with a catheter, and I solved the problem. But then there were subintimal dissections always because of the cases. What I do, in fact, is to follow up with an echocardiogram, and in 2 of those patients, in those subintimal sections, I had hemorrhage. So I don't know if I would do it as a common practice. And then laser, only in those patients, as you correctly said, Francisco, that is mostly back in history. We know now that total obstructions that are not easy to dilate could be used, but with the values that are available these days, the different techniques that we currently have, that honestly is solved. Alberto, I'd like to know what your opinion is, your final opinion. I don't do chronic occlusions, but from the point of view of the epidemiology, I think these are cases that are interesting, but anecdotic, more than a behavior to do usually. And we should see, as the other colleague said, what type of CTO cases, how many they have in those cases, and that's why they are more aggressive. But so far, they are just anecdotal cases. I don't do CTO, though. Thank you very much. Thank you, Alberto. I'd like to ask, finally, to Dr. Lopardo. Is he still here? Yes. I wanted to ask you, all of these things that you showed are about these new systems, the Philips system, Envision, that does the integration of all these images, and it gives you all this information that you have in your lab. This system is a system that right now, I imagine, is not that frequent in all the labs in our countries. I want to know about the costs, the software costs, and all the implementation costs. Well, in terms of costs, I'm unable to tell you because I don't know. I don't have access to that information. The Philips system, what it has is the new equipment, the Azurium. It's integrated in IFR and IVUS, and it's a separate software that is paid separately. I don't know the value of the Philips, the cost of the Philips software, but usually the restrictions that there are is the authorizations for the IFR wires and the IVUS wires. That's a restriction that we have, I think, in Argentina and worldwide. In general, there are many restrictions, especially in the wires, more than in the equipment itself. But I don't have the values because I don't know what the costs are. But once a year, we have an IFR and IVUS workshop, and I have Social Security representatives, and IFR helps to cut costs, showing that we decrease the hospitalizations. And these, you know, if we put on the balance the costs, we can continue using it. But the values, the actual costs, I don't have them. Okay, I think we are now at the end of this session. It's almost 4 o'clock here in Santiago, and for you, 5 o'clock there in Argentina. And the last thing I'd like to say is thank you for participating in SOLACI-CACI 2021. My congratulations to the organizing committee, especially the president, Aníbal Damonte, Alfredo Rodriguez, president of the scientific committee, for the invitation and the opportunity to, to have us all here together and sharing in these difficult times, sharing all this academic information. All my best to all of you, and I look forward to seeing you face to face when the virus allows us. Thank you very much. Thanks to the participants, to the panelists, for all your comments, and to the speakers, of course, for expressing and showing their cases in SOLACI-CACI 21. Thank you very much. Thank you.
Good afternoon. This is Dr. Robert Burson, and welcome to the joint International Andreas Grunzig Society and SOLACI scientific session. Dr. Alfredo Rodriguez invited us to present a brief 1.5-hour session to you that highlights the format of our society meetings. As you may or may not be aware, the Andreas Grunzig Society was founded in 1990 in honor of the late Andreas Grunzig, one of the founders of our interventional cardiology. This meeting and society has met biannually since that time, and also, in addition, every 10 years on the 10th anniversary of the first angioplasty. Our scientific sessions are conducted by the members, and the one thing all the members have in common is that they practice interventional techniques and have contributed in significant ways to our scientific knowledge base and/or the development of new devices and therapies for interventional cardiology, vascular disease, and vascular medicine. I will now pass over the podium to our co-moderators, Dr. Stephen Bailey and Dr. Cindy Grimes, who will now lead the 1.5-hour session on topics that we typically encounter with regularity and frequency as practicing interventionalists, but for which there's controversy and perhaps imperfect solutions or no solution thus far. Steve and Cindy.
Thank you, Bob. It's a great opportunity and great honor, actually, to participate with SOLACI-CACI, as you indicated, for this session. The sessions are positioned a little bit differently in that we present a problem and then look for our panelists to address that with solutions. Cindy, can I get you to introduce the first session?
Thank you, Steve. First session we have, let me just introduce the expert panelists because we're going to count a lot on these panelists. There will be a short presentation and then a large amount of the time allocated will go to the discussion. So in our panel, we have Carlos Caffrey, we have Gurig Elite, we have Jose Luis Lazarte, Gabriel Melinda, Oscar Mendez, Gustavo Jamaga, Pablo Stutzbach. And it gives me great pleasure to introduce our first speaker who will discuss this topic of PCI and TAVR, which lesions and in whom. And this will be given by Marco Wanstein from Brazil. Marco?
Hello everyone. Can you listen to me?
Yes.
Can you hear me well?
Yes.
Okay, so let's get started. So let me just first say that I'm very happy and appreciate a lot this invitation. It's been a pleasure to be here with you, especially with some good friends like Bob Bursin, Alfredo, Cindy, and all the others. I've been missing our travels. Last time we've been together, I think it was in New Zealand. I can't even remember, but I think everything will be going back soon to its almost normal. Okay, so let me share my screen. Okay, this one. Can you, and please tell me if you can see the slides. If you can see my presentation now.
Yes, we can see it.
You can see it? Okay. So in the next, I think 25-30 minutes, we're going to be discussing a very controversial topic. I've been trying to, we do TAVI almost every day now. Last night when I was finishing a TAVI here at the hospital, and the patient had coronary disease, not the one that I'm going to show tonight to you, but I was realizing that this is something that happens to us, I think, almost every day. The patient that I just capped before the primary PCI, it was a patient that came for a calf before TAVI. So this is something really very common, and we don't have a whole answer for this. So my plan here, Rob, Bob and Cindy, is to discuss, and Steve, with you guys and see what's your opinion about this topic, okay? Let me just put this here. Okay. So I think we have three remaining uncertainties and opportunities here in terms of TAVI. One is bicuspid valve. The patient last night was one of bicuspid valve. It's always a lot of work to discuss the anatomy and to choose the right and the correct size of the valve, and there is a lot of issues with bicuspid valve. The other, I think, I wouldn't care much now about moderate ES, but I think concomitant CAD, which is our topic tonight, is really something that puzzles a lot because it's frequent, and we don't have the whole answer for this, how to manage patients that have both CAD and are candidates for TAVI. So let's start with some concepts first. We have to bear in mind that aortic stenosis and coronary atherosclerosis are something that happen together very often. The incidence, for example, of CAD in patients with severe AS can reach up to 65% of patients when they are older than 80 years old. And the prevalence of CAD in patients undergoing surgery also increases, not only with age, but also with the presence of the valve of calcification. So those two things, the age and the valve calcifications, they both determine the chances of the patient have also coronary artery disease. There is also another very important concept that we have to understand, that patients with severe AS, they usually have some very important diastolic dysfunction, and microvascular dysfunction happens a lot with diastolic dysfunction. And this impairment in coronary flow reserve that is due to the impairment in the microvascular function also is responsible for adverse outcomes, LV dysfunction, and develop symptoms. So it's kind of tricky to determine the severity and how important is the CAD in the patient with AS, because it also has some microvascular dysfunction, and it's some kind of difficult to determine what is determined by the CAD itself, and what is determined what is being caused by the microvascular dysfunction. And we have to first also to understand why to treat coronary disease with AS. PCI has been performed infrequently in patients with severe AS and CAD. It used to be, at least. Okay, unlike the combination of surgery and coronary revascularization, CABG, and surgical aortic valve replacement. We know perfectly well, this has been very well determined, that the combination of surgery, okay, surgical valve replacement plus coronary artery bypass graft increases the mortality, in-hospital mortality. Of course, if you have an STS of 5% for a CABG, and you're going to have both CABG plus AVR, you're going to have 10% of chances of complications. But this is in-hospital complications. When you fix the coronary artery disease in patients that have both CAD and aortic stenosis surgically, you do that. The patients who have their CAD fixed, they do much better than the ones that they don't have their CAD fixed. So this is what happens with surgery. You know, when you fix both, increases in-hospital mortality. You look here, but it decreases long-term mortality when the CABG is performed together with the valve replacement. It's also very well known that for patients being submitted to TAVI, or TAVR, as you want to say, the presence of CAD is associated with a higher mortality. So it's something that is frequent and is associated, it determines adverse prognosis for patients that have both. Also for patients that are being submitted to TAVI. But that doesn't mean that treating or fixing the lesions by angioplasty, by PCI, it will reverse or improve the prognosis, as I just showed here with surgery. We don't know if this is exactly the truth. Actually, it doesn't seem to be exactly the truth, probably because of the microvascular disease that carries together. We don't know exactly how is the relation with the syntax score or the anatomy complexity of these patients. It seems in some studies, in some works, that the higher the syntax score for patients being submitted to TAVI, or the higher the CAD burden evaluated by the syntax score, the higher the mortality. But all the analysis, they did not reproduce the same data. So the impact of the syntax in patients with CAD being submitted to TAVI is not something that is very well documented as well. There is a meta-analysis, but a meta-analysis of bad studies, it's something that one cannot rely very well. Okay, we have the activation study that was just recently published and presented at PCR 2 years ago, and it's probably one of the only randomized trials. All the others are small randomized trials or non-randomized trials, observational studies, but this is what we have. And the primary question is, does PCI prior to TAVI improve outcomes? So we have this meta-analysis of 11 studies, roughly 5,000 patients who had CAD and were being submitted to TAVI. Okay, there was no benefit in terms of preventing MI, long-term prevention of MI, and also no benefit. Look here, only TAVI and TAVI plus PCI. No difference in terms of outcomes. Actually, there was a benefit for TAVI only, but this was not significant as well because the interval reaches 1, is 0.92 to 1.52. So it's not the term if doing PCI. We do it every day. I have to confess to you that most of the time when we fix lesions in patients being submitted to TAVI, but we don't know exactly if this is the right aspect, right? So PCI has been traditionally performed for one of the following reasons. The clinical presentation, if the patient is thought to be at high risk of both surgical and TAVI, and also this role of aortic stenosis in patients with CAD, the symptoms we cannot exactly differentiate if the symptoms come from the CAD itself or it comes from the aortic stenosis. The other thing, so okay, let's do it. We're going to fix the lesion before for the patient with TAVI. Should we do it prior to TAVI, concomitant to TAVI, or after TAVI? There are benefits, pros and cons for every situation. Usually we do it prior because we want to reduce the risk of the contrast and nephropathy. We don't want to mess with the patient when it's being submitted to TAVI, but there is some offsets of doing this. So we don't know exactly when is the perfect timing, although most of the time we do it before, we fix the lesions before TAVI, a few days before, in the vast majority of the cases. Another thing that I want to point here is the surgical risk, okay? There is a difference when the patient has intermediate to high STS and it's being submitted to TAVI. And this is most of the patients probably in your practice, but it's not every day and not always. We've been performing TAVI more and more often to patients with low surgical risk, okay? So if the patient has intermediate to high STS and it's a candidate for TAVI, it doesn't matter how complex I think this is my opinion, okay? This is not something that I took from the internet. This is my opinion. So if the patient is a candidate for TAVI, because it has, doesn't matter if it's because or not, but it has high STS risk for surgery, if you decide to fix the lesions, it's going to be PCI, okay? You won't change your mind and say, no, this patient now, because it has a high syntax score, I'm going to send it back. Let's forget about the TAVI and put the patient back to the surgery because it has a high syntax score. Because as I just said in the beginning, if you have one risk for TAVI and you add the risk of a concomitant CABG in the same procedure, at the risk of the combined procedure, it's going to be twice as high or sometimes 3 times higher than one surgery only. But this is not the case. That happens to patients with low surgical risk. If you were about to perform a TAVI and a patient who has an STS of 1%, and we are doing this every day, we have data for this, and there is probably TAVI in patients with low risk is even better than in high risk. We have meta-analysis, and we have the Partners 3 trials and others showing this. And this patient with 1% STS or 2% STS has a very complex anatomy. Well, then let's say a syntax score greater than 32. Then you might say, okay, let's change the idea, and the patient goes for CABG plus surgical EVR. So you have to bear in mind what is the risk of the procedure, also not only the anatomy. That thing about determining the predominant lesion in patients with severe aortic stenosis, in my opinion, if you're going to use or try to use FFR or IFR, I think there is a trend of doing this. What I can say to you, and again, this is my opinion, we have no data. We don't have a cutoff for any numbers, just because the microcirculatory function is so well affected by the aortic stenosis that we know that if we fix the aortic stenosis, and this, for example, in this study, the patients had their lesions only fixed the aortic stenosis. After fixing the valve, The IFR, there was about there was a roughly 0.8, 0.85. It was below 0.9. It improved. It changed to greater than 0.9. So probably the number, if you want to use IFR, because IFR is less affected by microvascular function when compared to FFR. If you want to use IFR, probably the number to determine the severity of the lesion is something around 0.74, completely different than the usual 0.9. Okay, look at here to this work that when you look to the numbers for FFR and IFR, when after replacing the aortic valve, they both change IFR and FFR. So it's the changing the valve, replacing the valve itself has a lot of impact in the IFR and FFR. So we don't have, although this is the most recent paper about this topic, you know, it was a paper very recent published in Eurointervention, and they say here, look, they put the prevalence of CAD in TAVR patients. We already discussed that, and they said that the future perspectives that we should consider FFR and IFR, promising preliminary results, but very preliminary. The use of CTA that it's now is mandatory, and no patients with TAV is being submitted to TAV without a CTA. But the problem of using CTA to determine severity of stenosis in patients with TAV is the calcification. The resolution, the accuracy of CTA for those CAD patients, for those TAV patients is very low. Very seldom you're going to be able to say, okay, CTA was completely normal, no calcification, and the patient is okay to go and has no lesions. Most of the time, the CTA will show some lesions, and the calcification won't let you know exactly the magnitude of the lesions. And finally, coronary access. This is probably the main reason we fix the lesions, right, before TAVI, because we are always afraid that if you don't fix the lesion before TAVI, we're going to have a lot of trouble to access the coronary later. This is not exactly the truth, especially with the balloon expandable valves, like the Sapiens 3 and all the valve, the Indian valve. Just the name came out from me. It came back. That have very large cells, but also with self-expandable valves, we can manage to have some commercial orientation. Now, the way we implant the valves, very seldom we don't have access to the coronary. So when you say, okay, I'm going to fix this because later I'm not going to have access, this is not 100% true. Although many studies show that the access is not the same, and the patients who develop unstable coronary disease after TAVI will have longer time to treat their coronaries because of the difficulty to assess the valve. So what is the possible approach to manage coronary disease in patients with TAVI? No obstructive CAD, of course, TAVI alone. If the patient has definitely obstructive CAD, and the lesion is in small vessels, is a CTO, very complex PCI, severe renal impairment, and no principal. This is my main thing. No significant proximal disease, probably TAVI alone as well. But if there is a lesion in a proximal tight lesion in the LAD or in a very large circle or right coronary, there is an acute coronary syndrome. Probably this is the main indication or evidence of large volume of ischemia. What we do nowadays, at least in my practice, is PCI prior to TAVI. Okay, so finally, we're just getting to the end. This is a patient with 89 years old. He presented with progressive angina, class 3 congestive heart failure, chronic kidney disease, creatinine impedance of 45, severe COPD, STS score 9.8%, severe ES, the aortic valve area 0.7, and the mean gradient 48. Ejection fraction was in the average of 45%. So hopefully you can see the slides. This is the anatomy. Very tight lesion in the circ, very calcified, chronic occlusion of the right coronary. Okay. Sorry, let me go back here. And a very, very tight calcified lesions in the LAD coming from the proximal part to the mid part of the LAD. Three vessel disease, tight lesion in the circ, very tight and long, diffuse calcified lesion in LAD occluded right. And severe ES. Options, isolated CABG plus surgical valve replacement, isolated PCI, and or PCI plus TAVI, and then in which order? First PCI, or at the same time, or after? Should we stop here, Bob, and to discuss, or should I show what I did?
Yeah, I think at this point, we should open this up for discussion of this case and then the topic generally. Marco, you've done an excellent job summarizing a very complex topic that has, it really could be 3 or 4 different lectures in one, you know, as far as the
exactly.
subtopics in this.
Too long, but it's not easy. It's to cover all this topic in one lecture.
Yeah, it's a tall order. So why don't we open this up and ask the panel, work down the panel, what would you do here on this case? Would you do PCI at all? And if so, would you do that prior to TAVR or with TAVR, or would you refer the patient to surgery? Let's go down the line and get some discussion going.
Bob, this is Oscar Mendes. I fully agree with you. Mark did a very nice review or overview about everything on the topic. This is also a very interesting patient. In my hospital, I would treat this patient with the PCI first. I would approach only the LAD and the left circ. And I would not treat the right coronary artery. It's a very old occlusion. I think it's not necessary to revascularize this vessel. And then probably 3 or 4 days at least after PCI, I would do TAVR. This is a very complex PCI. I don't do regularly. I don't do PCI the same procedure of TAVR, especially for very old patients with deteriorated renal function. And even in a single lesion, because I have had some experience of a very short lesion in the right that I end up doing a rotablator and so on, and wasting a lot of contrast media, which is not good for this patient. So to sum up, I go to PCI for the 2 branches of the left, and then TAVR.
You know, this is Ramon Quesada here. That was an excellent presentation. And I
cannot see you, Ramon. I just don't see you. Okay. I can listen to you, Ramon, but I don't see you. But anyway.
You don't see me?
I can see you on the sidebar.
Okay, it's in the sidebar. I'm sorry, Ramon. Nice meeting you.
So that was an excellent presentation, and really is the question that we all have. But we're not going to know more until we complete the study, complete TAVR, that we're going to know the answer. Did you do it before, during, or after? But what we do today is exactly what was mentioned before. Is depends on the symptom. Is the patient was symptomatic, have angina, and has also CHF, probably a combination of both. We will tackle the left coronary system, definitely. The use of shock wave, which is not an atherectomy, combined with balloon angioplasty, if possible, really have changed the way we look at complex lesion. Because if you modify the calcium structure, it makes the procedure simpler. And now this complex lesion, we can tackle it with a balloon angioplasty to put the shock wave balloon, and then we can expand the lesion. So the LAD and the circ, I agree with you 100%. That's what we would do, and probably, and then defer TAVR for 2 reasons. Number one, because the patient already has a kidney disease, so we don't want to precipitate a worsening of the renal function. So we'll wait for that a few days. But definitely we will treat the left coronary system, not the right coronary. I agree with 100%.
And now I'm more relieved, Bob, because they just passed with the patient. My fellow showed me that everything was fine and the LAD is fixed and the telemetry flow on the LAD. So I'm very relieved and I can discuss better. I was very stressed by the fact that the patient was at only with the fellow in the cath lab and he was trying to manage this acute environment. Everything is fine now. Okay, so thanks for also I agree with you both, but let's see what the others will say.
One question. Who will agree of performing valvuloplasty? Will you consider doing valvuloplasty before PCI in a patient with a low EF?
You were asking me or asking the panel?
I'm asking the panelists because it's something we will do, especially in a patient with a low ejection fraction.
The others answer. So Gabriel, thanks for your question. I wouldn't, to be honest with you. We are not doing this. In the beginning, when you have patients with severe dysfunction, left ventricular dysfunction or cardiogenic shock, or as a bridge to surgery or to TAVI, we used to do it. But now, because we do TAVI so fast compared to a balloon valvuloplasty, usually even without predilation, at least in 50% of the cases, it's usually faster and safer to implant a valve, transcatheter valve, than to do valvuloplasty. So I wouldn't, certainly not. But let's see what the others will say.
So, it's very interesting. And we used to do a lot of valvuloplasty, and today is rare. But in a patient with really severe left ventricular dysfunction, and you're concerned that you're going to increase the pressure to the left ventricle, we will use a true balloon, true flow, which allows you to do balloon valvuloplasty, and still you have better perfusion. But in reality, I agree. Today everything has been simplified, and I think we can definitely deploy the valve and treat the coronaries in a very efficient way. I mean, his ejection fraction is 45%, so that's the other thing that if the ejection fraction was 20, 10, 15, 20%, then I think we will consider it.
So maybe we could ask another question that was posed, not if you were going to intervene now, but if you saw anatomy that you were considering you might intervene later or might need a later intervention. Are there anatomic criteria that would impact what valve you would place? So is there something about the either annulus, STJ, that would influence your thoughts about your choice of valves, or does that change how you approach your valve if you're thinking you might have to intervene later?
So you're saying that to intervene later and to just I couldn't exactly.
No, not for this case. I'm changing the question.
Oh, okay. You're doing in another situation, another scenario. Okay.
Right. The third scenario you gave for patients where you may need to intervene later, and I'm asking, in the situation where you're thinking maybe I might need to come back, is there an influence of anatomy or other things that would change what TAVR valve you would do or TAVR procedure you would do at the beginning?
What I can say to you, Steve, is that just one second. Tô dando uma aula para os Estados Unidos agora.
Não, só para ele dizer que ele não interrompeu ficar na CO, tá? Mas deu tudo certo, a gente já lançou tudo.
Okay, obrigado. Sorry, my secretary. This is the sorry. This is the problem of in a Congress in the middle of the day in work. But answering to your question, which I think is a very good point, what I think is that if this patient, of mine that I'm presenting here to you, was for example, a 60-year-old guy with this anatomy, calcified lesions, complex LAD disease, chronic CTO of the right coronary, and if it has an STS of 1%, or 2%. And I was doing this CAF as a pre-TAVI diagnostic CAF. Maybe I would stop and say, okay, let's consider now if it's not the best for the patient to be submitted to concomitant CABG and surgical valve replacement. Okay, but this was not the case for this patient. So Bob, can I go ahead now and show what I did? Because I just, for a matter of time, I'm a little concerned about the timing.
Yes, we only have a few minutes left.
So. Okay, so let me show what I did. Okay.
Yeah, share what you did, and then.
Okay, so what I did, exactly what my friend, my very good friend Oscar said. Probably, I think I'm always listening to his advices. So that's what probably what I did, Oscar. We fixed the circumflex. It was a straightforward procedure, and to the LAD, what we did was this is a long diffuse lesion in the LAD. Was rotoblator. Okay, I'm a big fan of rotoblator. My threshold for doing rotoblator is very low because we do it a lot, and when you do it quite often, your threshold gets lower. And then we fixed with rotoblator, and we stented the whole LAD from the proximal to only the distal part we did not stent it. And then a few days later, the patient was submitted to TAVI. This is his annulus. The area was around 550. He has some calcification also in the sinus of Valsalva, a large sinus of Valsalva. Good access. Okay, now I'm trying to speed a little bit and go fast. This is crossing the valve. This is the valve being positioned. This is an S3. I think it was on a 26 size 26. We did not predilate because we didn't think it was too calcified, and then it was also not severely tight, the stenosis. So we implanted directly, and I think we also did not post dilate, and this was the final result. Very, very good result. And then to finalize, this is my very, very last slide. As the highlights, the impact of CAD in TAVI recipients remains controversial. I think we said this word today like at least 20 times. And no definite data exists on the most appropriate revascularization strategy. The use of CTA, I disagree, but I have to bring it because it is in the literature. I don't rely on CTA, but the use of CTA and hemodynamic assessment to guide pre-TAVI revascularization will likely increase in the coming years, but I don't think that both can be very used nowadays for the reasons I already explained. And the management of coronary events occurring after TAVR, including coronary access, requires further investigations. Thanks a lot.
Okay, very nicely done. Just briefly, Cindy and Steve and Marco, you summarize this and distill it down. What I'm seeing, just briefly, is that we're moving away from any attempt to do complete revascularization in the TAVR patient, especially prior to TAVR, and you're just going to revascularize large epicardial arteries that are responsible for large areas of ischemia, not chase branch vessel disease and small vessel disease, et cetera, if you are intervening. And then the other thing is we're intervening a lot prior to TAVR rather than after TAVR for it's seemingly reasons of access more than anything else. Maybe that's not true, but if the patients have an acute coronary syndrome, sure, but the vast majority of TAVRs are elective, they're chronic stable patients, they're not unstable angina patients. So if we had improved access with our TAVR devices, perhaps we'd be doing a lot of this post. Is that fair to say? And we'll see if we could summarize with Steve and Cindy if they agree, and where do we go from here as far as getting actual scientific data to guide us.
Now, I think I agree with the summary that's been stated so far. I'm struck with how FFR is really not very accurate during these aortic stenosis cases, and perhaps IFR would be a better way to go. Given, the baseline increase in basically the LVH changes the baseline coronary flow. And so your FFR may not be that accurate. But I agree with everything that's been said. I think that CTA, there is definitely a role for that, but many of these patients have associated heavily calcified coronaries, and so it's very difficult to determine coronary anatomy in that situation.
So I agree with what's been said, and I would echo the fact that I think we need more investigation, and we have a couple of trials underway that hopefully are going to give us better information about timing of intervention and exactly how much ischemia is going to benefit, or whether it will benefit at all. So we look forward to that as one of the follow-ups.
Great, thank you very much. I think now we move on to the second topic.
Okay, Steve, do you want to introduce Bill O'Neill, or would you like me to?
Well, I'll be happy to. I think it's easy because he's a man who needs no introduction. So Bill O'Neill, who has led us in so much of cutting edge technology, we're going to have looking at what is, I think, one of the most exciting areas, and that's the role of interventions in heart failure. And joining him, we'll have just an outstanding panel of discussants, including Marcelo Aguero, Alejandro Berlotti, Jaime Francesca, Sergio Paroni, Ramon Quesada, and Ernesto Torresani. So, Dr. O'Neill, we look forward to your positioning the question for us and allowing the panelists to help us think through about where we're at and where we need to be.
Thank you very much, Steve. It's a delight to be with all of you today. You'll have to tell me if you can see my my screen yet.
Yes, yeah, we can see it.
Okay, so I was asked to sort of help for the SOLACI folks at the Grunzig meetings. We get together a small group of people who are great friends and experienced interventionalists, and we come up with new concepts. I remember 1992, Antonio Colombo discussed using high-pressure balloon inflation so that we wouldn't need to use Coumadin after coronary intervention, and that was absolutely mind-blowing. And we've shared many other amazing interventions. We saw the first use of shockwave, so we heard about that before it was being used in Australia by Ian Meredith when we were in New Zealand meeting. So that's kind of the flavor, and we certainly hope that many of you can join us in the Dominican Republic to share this. And so I was given kind of a broad portfolio, and I just want to share something new and exciting that's just kind of hot off the press, and I thought all of my friends here would really appreciate this. So this is something that we're doing now, and it's a case, and my colleagues, Dr. Pedro Villablanca and Pedro Gonzalez, were the ones that did most of the work here, but I want to sort of tell you what this is about. So normally when you do ECMO, extracorporeal circulation, you take blood from the venous, from the SVC and IVC, pull it out, put it into the ECMO machine, and then arterialized blood is inserted retrograde into the femoral artery. This is femoral bypass. We've been doing this basically since the 90s with what we called in the 90s CPS. The biggest problem with doing this is that when you put in blood retrograde into the aorta, you markedly increase the afterload in the ventricle, especially if the ventricle doesn't eject, because the ventricle will then start to dilate, and over a period of time, this causes severe left ventricular dysfunction and sort of irreversible heart failure. So we've now started this. You all know that we've been doing a lot of work with Impella, but this is actually a very interesting and new approach, and it's something that I think is going to bear a lot of interest in the future. So let me tell you about the case, and I'll sort of set the case, and then maybe have folks sort of weigh in on what they would do. So this is a 51-year-old man, so absolutely, completely viable, salvageable, and we're going to do whatever we possibly can to get this man through the hospitalization. He had 48 hours of chest pain and short-ling dyspnea. He presented to an outside hospital where, as in the United States, when they were going to shock, they promptly had an intra-aortic balloon pump implanted. His blood pressure was 80, his heart rate was 60, and he had a 4/6 murmur at the cardiac apex with a diastolic component, pulmonary rales, The patient had had a previous surgical valve replacement with a root repair with a freestyle 20 millimeter root in 2010. So this valve lasted for 10 years. His troponin was elevated, his BNP was elevated, and his lactate was slightly increased. He'd been on hemodialysis in the past. He's obese. He had a sleep apnea, AFib, so the numerous comorbidities. So this gentleman was 51 going on 81. But regardless, he was now coming into our hospital in cardiogenic shock. If you can see, this is his LV function. You can see that the LV is frankly completely dilated, EF maybe 15%. Severe wide open aortic insufficiency. And in addition to that, you can see that the aortic valve is calcified. So it's both stenotic and regurgitated. And one of the leaflets was flail, and basically the patient had wide open AI. On top of that, this is his cath, and you can see that he's got a subtotal occlusion of the ostium of the LAD and disease of the major circumflex branch. So these are the hemodynamics: RA 27, RV 74, PA 75, wedge was 40. So if we take a look at and calculate a PAPI, the PAPI is about 1.5. So there is not overt RV failure, but right ventricle is straining. LVEDP is 35. His cardiac index is 0.96. In addition, he had a stenosis across the valve, and so he had a valve area of 0.53 with blood pressure of 80/30. So this is how he presented. And Bob and Steve, Cindy, I'd like to just ask the panel kind of, this is the overview. Young guy, we want to do whatever we possibly can, but he's got wide open AI, severe coronary disease, and is in cardiogenic shock. So I'm wondering kind of what strategies should be considered and possibly what support should be considered for trying to save this man's life.
We have a great panel, so hopefully they'll jump in here as well. So,
well, clearly you don't want to put a balloon pump in if there's severe AI. I would probably initially opt for an Impella in this situation.
Okay. Yeah, well, and I think you probably are going to need to talk about a broader strategy, given the AI and the volume in that ventricle. The support given his cardiac output with even ECMO or ECPella probably is going to be where you're going to be headed, because you're going to, even with ECMO, you're going to have to decompress the LV as well.
Right.
I differ a little bit on this. I think that definitely this patient needs supportive care before we do anything with the valve or with the coronaries. And I would use probably a tandem heart as a first choice, only because I don't have to cross into the LV. And if I have to oxygenate, immediately put him on a tandem heart plus oxygen, full support with oxygenation, and then tackle the coronaries and actually the valve itself.
I think that's a good point, Ramon, and we've actually done that with wide open AI. It's really, I don't know how the physiology, but draining the left atrium with a tandem is a very effective therapy, and you can get sort of 4 liters of flow. And in some patients with aortic insufficiency, we were trying to see if they survived or not. We've kept patients alive up to a week on a tandem, so that would be a very good approach. I'm a little dissuaded by putting an Impella across, because a 3.5 Impella is going to not really provide enough forward flow to help this man, and so it would have to be some sort of combination. So so let me sort of go forward then and show you kind of where the hemodynamics. So this is his right atrial pressure is 22, his RV pressure is 70/20, 70 PA pressure 70, and his wedge is 38. So he's in pulmonary edema, and he's obviously going to decompensate and need some form of oxygenation in the near term. His CPO is 0.4. So Ramon, does that do anything to you in terms of the approach? You guys think we should just go straight to ECMO or what?
No, I think you have to drain the left ventricle, absolutely, and you have to put him in full oxygenation, definitely. So that's what I suggested tandem heart, because a tandem heart, with the new variety, you can put them on, you can oxygenate it like an ECMO, and also you can drain the the left ventricle and then proceed with your revascularization and TAVR strategy.
So Cindy, are there any other panel that would like to weigh in?
Yes, I think that the Impala is a problem because you have a lot of calcium in the valve. I prefer the ECMO. Stabilize for some time the patient, and then you could decide what to do.
Yeah, Sergio, I think I absolutely agree with you on that, because we found that these calcified surgical valves, once they start to degenerate, they're brittle. They're like eggshells and also very brittle. So doing a manipulation other than putting a new valve in, I think is fraught with a lot of risk, and you could have embolization and cause a massive stroke. So I think that's a very good point, and a reason why probably I would, I'm a big Impella supporter, big Impella user, but this is one where we probably would avoid that. So let me go on and show you and further complicate matters. All right. So anyway, so this is now we did a transeptal puncture. This is the balloon pump tracing. So, they put a balloon pump in spite of the fact they had wide open AI and really didn't do a lot of hemodynamic value. Crossing the valve, he does have a significant stenosis. This was his LA and his LV. He had a V wave of 80. And LVDP of 45. So really in terrible distress with a small likelihood that he was going to survive. And honestly, when we started doing this case, we've got public reporting now for our TAVR programs, and I really wasn't sure whether we should even consider him because I thought he might have been too far gone. So we decided to support him and wait for a few days to see if he would improve. And so
what do you make of the lower left-hand tracing? Because, with severe AI, you would have thought that the diastolic gradient would be higher, or the diastolic pressure. So it's a bit unusual, isn't it?
Yeah, it is. And I think it's a combo of AS, AI.
Yeah, mixed.
So some of the valve is actually preventing a huge amount of regurgitation.
Right.
Mm-hmm. Interesting.
Yeah, it's probably it. So let me go on then. And so the combo so we basically discussed doing traditional VA ECMO, veno-arterial ECMO, or left atrial ventricular assist ECMO. Now this is sort of a new concept, and what we do is we do a transeptal puncture rather than putting the venous cannula into the SVC. We take the cannula and we put it across the intraatrial septum so that you're able to drain blood just like you would with a tandem, but also you're able to drain venous blood. And so you have an AV mixture of both arterial and venous blood that goes into the oxygenator and then gets put back retrograde into the descending aorta. And the advantage is that you're providing both right ventricular bypass and left ventricular bypass. Regular traditional ECMO is a very good strategy for fixing RV shock, because you basically drain the RV and then you put blood into the aortic circulation. So this does both. It drains the LV and drains the RV. And so this is the cannula. They're made by Medtronic and Edwards, and I have no financial interest in any of this. But it's not made for this at all. I mean, the companies are going to have to do a better job of making this stiff sheath here could easily puncture the roof of the aorta, so you have to be really careful with it. But in any event, there's 10 holes, and you try to put 5 into the left atrium and 5 into the right atrium. And so this is the technique. You bring a catheter across, transeptal puncture. And then with an Armada balloon, we do an atrial septostomy, and then we use the Armada balloon actually to place the cannula into the left atrium. And you can see here that once the cannula is placed, it's sitting across the left atrium. This is the pigtail, and you can see that there's basically torrential AI with the right coronary leaflet is basically completely gone. And so that's really basically the setup. Then you take blood, both LA and RA blood, put it into the oxygenator, then put it back into the descending aorta. And this is the cannula, so you can see where we are. Okay, so this is immediately after the procedure. LVDP went to 16. The LA pressure now is 13, and the wedges and the V wave went down to 20. So absolute dramatic decrease. In addition, the RA pressure dropped, the PA pressure dropped to 30, and the wedge was 18. So that really allowed him to, his cardiac output improved. The CPL went from 0.4 to 0.4. And so we did this on a Thursday, and we watched him over the weekend to see what he would improve. Serially, his lactate got better. His urine output was fine, and his PA pressure was down. He wasn't intubated, which is another great thing, because a lot of times with ECMO, you have to intubate the patients because they get white out of their lungs. And in this case, it didn't happen at all. So we had a heart evaluation. We wanted to perform a PCI, and going to the last lecture that Mark was talking about, you do it before, you do it after. I don't know what the right answer is here, but we thought that he obviously needed that osteo-LAD fixed and the circumflex fixed as well. So we decided to do rotational atherectomy of the left main, and then PCI, and then hopefully at some point do a valve-in-valve. So this is the angiogram, and again, this is on full support. Ventricle is beating. It isn't sort of ballooned out. It's decompensated. It's decompressed and it's contracting. And then this is after the left main LAD intervention, as well as the circumflex intervention. So all of the vessels were fixed. And then we didn't do anything further that day to, again, try to minimize the dye load and just, again, survivable to make sure he would survive before we were going to do the other complicated feature that I didn't tell you about is that, you can kind of see it. Look at how low his coronaries are. His coronaries are like 5 millimeters, and that's going to, require coronary protection. And so it was just too complicated to do it once. And so we brought him back to the cath lab. This is now the Edwards valve being placed.
Bill, can you go full screen on that? I think we've got the preview.
I don't know how to do that. I don't know how to do that, Steve.
Okay, all right.
Let me try to go forward then.
Right.
The valve is in, and then now, because of the low riding coronaries, we protected both the right and the left coronaries, and then implanted stents for coronary protection. So you can see the coronaries are widely patent, and the valve is improved. There's just trivial aortic insufficiency afterwards. These were the gradients after the procedure, and then we closed with both the artery and the vein with Manta devices, and so the patient actually did great. There was 2 millimeter gradient afterwards, and he was in the hospital for about a week, but subsequently survived, and now he's out about 2 months and is doing very, very well. So that's kind of one of the cases. We have gone on, and so this is again a summary of his hemodynamics. You can see that his cardiac output went from 3 to 7. His CPL went from 0.4 to 1.3. LA pressure dropped dramatically. Right atrial pressure dropped. Pulmonary artery pressure dramatically dropped, and wedge pressure significantly decreased, and blood pressure increased. So it was really an excellent sort of hemodynamic and clinical way of stabilizing what a patient that I just honestly don't think that would have been salvageable with the other sort of support mechanisms that we've had in the past. So let me just stop for a second, and maybe we can chat for a bit with the group about support strategies, and I can then at the end sort of show you, we've now done 13 of these cases, and I'd be happy to sort of, discuss with the group where possibly this is going to be going.
Fantastic case, Bill. I think the take-home message here is this is, of course, an extremely high-risk case, but the key to it was the AV unloading, right? The left side had to be unloaded.
Right.
And, tandem heart was mentioned, which also does that, accomplishes that. But every time it's mentioned, Ramon brought that up, it seems like there's very few adopters and very few interventionalists who are familiar with using that particular device. And your technique is one that perhaps is more familiar to people. I mean, people do ECMO and people do transeptals, and you combine the two, and perhaps the adoption of this approach will be greater as a result. But both techniques critically unload the left side, which is, I think, the key to the success of this case. One of the keys.
Bill, if I'm correct, so you use a catheter that is bigger with more holes, so you can drain both at the same time. You drain in the left atrium, like you do in the tandem heart, plus you drain in the right atrium. Right. You have more holes. That's exactly the principle.
Yeah, that's exactly the principle. So you're getting an AV mixture. So you can't just put it back in without putting it through an oxygenator. So the SAD is probably 70%. It's admixed. And again, this is just completely kludgy. It's just something that we've taken off the shelf. And obviously, if we can get industry interested, they'll make safer sheaths, and you'll be able to differentially pull blood more from the right or the left side. The other thing, though, that I think that we all have to really comment about with these support strategies is that the two biggest problem is not really the mechanics of either unloading the ventricle or providing support. The biggest problem is access. And we've seen in the cardiogenic shock initiative, if you have loss of femoral pulses that you don't quickly fix, is almost 100% mortality. And also with ECMO, there's the oxygenator you get at a price, and there's a lot of bleeding complications. And I think that there's a signal towards a higher incidence of stroke that we can't ignore. And so I think those are two really important things to really talk about, because these cases can be really ugly when they're fully supported, and they're losing their limbs and they're stroking out. And I think that we have to really kind of understand that a little bit better to try to figure out why those things happen.
Well, the third piece, Bill, that you brought up is at least in this case, I'd love to hear about your others, but you seem to partially protect the pulmonary circulation, and the hyperemia that happens there is, which I think is equally important in terms of the survivability of these patients.
Yeah, Steve, I think you're absolutely right, because when you put patients on VA ECMO, traditionally their lungs white out, and you say, well, that's just ARDS, and you're oxygenated, so it's not a problem, but the lungs are really getting flooded, and the LA pressures are dramatically increased because you're not removing the afterload. So I think this does provide that. It does provide both LA and RV unloading. And so in particular, as you said, the unloading of the pulmonary system, it's really remarkable that you can put these people on this combo without needing to be ventilated. This guy had this device in for more than a week and didn't require intubation at any time.
Yeah, the ventilation complications certainly are a major driver as well of mortality. So,
Steve, can I ask Bill a question?
Hey, Marco.
Hi, Bill.
You're a master of doing an acute MI and doing a
exactly. It was in your honor. We're doing the acute MI, no reflow, in your honor. What a coincidence, right? But let me ask you. It's always a great presentation. When I start everything to do what I'm doing to listen to Bill, it's always a legendary presentation. Thanks a lot, Bill. So it's a very simple question, at least for me. We don't have, I think, in Brazil, this option of decompression using this ECMO cannula to the left atrium. So probably what we tried to do here was was something like using a cannula, ECMO cannula to pulmonary circulation. Do you think this would be possible, or to doing only a septopuncture, or both? Instead of
these cannulas should be available, Marco. They're made both by Medtronic and Edwards, and I think that if you have ECMO capability, I would really strongly suggest you talk to the distributors to see if you can get those available. It's actually pretty. If you're comfortable doing transeptal punctures, it's actually pretty easy to do.
Yeah, we are.
The cannulas, but be careful with the dilator because you can't see it. The dilator is not radio opaque. And that's why we just bring the cannula up to the right atrium, take the dilator out, and then put the septostomy balloon across, and use the septostomy balloon sort of as a tracker to do a balloon assisted tracking to get into the left atrium. Mm-hmm. And then that's pretty safe to do.
Yeah. Okay, I see. Oh, very nice. I'm going to check. I'm here with Rodrigo, my brother, as you know him also very well, and he's responsible. He's listening carefully to your presentation, and he is responsible for our program of cardiogenic shock. And I don't think we have this cannula here, but we're going to check. They should be probably available, and we don't know it.
So, Bill, you gave us a teaser of additional numbers of patients.
Sure.
Can you give us the follow-up and what you're seeing?
Yeah. So far we've done 13 patients, and there are a variety. Again, this is just sort of a feasibility study. We're trying to figure out where we want to use this. I think as we suggested that biventricular support is really the reason to do this. And the patients, I think, have either moderate or severe left ventricular dysfunction. We've done some of these patients now, 5 of them with severe aortic insufficiency, and it really works very well to unload the left ventricle, which is really kind of surprising. I don't entirely understand the mechanism, but unequivocally, it unloads the ventricle with severe AI. We've done some cases with moderate severe aortic insufficiency, and some of those patients had multivessel coronary disease. These are the numbers, and it is consistent. You decrease the right the pulmonary artery pressure, you decrease the right atrial pressure, so you're decreasing the right-sided congestion. Creatinine decreases, which is very gratifying because patients on ECMO often have a deterioration of renal function. Lactate has gone down, pH is increased, and ECMO flow is about 4 liters. So, and then finally the SATs went from 51 to 73%. This is what happens, and we check carefully with, you have to put a second catheter into the left atrium when you're doing this, so that we've only done it in 3 patients, but you can see that in the 3 that we measured, immediately after the patients go on pump, the left atrial pressure dramatically decreases post-LAVA. This is the right atrial pressure again. This is drops significantly, and then the mean pulmonary pressure drops. So the numbers are small, but the trends I think are very favorable. The lactate decreases, and the serum creatinine decreases over time. So again, very, very favorable hemodynamics and biochemical factors. So we conclude that it's a fenestrated cannula. You need a transeptal insertion. It pulls blood both from the left and the right atrium, and indirectly it loads the left ventricle and the right ventricle. And that's really kind of the secret sauce to this. Rapidly unloads the heart, improves lactate pH, and then allows us to bridge the decision. These patients, as you can see, were just incredibly ill. 54% survived to discharge, and they basically had a 95% mortality with any other technique. And because of the use of ECMO and the large bore cannulas, blood transfusions were common. So it's not free of cost, but you can see that it does really provide some life-saving support for these complex multi-valve cases. In cardiogenic shock with both AS and AI, MS, and MR.
Did you have any? Were there any strokes?
Yes, we had 1 patient that stroked.
You know, Bill, one of the things that is amazing is that you will, in all these patients, you were able to keep the cannula for a long time without coming out. One of the problems with draining the left atrium and doing, in this case, both, is that you don't have stability in the cannula. So the patient has to be really flat and not move, because one of the problems is that they move in the ICU and the cannula comes out. The next time they call you because you have shock.
You're absolutely right. That's crucial, and we always put a board in the back of the knee so that the patient can't bend their knee, and the nurses can't bend their knee when they're rolling them. And so sort of has to be a log roll for nursing care. But you're absolutely right, Ramon, and that's where industry could help us. I mean, if they really took this on, they could put like a cuff that would hold the cannula in place so it couldn't come out of the left atrium, or it would remain stable once you positioned it. So it's something that we have to get their attention to, and I think that I'm hoping that we can.
Yeah, or even a more flexible catheter that you could steer into the pulmonary veins, huh?
Right.
That would
yeah.
So
Bob,
Always out of the box. Great, great concept here. Thank you so much.
Bill, did you see any cases of lack of oxygenated blood in the upper body?
It's that Harlequin syndrome that people talk about, or the North-South syndrome, and we haven't seen it yet. We're looking for it, and that happens primarily in people that have relatively well-preserved ventricular function, so that you're getting so the scenario is people that had really terrible lung function, and so they can't oxygenate, and so a deoxygenated blood is getting into the left atrium, and then it's getting pumped forward into the ascending aorta. And that's really the Harlequin syndrome. These patients all had well-preserved pulmonary pressures, and so they didn't have any intrinsic pulmonary problems. So they were probably getting arterialized, oxygenated blood into the left atrium that then would come forward. So even if they were able to contract, we didn't see that, Cindy. So I think that's another advantage, but it's absolutely, certainly for regular ECMO, that's a huge risk, especially if the ventricle is starting to improve and starting to eject and contract.
Well, it's brilliant. In the interest of time, I think now we need to move on to our final topic, which has no controversy at all.
Okay, so Steve, do you want to introduce Kirk, or would you like me to do that?
Go ahead, Cindy.
Okay, our next speaker is Kirk Garrett. He's a past president of SCAI, well known to all of us, and Andreas Grunzig Society regular. He's going to talk today about when to intervene post-arrest, raising the dead. And we have, again, several panelists here. I'd like to introduce Andre Boucheur, Mauricio Cohen, Dario Echeverri, Pedro Limos, Alberto Sampolisi, Fernando Scazuso, and Hector Vituli. Welcome.
Thanks a lot, Cindy. And let me start by adding my expression of gratitude to Alfredo, and congratulations to Alfredo and his colleagues for putting on another fabulous event. And it's a terrific pleasure and honor to be a part of it. I'm reminded about why I always dread looking at an agenda for a program and seeing that I'm following Dr. O'Neill to the podium. It's always such a humbling experience. And this promises to be no exception. We'll be moving from a lecture where we had an impossible challenge to overcome, and Bill clearly found a way to do that, and further provided us with data that looks like it's blazing the path for a long-term solution for all of us. I, on the other hand, will be presenting an evergreen, intractable problem, and I'm hoping that this group will be able to steer us all in the right direction. I'm going to launch my screen now. Tell me when you're able to see my slides.
Yes, we see you.
Okay, I'll go to presentation mode. Tell me, is that showing okay? I can't see.
Perfect.
Okay, terrific. So thanks again, everybody, for giving me an opportunity to be with you. In keeping with the Grunzig Society tradition, this will be a brief presentation. I'm really going to toss it to the panel for the wisdom. Here's a case. This is a young male, a 36-year-old individual, had no prior cardiac problems, frankly didn't have a lot of risk factors other than some family history of coronary disease. He did, however, have gastroesophageal reflux disorder and started complaining of reflux symptoms after dinner one night. It was distressing, but he was able to go to bed, go to sleep, woke up in the morning still having the discomfort. And shortly after getting out of bed, he collapsed. This was all witnessed by his wife, who happily was young, healthy, and knew a little bit about CPR. She called for help and started bystander CPR. Emergency medical services arrived. They found that he had a shockable rhythm, and he was shocked, which put him back into sinus rhythm. When he arrived in the hospital shortly thereafter, he was unresponsive, hypertensive, tachycardic, and you can see he was pretty profoundly hypoxic, had a pH of 7.2. His initial lactate was more than 7.5. It was concerned he might have had a stroke, which was reasonable. A head CT, however, was negative. This is his initial electrocardiogram. There are abnormalities on the electrocardiogram, but I think you'd agree that this doesn't meet usual criteria for an ST segment elevation myocardial infarction. So the dilemma we have here is a young man with an out-of-hospital cardiac arrest, now resuscitated, but certainly not recovering promptly, significant metabolic abnormalities, doesn't have ST elevation infarct criteria on his electrocardiogram. This is a common problem. We have approaching 400,000 people a year who present with out-of-hospital cardiac arrest. Now, many of them have ST elevation myocardial infarction as their presenting finding, and there's generally universal agreement that those people ought to go to the cath lab promptly, unless there's some reason not to take them. They have evidence of head trauma with intracranial bleeding or something. And I think we all feel comfortable with that approach. I'll note that even with that proviso, survival rate for these people is still exceedingly low. It is rarely reported to be over 10%. And of course, your probability of getting through is linked to the reason that you had your arrest. The infarct population in today's world actually does reasonably well. If it's something else that caused you to arrest, your odds of pulling through are not very good. And although we have general consensus about the importance of a trip to the cath lab if you present with an ST elevation myocardial infarction, it's interesting to note that we have almost no data to guide us for the remainder of the patients who arrest. That has not prevented the societies, including SCAI, from publishing recommendations, even guidelines, that suggest that an early trip to the cath lab should be considered. Again, in keeping with the tradition of the Grunzig Society, I'm not going to tell you what I did just yet, but I'm going to pause here, Steve and Cindy and Bob, and ask your thoughts about what to do for this patient. Young guy, not a hospital arrest, no STEMI, don't know why he arrested. No, he hasn't had a stroke or a major intracranial event that we can see on CT, and significant metabolic derangement.
So Kirk, we have a wonderful panel. I'm hopeful that they will share with us how they would approach the patient and give us, you know, a more global understanding of how this patient's going to get treated where they're at.
Kirk, what was the blood pressure and the heart rate at when he stabilized? Is he on pressors? Do we think he's hemodynamically unstable?
You know, he didn't require pressors initially, Cindy. He came in hypertensive, as I showed you, in tachycardia, which probably speaks to young adrenal glands, I would guess.
Right. Okay.
So, Oscar, Mauricio, what would you do?
Hi, Steve. Thanks for having me. It's a pleasure always to be with SOLACI and the Grunzig Society. I think you need to figure out. I don't think you don't have ST elevation in the EKG, so it's not like time is myocardium. In this situation, you can pause a little bit. The patient has a rhythm now, has a blood pressure, has a cardiac arrest, is intubated. So I think you can do an ultrasound. You can get blood work, and then you can figure out a little bit what's going on with this patient. So if this could be a PE, this could be many other host of different situations that could potentially have caused this patient to arrest. Mm-hmm. So I think figuring that out is important before taking a patient to the cath lab if you don't really have a little bit of more background information. If he is a patient that arrested and was in his usual state of health without any other major comorbidities, I think that I would lean towards taking the patient to the cath lab, but not before doing additional imaging studies and trying to understand why these patients are arrested.
Mm-hmm. Yeah, you bring up a very good point about massive PE causing cardiac arrest, and But I also think that every single cardiac arrest patient that I've taken care of, they have a EF of 10 to 15% after the cardiac arrest work, irrespective of their coronary arteries. And I just think there's an incredible stunning that occurs during the CPR process. So that doesn't seem to help me that much. But I suppose if you saw regional wall motion abnormalities, you'd be more likely to suspect coronary disease. But
So-
yeah, we can never forget about pulmonary embolus.
So it is of interest, and while I don't yet have data, I will say that we are engaged in an AI project looking at post-arrest EKGs to see if there is information that will help us further separate it out. The teaser is that preliminarily it looks like AI may in fact give us something that would add beyond our clinical assessment, chemical assessment and echo imaging. So I think there may be something going on there. But other members of the panel, would you go to the cath lab? Would you stop, assess, pause for a minute and try to better understand what's going on?
Yes, usually for example, in my hospital. I'm sorry. We use in my hospital in these cases is the medical treatment, the imaging, and wait 24 hours for evaluate the neuroprognostic for clinical, or use the different imaging or potentials in neuro for identify how is the residual brain to decide continue the invasive procedures give to the cath lab.
Buenas tardes, soy San Paulesi. ¿Cómo les va? Cindy, mucho gusto, doctor Renín. Mi opinión en este caso es que el paciente, justamente es el problema de estos pacientes por reanimado. ¿Qué conducta deberíamos tomar? Creo que este...
What should we do with these patients? I think this patient has a predictive balloon that is pretty low for coronary disease. So I agree with Mauricio that if he's stabilized, I would go to imaging, echocardiogram, maybe a CT scan to try to locate the etiology of his sudden death. That is probably not cardiological. Maybe it's not coronary. Sometimes it's difficult to know whether they have coronary disease. But the reality of this patient, without comorbidities, without any background in the family, it's pretty low for coronary disease. So for me, I would do complementary tests before taking it to the lab, to the cath lab.
Overall, people favor doing a little more evaluation of the patient before you take him directly to the cath lab.
Mm-hmm.
That seems to be the consensus.
Yeah, and
right,
and I would re-echo Cindy's concern about considering PE given everything else that you presented.
I know we're just about out of time. Maybe Steve, shall I just go ahead and show you what we did?
Yeah, we actually have a few some more time as well.
Yeah, you do have an extra 10 minutes or so.
Yes, we have. You have, Bob. You have more time.
But I think showing you what you did will probably result in some further conversation. So let's do that.
Sure. Well, the first thing I'll tell you about is our approach to these patients. About 5 years ago, there was a risk score published by a team from Paris that predicted your probability of surviving as well as your probability of having a favorable neurologic recovery when you present with out-of-hospital cardiac arrest. I know this is complicated and too much to read through. I'll just make note that the risk score tallies up points based on your age, where you arrest. If you arrest at home, that's riskier than arresting in a public place. If you initially have a shockable versus a non-shockable heart rhythm, the length of time between arrest and initiation of basic life support and return of spontaneous circulation. And then you also get high points for a low pH and the need for significant epinephrine or pressure support. In our case, we had a relatively young guy who arrested at home, but he had bystander CPR quickly, a shockable rhythm. But as you saw, some of his metabolics were unfavorable. So he had sort of an intermediate risk score. We like this risk score because in our population, we've been able to validate its precision in predicting which patients will survive and which will have an unfavorable or favorable neurologic recovery. The R score is about 0.8 for survival, shown here, similar for neurologic recovery. But that's different than answering the question of whether or not a trip to the cath lab is warranted. We stratified patients in our population over the past decade or so into three categories: those with low, medium, or high risk scores. Higher risk score portends a worse outcome. And as you can see, when we looked at outcomes stratified by risk score based on whether they had or had not been taken to the cath lab, we did not find a signal of benefit with early catheterization for those with lower intermediate risk scores. Those with high risk scores did have a trend toward a more favorable outcome with early cath. The point estimate was going in the right direction, but the confidence intervals were broad, and this did not reach statistical importance. I think this comports well with what we feel clinically. That is, if you have somebody who is perhaps like the patient I've described, young individual, some unfavorable, but not a ton of unfavorable risk factors. And as we heard from the panel here, the thinking is, well, a trip to the cath lab may provide benefit, but there are other things that come to mind that might explain the event. So I think that all makes good sense. I will tell you that my patient, in fact, went back to the CT scanner to exclude PE, exactly as I think Cindy called out, or Steve, I forgot now. Somebody presents with that degree of hypoxia, you have to be thinking about PE. It is unusual for PE patients with severe hypoxia to present with such significant hypertension, but nonetheless, that was done. His head CT was non-contrast. He went back for a contrast CT, no PE. What to do? Well, we elected to take him to the catheterization laboratory, not because we felt that it was going to be high yield, but because we didn't understand what was wrong with this patient. We had no good explanation. He did have a positive troponin result, as you would expect. Surprisingly, despite his young age, he in fact did have significant coronary disease. I'm not entirely sure yet how that related here. I have to assume it was related to his arrest. These are still images which I elected because I wasn't sure how the videos would display. You can see that the flow in his LAD territory is diminished. He had good filling for about 2/3 of the vessel, and then diminished flow, looking something like embolus, but it did eventually fill out the distal vessel. It was just slow, less slow in the circumflex distribution. So I was thinking he probably had intermittent atrial fibrillation and had thrown clot down his LAD, but then his right coronary artery actually had very significant coronary disease, and in some views, significant haziness, which may have been in situ thrombus formation around the time of his event, or could have potentially been a triggering event. That was treated with coronary stent. The more intermediate disease distally, which seemed not to be flow limiting, was left to be managed medically. So that's the story. That is what we did. I'm happy to hear that it was a terrible idea and that we should have done something completely differently. I can tell you he happily did recover well, including his pump function. He left the hospital with injection fraction of about 45% and no clear regional wall motion abnormalities. His neurologic recovery was also favorable, and he's come back to clinic several times now and is doing well on very intensified medical therapy for unexpected advanced atherosclerosis at a young age.
So Kirk, did you cath him the same day he arrived, or was it delayed at all?
It was only delayed by probably 2 or 3 hours, Cindy. In that interval of time, we'd done the work that I described. and powwowed about what could this be, and what might we be missing. No drug history, as mentioned, no other significant medical problem. The EP folks noted that his intervals were a little broad on his ECG, and we thought he might have some sort of channelopathy or other problem leading to an arrhythmia there. But his troponin resulted positive, and a second came back even further elevated, could potentially have been fully explained by his arrest. But we thought, well, this was now at about 9 o'clock at night. The team is all there. Let's just cath him and clear the air. It's a tough one, though, right? Because you don't want to do an unnecessary cath, but at least you feel comfortable that the risk of cath is relatively modest in a young patient.
Well, I agree. Eventually, you're going to cath this guy, right? If he doesn't have a pulmonary embolus, you need to cath him to make sure he doesn't have unexpected coronary disease. So I think that's totally appropriate. The only issue is, do you cath them acutely prior to determining whether they're going to have neurologic recovery?
Right. Yeah, and he had sort of an intermediate score there, so we were optimistic, but he wasn't out of the woods, that's for sure.
Yeah, and I would agree. I think you at that point with the troponins rising, that's a little above what you might expect given his hemodynamic status, and I think you're obligated to clear that. Sometimes you can get enough information from the CTA if they, depending on how they format that, but we would have done the same thing. I think timing is an issue, but it sounds like you had an overall good prognosis, and knowing whether or not he had coronary disease was likely to impact your therapy. And for me, that's the pivotal question is, will it change what I'm going to do as soon as I'm done with the cath?
Kurt,
Mauricio, I think had his hand up. Cindy, should we give Mauricio, you have a question?
Yeah, thanks. So I have a couple of questions. So one, you did a chest CT. So as Steve said, you could have seen lots of calcium there in the coronaries.
Yeah.
That's one. And second, did you go straight to the coronaries, or did you think about doing a right heart cath?
No, he went straight to coronaries, actually.
Did you?
That's a good point. Well, we were comfortable.
I mean, with a right heart cath.
Yes, go ahead.
No, with the right heart cath, you can entertain some other possibilities. I don't know. I mean, I usually find it useful to do right heart cath, especially if the patient has been hemodynamically unstable. But I guess the patient is not in shock any longer. But you can, it could be a yes or no for the right heart cath. I would have probably done it, but that doesn't mean that it has to be done, because you don't. This is a case where you don't have a right or wrong question.
Yeah, it's a great call out, Mauricio. I think in retrospect, I'm not sure why it wasn't done. But other than, had he been in shock, that's always the first move in my lab. But I think the setting at that point, he was hemodynamically okay, as mentioned, hypertensive, still tachycardic, but you were not, frankly, I think, anticipating finding significant coronary disease. We just wanted to settle the issue. I think the question about delaying the cath is a reasonable one for two reasons. Number one, even though he's young and had good renal function, not an optimal time to give him additional contrast if it can be deferred. He was not hypotensive though, so that didn't slow us down much. The other big impediment, of course, or consideration, is recovery of his neurologic function. And it's always just a tough call. Again, intermediate risk score, so we felt optimistic that, given his age, that he would have a good shot, and happily did play out that way. I'm quite confident that if he was 30 or 40 years older, coming in with that PO2 would not have anticipated such a favorable neurologic recovery.
Right, and the interesting thing is Mauricio brought up the coronary calcium. Basically, sometimes on the CTA for pulmonary embolus, the radiologist will comment on that, but not uniformly. And obviously, if you see coronary calcium, it's diagnostic of coronary disease. But when these young people, sometimes we have soft lesions that don't have much calcium buildup, and also spontaneous coronary dissection, which occurs more often in young women, you're not going to see any coronary calcium. So it doesn't really rule out the fact that you might have ischemic heart disease.
Yeah, all good comments, Cindy. And I honestly don't recall seeing nor reading anything about calcific deposits in his coronaries during the CT, but it's all good comments.
No, the TIMI flow was 3 no less, right?
No, the TIMI flow was not 3 in his LAD and diagonal branch vessel.
But you did it right. Which one did you intervene upon?
Yeah, there was not really sufficient disease to intervene on the left, Mauricio. So he was treated just medically for that with the usual cocktail of vasodilators and antiplatelet drugs.
Now I'm going to play devil's advocate. What if you didn't do anything? I mean, just because, you know, once the patient is not completely being declared, right?
Yeah.
So you're putting stents there. Now you have to do dual antiplatelet therapy, which does not come without you know, special issues. So you have TIMI3 flow in the right. What if you didn't do anything and just wait a little bit until the patient declares himself, or not, or do it in the second instance?
Yeah, I think that would have been a reasonable alternative, particularly if you use something like Cangrelor, which can give you high intensity antiplatelet therapy for a limited period of time. Had I done that, I probably would have treated him for 36 hours, 48 hours, brought him back to the cath lab to take another look at that right, which was pretty hazy and pretty severely narrowed in some views.
He was not on pressor, so sometimes we see these lesions, which might be due to vasopressors, but in this case, I would suspect it's coronary disease. I guess we should ask the rest of the panel, how would you have managed this coronary anatomy? Anybody want to chime in?
Who haven't we heard from?
Bob, I actually will use this time. I was typing here. I'm very, very sorry, guys, but I had another session that's actually already started at 7:30 p.m. So what I have to say is, I think I'm gonna have to say bye-bye and go to the other session. They keep calling me.
That's fine. We're concluding now. Anyway, thank you so much for your participation.
Okay. Thanks a lot.
Ernesto, did you see those coronary angiograms? How would you manage this case? Maybe he's not hearing.
He may have signed off.
Yeah.
Alfredo, what do you think? Would you intervene?
Alfredo maybe had to sign off also. I think for me personally, I probably would have deferred an intervention because it wasn't clear who was the culprit. I mean, you had slow flow in the LAD and, you know, perhaps a ruptured plaque with some haziness in the right, but not super critical, something that could be stabilized over time, especially without ST elevation. So I probably would have waited. Doing the angiogram, of course, is prudent. Timing-wise, you could debate whether to do it the first day or wait a day or two with stabilization. But it added, I think, very valuable information to know the anatomy, and that helped guide therapy. But I probably would have deferred an intervention seeing these lesions, given the circumstance, till I knew I had a neurologic recovery, because you could stabilize this anatomy medically in the interim and not commit the patient to dual antiplatelet therapy until you knew you had a recovery.
Yeah, good
Cindy,
thinking, Bob. Yeah, very good thinking.
Cindy, I'm here. I come back. I am muted. I fully agree with Bob. I do not interview this guy. I watch and wait.
Yeah.
The lesions in the right looks very bad.
Yeah, it's a diffuse lesion though, so I've always been.
Yeah, it's diffuse, but yeah,
it can wait. It can wait.
Yeah, but when you have long lesions,
watch and wait. Yeah, I agree.
Lesions are often significant. So, you know, Kirk might have been right, but I might have done additional, like, for example, IFR or IVUS just to verify what's going on in that coronary artery.
Really, the lesion don't.
Bob, don't you think it's?
The lesion
I think Cindy.
Yeah.
Yeah. Well, I think you guys are exemplifying the spirit of the Grunzig Society, and that is not providing answers, but providing debate and questions. And so this has been a wonderful session for that.
Yeah, so it's a great case to bring up the discussion. So I think with that, we're closing here on our transmission time. But I really wanted to thank everyone, especially our panelists, and of course, Steve and Cindy for moderating this session, and mostly for Alfredo for inviting us to do this, and for providing valuable input throughout the process of not only the invitation, but also suggested topics, suggested speakers and panelists. Really, it was Alfredo's session. So for that, we'd like to thank you so much.
Bob, Stephen, and Kirk, and Cindy, you deserve that. And Gary is now in Africa. He deserves also. Thank you so much.
You're so welcome, and thank you. With that, we'll say goodbye.
Okay.
Bye-bye.
All right. Good night, everyone.
Bye-bye. Bye-bye,
Bye now.
friends.
Ciao.
Good afternoon, everyone, and welcome to this symposium. With us today, two friends and excellent professionals, Jorge Andrés Chavarria from Costa Rica, San Vicente de Paul Hospital, and also a professor of the University of Costa Rica, and Natalia Pinilla from the McMaster University. And we'll begin with this symposium on algorithms in OCT-guided percutaneous coronary interventions, MLD Max. Before we get started, let me say a few things. Jorge and Natalia we would like, with Carolina Perovicini, to thank all of the doctors and members that have been struggling during this pandemic. A lot of coronary units have been shut down, and now our intensive care units and a lot of our colleagues have become therapists to be able to fight against this terrible pandemics we've had for a year and a half now. Not only medical doctors, paramedics, everybody that is involved in this health sector, from managers to maintenance people that have supported or made so much effort to fight against this pandemic, to help to support the community. So this is in honor of those people and the industry that has enabled us. Even though we don't have person-to-person meetings, we can actually continue with our specialization and continuing medical education. Thank you. Let's begin with the presentation. Jorge, Natalia. Alejandra, thank you very much for such a beautiful introduction during these hard times, and hard times for everyone, professionally speaking, family-wise. We have learned to recognize a lot of values that we did not notice. But for example, these virtual meetings before were not that nice. We didn't want to join, to speak on the phone. And now we have the opportunity to spend some time together and enjoy. So your words have been really kind. Thank you very much for such a warm message. And, we can be here together despite being far away. This virtual, this technology, and of course, thanks to Abbott and SolacI for giving us this forum to discuss image. Jorge and I are really excited because we'll be showing two beautiful cases in the MAD Max context to put together cardiac image and CT images to support complex interventionism. So this is the message we want to convey. The dynamics, I mean, basically we'll discuss the origins of MLD, and then we'll show you the algorithm in two cases so that it's more interactive. Alejandro, if you have any questions or comments, just you can interrupt us at any time. So first, let us share with you the origin of MLD mags, and well, they have the intravascular imaging with the highest resolution of the market. And how can we have doctors use these images? There are many barriers, financial issues, time issues, because some people say that it's very complex, it takes more time, and that there's a lot of information that well, they don't know how to use it, so it makes the procedures more complex. So Abbott decided to come up with an algorithm and put together some guidelines so that interventionists could actually follow them, and whether that could actually help case flow in the cath lab, so that OCT, instead of making the case more complex, would actually facilitate it. So this is, we put this together into an algorithm that basically the different steps in different American centers with over 50 operators that used OCT in interventionism. And so the question was whether Imogen actually changed their workflow. So experts decided on what was the most important thing of this procedure and how imaging could actually help procedure planning. And Alejandro, you may remember at the beginning, imaging was taken at the end of the case when there was a complication or the stent did not look nice. So people used imaging in those circumstances, and this led us to think that imaging is not so important, but we could use it at all times. So many engineers with cardiologists, interventionists, performed an angiography, what stand, what diameter, what size, how you're going to upload it, and whether a balloon is going to be used. And then an OCT was taken, and then back to the interventionist, what kind of stand would be selected, long, short. So they realized after analyzing all of these over 600 cases that interventionists changed their plan in 88% of the cases. So this message, I mean, the people using OCT in interventionism could change their decision in almost 100% of the cases. When they analyze data, they realize why they changed their decisions. And the most important thing was the kind of plaque and the plaque preparation. So when they analyzed these data, they saw that in 51% of the cases, interventionists had to change their decision because they saw calcium in the OCT. They could not see that on the angiography. So they said that calcium actually makes complex interventions. And out of these 51%, half of the cases, they had to use balloons. In a quarter of those cases, scoring balloons, and the rest with other balloons. Another important thing is that I mean, if you do it wrong, you do it wrong because you're placing a small stent. But if you just use angiography, we'll see that the same percentage, I mean, playing a larger stent or a smaller stent, based on what we really need. And after imaging, you can see your job can become so much more accurate. And all of this data actually showed in real life that these things actually take place, that angiography has a lot of limitations. This is an interesting chart or graph that, so when you do OCT before placing the stent and before the procedure preparation, you perform dilation in 85% of the lesions before post-PCI OCT. So the message is that by having an algorithm, interventionists change their decisions because they see things they don't see on the angiography. They can plan procedure and optimize the procedure and decide on the length, the stent size that is required. They do this more in a more optimal way. So this is a workflow that can be used in the cath lab that gives us a sort of a perfect recipe to follow to use an algorithm that helps us in diagnosis and planning of the procedures. And when this was launched into the market, it was just like, having a recipe available, which are the most perfect parts in order to have optimal interventionism. And it is funny because a lot of interventionists think, okay, what are we going to do if we are removing all of the fun of the intervention? We'll not be able to think or discuss. We're all aware of this, that if you have 5 colleagues observing an angiography, the 5 of them will place a stent in a different way, a different size, different length. Some use balloon, others don't. So some do kiss and balloon as others not. So this was just an attempt to sort of standardize these concepts and come up with a perfect recipe for intervention. So MLD Max will be showing in the cases is to basically organize our minds, because when we perform an OCT, there's so much information you can't even put it together in the procedure. So this helps us focus on what really matters, to focus on morphology, which I think is the most important thing, aspect of the algorithm, and then decide on the stand, the size, the length, and decide the optimization that you believe the stent will be need based on the image, and the balloons, the number of stents, whether it's a bifurcation strategy, you can plan it, and your procedure. And in the OCT, that is performed later, is to actually assess that the stent is in the right position and well expanded. So there are slices and very clear algorithms. So what really matters, what the most important thing, since we don't want to speak a lot, I mean, we want to show you the cases. I like to focus on the image preparation, the most important thing, or the plaque preparation. If we have superficial calcium, we don't have much time. I mean, if you use a compliant or non-compliant balloon, you will achieve good expansion. The issue is when you have this calcium on the right that is concentric, very thick. This is where you have to plan your procedure better, because this is the type of calcium that will prevent a perfect expansion. In morphology, the lipid plaque, you can put a stent in the fibrous cap. You need to make some modifications with a compliant or non-compliant balloon, but the thick calcium and superficial calcium, this is the worst calcium we need to focus on. And in both cases, we'll show today, there's calcium to be able to enjoy those images. This is just a quick overview on the algorithm and how we're going to use it. In the case you define the length, you're sure that you're not putting the stent in the iliac. You pick the diameter based on the external measurements, and if you don't find the external elastic layers, you can use a size on the lumen. We're going to over the lumen because this is not real life. You will not see 360 degrees of the layer. And regarding the optimization, there are very clear tools in OCT to define and focus on the fact of not having a distal dissection that is deep. And then there are some other very nice tools in the OCT console to show the apposition. There's an apposition bar and other percentages that are automatically analyzed. They show that, how well expanded is the stand distally and proximally. So in the cases we will have a look at these algorithms in a you see how a procedure that was thought to be more complicated, then it becomes simple. Now, Jorge, I would like you to show you the first case, which is our favorite, because it is actually having all of the images together that help us simplify this case.
Can you hear me? Yes, we can hear you fine. Alejandro, thank you very much. I echo Natalia's words for that introduction, and definitely I'd like to thank you for the opportunity to share with you during the SOLACI Symposium. Thanks, Abbott, also for allowing us to still enjoy this passion of sharing images and procedures supported by intravascular imaging. As Natalia said, this is one of our favorite cases, especially because we are involving more and more the analysis of different images and the correlation of these approaches to make the best decision with our patients in complex osteal LAD PCI. Especially I think about the younger interventionists, because we don't have as much experience as our professors, and these approaches that are systematic allow us to offer the patient a procedure that is safer and, most of all, to give better outcomes in the long term. This is a real life case. It's very controversial, as Natalia said. More often than not, we have to adapt the algorithm to make the best decision in order to prevent any complication for the patient. But we also see the manipulation of the different images for these processes can help us make a decision within the discussion of the heart teams. So this is a male, 77 years old, hypertension, dyslipidemia, and peripheral artery disease. He was referred by his clinic, his family doctor, and we met him in the settings of CCS class 2-3 angina. And when we saw the historical information of his angina, we were able to see that he had a severe osteal LAD disease, and with high AGS calcium score in all the coronary arch. After we diagnosed him with this angiography, his main physician referred him to us, and that confirmed the angiography showed and confirmed what we saw. In this image, with an angiography image without contrast, we see that it's a highly calcified vessel. We see calcium on both walls of the artery. And in this image of the head, we see that the LAD in its mid-third, maybe it's not very clear in your screens, but there is a myocardiac bridge that was confirmed by the CT scan, by the coronary angiotac. Taking into account this, the ostium in LAD, and that it was not been a candidate for, we're gonna have to work on the main. The patient was evaluated in our team, among the people in our team, and we said, okay, do we call a surgeon for MICS, CABG, or CABG, or do we proceed with PCI? considering that we're going to deal with a severe calcified morphology, and we were going to have to go into the main with different strategies to change that plaque. If we analyze the tomography in detail, we see that, yes, we have the proximal calcification in the LAD, but the lesion that we had in this case, it had certain characteristics in the CT scan with a low attenuation, not calcified in the site of biggest stenosis, which is at ostium level. There is another detail. We're going to see how this new approach allows us to plan a better strategy. For instance, in this case, even to save radiation or contrast, because these virtual 3D models allow us to even analyze the best projections so that when we are inside the CAT lab, we can go directly and guide ourselves to do less projections and less use of contrast. So here you can see pretty well how this proximal stenosis is not highly calcified, and we can see also the segments that are intramyocardiac. So this intramyocardial course, we were thinking, okay, is a bypass the solution? Is it going to be very complex to perform? Well, we decided that the strategy with CTA and OCT, focusing on the main and through an analysis of these calcified lesions, whether we had to change this plaque. So the comparison between CT scan and OCT, this eccentric lesion with an excellent correlation with the CT scan image. We see an absence of calcium or a calcium plaque. Here we have an image that has high density of the signal in the most superficial areas closer to the lumen, and how there is an attenuation in the farther parts of from the lumen. And considering this analysis, both imaging strategies, we decided to do the strategy by intracoronary artery strategy that we're going to show you now directly from the console. The great thing about that case, at the beginning it looked like a very complex lesion with a calcium score above 2000, which is a nightmare for us in the CAT lab. And as you showed, in the ostium of the LAD, there was more than 40. So when we think about interventionalists, we thought about ablation and that it was going to be a complex procedure until we went back to the CT scan. It was not that severe, and it was not the most calcified as what you're showing here. But that lesion had pretty much distal calcium, but the lesion was eccentric, and the calcium was not giving us luminal extension. Right. And we want to show that when we are planning an approach for a bifurcation in the main, it's important to do the baseline pullbacks for the arteries. This is in the LAD. There is a correlation, very nice correlation with the images that we saw in the CT scan. The longitudinal plane of these calcified plaques, 160 degrees without an important stenosis. But when we go towards the area that is of our interest, we can show this plaque. I don't know, Natalia, if you want to describe what you see. Yes. What we see in the CT scan is that calcium nodule that is protruding and that is smaller than a quadrant, and the other segments that are at 35, it's mostly a soft plaque, mostly liquid and fibrous plaque, which is not calcium, very complex calcium to modify through an intervention. That's what we thought before we have this image. So what the algorithm does in the LAD, the morphology of this plaque, help us make this decision. We don't need to modify or to use a rotablator or any excessive dilation. In terms of the length, we decided to cover the main with the goal of making sure that we're going to cover the plaque completely. And at distal level, one of the main messages to take home, we want to show you how, when we're dealing with this type of calcium plaques, we can also make a decision about our distal landing in a safe way. So here, I'm going to zoom in and I'm going to activate the light surrounding. So what would be your decision in terms of the sizing of your stent in your case? Well, the size, we cannot see the external elastic sheath as in real life we cannot see, but if the person is living with this, we use the lumen and you go to the next one above. One more. So the mid diameter is 3.82. So the recommendation is that if you use the lumen of the stent, one stent higher than that, and if you use the external elastic sheath, then it's three smaller. So maybe a stent of 4 is appropriate. So remember that we have this application within the software where we can activate this profile, this lumen profile, that allows us to find our proximal and distal landing, and it gives us the length of the stent we're going to use. So a diameter of 4 millimeters in a stent with a length of 20 millimeters is a very good option. Jorge, can you show the proximal optimization for the length? Because that's why we decided to cover the main, in order to have a sure main, a sure length. So that's another important detail. We also have the tool here to measure the length, and we need to take into account all the tools that we have in our lab. For instance, if the shortest balloon is 8, we need at least to have proximal coverage where we're going to do the pod of 8 millimeters. So here, the main length is 5.7 millimeters. So these 2 millimeters can be outside when we have post-dilation. Any other comment, Natalia, that you'd like to make? No. I think you have to show something important. When you are going to do intervene in a bifurcation to see the lateral branch, which is the circumflex, which was a huge branch, a very important vessel, and what happens in the ostium, and to predict if you think that CTA ostium is going to be affected. And in this case, the ostium, the area of the ostium, was pretty well preserved. The area was above 6, if I remember correctly. There was calcium, and the truth is, at the end of the day, calcium protects to prevent the misplacement. As you can see, the morphology 7 and 8, you see that there is a calcified nodule that is going into the lumen, and then at 9 o'clock you see the LAD. So with this calcium that is there, it's going to kind of protect when you place a stent. So with that image, you rest assured that the ostium of the circumflex is not going to be modified. If you have the area there, what is it? In this case, we have an area of 7.24, which is completely perfect, and that's important before we plan the procedure. Correct. And remember, you can use the cross-sectional view and to turn it around, and at the same time to analyze the longitudinal model to define the area of interest that you want to analyze. In this case, if you don't know whether this is LAD, you can go frame by frame so that you have that information very clearly.
Now we'll show you what we decided to do. The lesion to be treated is the LID proximally, and the provisional strategy was selected based on our basal image analysis. The summary of the procedure: you can see we implanted a DES 4/24 in the LID towards the left main with poured a POT of 5/8, I'm sorry, and this is also based on the algorithm. We performed a kissing balloon 2.5 to the circumflex and 4.8 in the LAD, also based on the sizing, the initial sizing. And since we were dealing with a calcium nodule, we decided to perform another OCT in order to define whether we had obtained a good expansion or not. In this case, we saw that the expansion was not acceptable, so we continue with a more aggressive post-dilation with a double layer balloon and a second kissing balloon with a non-compliance balloon 2.5, and the repot again 5.0, and finally the OCT approach, which we'll show you now. I believe you should show the image, because if he decided to perform a very aggressive post-dilation with a double layer balloon, what you saw it in the LAD, the Austral LAD, I believe that in the fourth, you see the under expansion. So when we are approaching the result of the intervention, we have the max algorithm, as Natalia explained. M is searching for dissection at the edge level, and dissections that could lead to a faster scarring procedure or an early artery occlusion. And A is about position, and X is expansion. So the software allows us to, as you can see here, if we activate the light profile, we can select the stent edge, the proximal edge, and to visualize this position indicator that very quickly can tell us about the elements we could have in terms of a non-acceptable position. When we're dealing with calcium, we could have certain segments that are not well positioned, but if the condition is appropriate, then it can be left as an adequate result. So that distally, there's no dissection. So the 4.0 sizing on this calcified plaque was appropriate. However, when we look at expansion, we see we have 59% of expansion following the taper algorithm in order to approach the expansion of the stent. It is exactly in the segment we had identified, a calcified nodule. And thanks to this image, we decided for a more aggressive post-dilation with a double layer balloon. How did you come up with the decision of 4.0 with a double layer balloon up to 40 atmospheres, 36 atmospheres? Well, the taper mode, that ostium of the LAD, the lumen was almost 4.5. So when we use a double layer balloon, we want to use a value that is below the lumen of the vessel, because those they are quite aggressive, 40 in terms of dilation. This is this is for the insufflation, that it would be 40 atmospheres, 40. As Jorge is showing, the measurement is 4.35, 4.49. So 4 at high pressure, we thought it would be enough for post-dilation in this segment. And then, based on the fact, based on kissing, otherwise there would be a lot of expansion, and we didn't want the ostium, the circumflex, to be affected. And the luminal area measurement, we want to increase 0.25. We want to use this luminal measurements. We don't have a clear evidence on where the external membrane is. And after this, we performed a new final assessment in order to follow the algorithm, and this is what we were going to see here. So the first part of the acronym is searching for distal dissections, and as we can see over here, there is no dissection. We're close to diagonal bifurcation, and we're dealing with a very short segment of non-apposition, but it is good. I mean, the stent is properly expanded. So from 59% expansion, we moved to 82% expansion, and the minimal luminal area is no longer located in the LAD, but it's distally on the calcified plaque, and we don't want to actually fracture it. The short axis image, once we rotate it, we see the software allows us to perform another assessment. How open is the strut after the kissing? And we can see that this can be manipulated in different ways in order to define the location of the guide wire, and whether, I mean, if there's a lot of protruding material at the bifurcation level, you can rotate the short axis. You can see we can get these kinds of images. You can zoom in and zoom them out to assess, I mean, to come up with a very good result after kissing and at the end of the procedure. In this particular case, the two main objectives of the algorithms are met. The most important thing is expansion. Expansion leads to better outcomes, long-term outcomes, and this expansion, this non-apposition in the distal segment in heavily calcified plaque for us is acceptable. Natalia? Alejandro, did you like the case? I loved it. I loved it.
It is so great. Such a complex case at the beginning. The OCT, to what we thought it was going to be complicated, it simplified it, and you can rest assured that you had a main approach that is perfect, and you cannot worry. I love that image, Jorge, when we get used to the angiography and we see that ostium and the circumflex that way. Wow, we found the ostium of the circumflex, and we can see the OCT of the circumflex, and the area of the ostium of the circumflex was not affected, and we didn't need to do an interventionism. So this gives you just a 2D image, and you can exaggerate or underestimate the findings because the image is very poor. So in this procedure, something important about the efficiency using OCT is that a procedure like this, after 6 hours of interventionism, people say, okay, OCT is very costly, the catheter is very expensive, and our managers say it's not justifiable. But at the end of the day, if you can send a patient that has a main intervention who goes home after 6 hours without the need of hospitalization, I think that justifies the value of the catheter, the cost of the catheter. And something else, when the nurses start coming, the patients feels a chest pain, and we call the main physician the next day, and you say, I don't care. That is expanded, no dissections. I don't repeat angiography. The chest pain is not important. And that confidence that you have in the procedure with the transvascular image is not given by anything else. Well, Natalia and Jorge, to use the algorithm of MLD Max, how do you select the patients? Without a doubt, in Latin America, it is complex because of what you said, Nati, using images in all the patients. How do you select the patients to use the algorithm? And what patients, apart from these, you discriminate against in order to do a CT scan? That is a very good question, Alejandro, because in Canada, the health system is a public system, like in many Latin American countries. Here, we don't use OCT. Yesterday, in Greg Stone's, Gary Means talk, it's not like in New York and Manhattan, they use imaging in 100% of the cases. In Canada, that's not the reality. We use images in the cases that require so and that are most benefited. So, for instance, in a stent failure, we always, whether it's at 3, 4 o'clock in the morning, in a busy day, that case has OCT, and that simplifies it quite a lot. Yesterday, I was on call, and nurses love that they do an OCT, and because there is a vulnerable plaque, this is atherosclerosis inside the stent, 324. The efficiency of ending the case and to plan your procedure, optimal procedure, it gets clear. In those cases, there is not a doubt. The other cases that we do are these bifurcations where there is complex interventions, calcified plaques. Those cases are done with OCT. And another important case are the acute coronary syndromes where the culprit lesion is not done. Young people, for instance, who have coronary lesions that do not look like a dissection, but you need to be sure that that has arteriosclerosis, that has an LAD lesion, whether it's a Takotsubo or it's a vulnerable plaque. In those cases, when the injury or the lesion is ambiguous, we do it. You would not believe the number of eroded plaques that appear as a blurry image on the angiography, but that there is something important. Those are the cases that I would say that are always done. And what we're trying to do, if we have to do ablation, retrotrachea, to do these with this technology, because the risk of those technologies is that they are too powerful. You have a 40 atmosphere OP of the balloons. You have to say that you have to make sure that the balloon size is correct and that you're not going to have complications when using those devices. The other important point is that this technology is evolving very, very fast, and the data shows that we do safer procedures with better prognosis in the long term for patients. One thing that we see now all the time is that in patients with some level of kidney insufficiency, these procedures we're using less contrast, and at the same time we are protecting the staff more because we're using less angiographic projections, and to define ambiguous lesions, instead of doing 3 or 5 projections and using different types of injections with only 2 projections, octagonal with a registry, we have all the information, and for instance, we can plan all the procedure. If we apply, for instance, MLD Max, we are sure that the balloon we're using is going to have a deep dissection. We don't have to do continuous tests to see if the artery has been perforated or if at distal level it was dissected. And at the 4 different points with the angiography, we do 2 final injections and then shots, and then I think this is going to evolve a lot more with the low contrast, and also with iBoost, that we should use contrast, but also with OCT, where we need to plan initially with the contrast. Alejandro, let me tell you a story. I'm so fast using OCT that one day I was on call at 2 o'clock and I had 3 patients on the hall. So how am I going to do these 3 procedures? And I said, okay, take the OCT catheters, in, out, stent, done. And I was the most efficient one doing those cardiac arrests. And they said, wow, you were much faster using OCT. So I think it's important to become familiar with the measures. If you do it and you don't know where they are, it's complicated. And that's a very important role to promote education and to explain how to do it easier. Then it's all simplified. I wanted to show you this other case. This is a 74-year-old man with all the risk factors, and he had a complete heart block with a permanent pacemaker, and the patient had a class 3 angina, progressive. They did an MPI that showed that he had LV dilation post-stress. Something important about this person, he said that he had a 25-year-old girlfriend, and he said, my girlfriend is 25, so doctor, if you find something, try to fix it, because he wanted to be good healthy. He is a patient that I really appreciate a lot. I love him and laugh a lot with him. When we do the angiography, there is something important about this right main, because I couldn't inject contrast. There was no way to hook the right ostium, even though I tried with an L. I couldn't enter the contrast, and it's like a blurry image in the ostium, but I couldn't understand why. And now in the image I will show you why. This lesion that is kind of blurry, every time I see a blurry lesion in the right main, I say it's calcium until otherwise proven, and he has a diffuse disease in the midsection of the artery. The left system had a main that was distal main disease, and this circumflex was pretty ill in 3 different segments, and the LAD, of course, was not less. It had, in the video we cannot see it very well, but it had we had a lot of lesions in the ostial and medium sections. So here, this is the guy, my patient. All of those attending this webinar, this guy is 74 with a nuclear test of high risk. He has a 3-vessel disease, is diabetic. So heart team round quickly says, okay, you have to debate it at least in the heart team round. And diabetes was another important factor. When we did a heart team round, we had to use CABG, and he said, I'm not going to do it. How long will I take to recover? I go to the Caribbean with my girlfriend. I don't want to go with that scar. I heard that Dr. Pinisha has some stents with an imaging technique. The patients know everything. So I want Dr. Pinisha to fix me. So that's the story of my patient. And from that procedure, he became my patient forever. So I still hear his stories about him and the girlfriend. The intervention on the right that I wanted to show you is pretty nice because I realized that I couldn't inject the contrast in the same way with the catheter that I placed. And when I did the one on the right, I realized that what there was right in the right ostium, as I said, every time there is an image that is blurry in the right coronary artery, it's always calcium. It's not a thrombosis, it's just calcium. So for sure, I was trying to put the diagnostic catheter. It hooked here in this calcium thrombosis, and the great thing about the angiography is that this is the problem with these patients with multivessel disease. If you're going to compete with surgery, it has to be within a perfect intervention. Otherwise, the surgeons will make fun of you because they will say, okay, your stents didn't work, you didn't do a good job. like in the bypass surgery. This was a quite diffuse disease. I want to show an error that they make, all of them who make OCT. They're in the catheter, in the cath lab, they look at the screen, they display. This is the most boring thing that you can do with OCT, seeing these images run at this speed. In this sense, you lose time, you play the play button, we never use it. Another important thing is that this image, length image, we never use it. All the procedures are based on this upper, the lumen profile area. And another important thing is for interventions, it's really helpful after you choose a distal area where you are going to place your stent, you can use the length, this length tool to decide the stent. In this case, we had to place 2 stents because of this diffuse disease and quickly analyze the type of plaque in this patient. Most of the distal plaque was lipidic. It had microvessels. It had calcium that was mostly in the proximal side, but as you see here, this is a plaque that is completely lipidic at 360 degrees. As you can see, some macrophages. It was fibrous, and in the proximal segment we see calcium, but calcium was not as complex, and the truth is that the most complex plaque was the ostium plaque with that calcified nodule. So at this point we decided to do predilation with a non-compliant balloon at the proximal level, and we had to put both stents pretty far apart. But then in the results, when we see this artery, the before and after, and once again you remember that you used an algorithm to place the stent in a perfect position in this right coronary artery, then you rest assured that your intervention was successful. Something important to say, and this is a tip: when you put 2 stents of different calibers, the tools are not perfectly designed for these long stents. So when you place 2 stents, try to analyze each segment separately, because when you take everything to the very beginning, the software will not put everything in perspective, and at the end of the day it's going to dissect in severe infra expansions, which is not the case. So in this image, it's important because of the tools of the OCT that the stent is in apposition. This is the apposition bar. And then as operators, we need to learn to trust in these tools with eyes closed. We blindly trust them because if you have a pulp that is pretty clear, the tools can be used with high trust. They are telling you exactly what it is.
And here in the expansion, these are the distal segments first and then the proximal segment, because the software mixes it up when it's too long. And you can also use this other tool, stent expansion tool, that divides the stent into 2 segments, and then you can move this around in any direction, but this tool will always split the stent into 2, and if you're not happy with the segment, you can move it upwards or downwards, whatever direction you want. I will just not spend any more time on the left because I'm more interested in the main left and the LDA. This was carried out, performed in 2 times because the patient had kidney failure. So there were 2 procedures, and the OCT tools in the lumen profile, you have these pink dots, which are the bifurcations. And as you know, this angiography, you know exactly the branches that you're interested in, which are these 2 diagonal branches. You can also see them on the image, longitudinal image The most important diagonals are these two, which are over here with these yellow dots, and this helps you. And as I knew that this diagonal was too large, the first stand I wanted to place it after the diagonal so that stands are not overlap right at the bifurcation, and then we decided the stand of the LAD. To decide on the segment, the stand that I wanted to show you this plaque, and the majority of the in the MD Max is you can see the ostium in the ALD. This is a plaque which was so vulnerable. They had eroded or ruptured in the past, and that I mean, they had a scar tissue, and this is the and over here this is the scarring, and it probably was a thrombosis that, and all of this was the plaque that is in the LAD ostially, and this is the plaque that extended to the left main, and over here you can see the left main. This is the transition from the circumflex. You can see how this plaque, and in the left main you can see that it is below 6. So after this imaging, I knew that the stand I wanted to place would be the LAD. I mean, it had to be the LAD due to this, this plaque. Let me show you the circumflex that had plaque, but it was not as severe. So with this, I decided that the circumflex ostium was not bad enough in order to cover it with a stent. And let me show you here in the transition, the left main. This is the transition in the ostium of the circumflex, and it was much nicer than the LAD ostium with a lot of differences. To simplify the procedure, this ostium, this circumflex ostium, the area was above 6. I decided to place a stand from here to the proximal segment. As you can see on the angiography, the circumflex was quite diseased, and after placing two overlap stents, and this is the result, the ostium was not covered because the area was above 6. And this is, you can see in the record, the result. But the Max algorithm showed us the stent was perfectly placed. This is the apposition tool. The stent is white, completely white, but when we shifted, when we shifted to expansion, this stent is not perfectly expanded, and we had to optimize it. Here you can see how the software tells us exactly which segment it is. Here we are looking at the expansion and indicating that this distal segment is yellow red, which means that it's below 80%, and if you want to optimize it, it is exactly in that segment and no other segment. So this is the way how the software simplifies these procedures in this patient. Optimization was performed exactly in this segment. The rest of the segment was very well positioned and expanded. In the post-PCI of the LAD, let me show you, the disease was quite diffuse. This is how we simplify the procedure, which was quite complex, but we were able, the main three vessels were left open, and you can see here how in the distal segment there's no dissection, and the stent is well positioned. There are some red segments, and I will just click on the red segment, and I am sure, for example, this is a pollution, this is blood contamination, and there's another red point over here. This is also contaminated blood, so this stent is perfectly it's a perfect deposition. With long stents, you should move on. You should look at segments separately. So here the stand and the expansion is above 80%, so the result is quite good. So this is the way, basically, Alejandro. So if you use these tools, then procedures become more simple compared with, I'm sorry about, I'm really excited about this. So very beautiful demonstration, but we are out of time. And I would like just to make a few comments. First, your 74-year patient with this coronary disease and this bi-chamber pacemaker, I would recommend to spend more time with a girlfriend. This will decrease the incidence of sudden death for sure. One question just to wrap up, and you talked about the algorithm to discharge patients, early discharge. Just a few seconds, if you could tell us about the percentage of early and late. I mean, how does the algorithm benefit? 100%. Everybody goes home. Nobody stays in the hospital. Patients coming from their homes. These complex interventions, we use rotablation, CTOs, bifurcations. Everybody goes home that very same day. After 6-8 hours, 100% goes home. Patients using algorithms that are admitted due to acute coronary syndrome, because they stay, but interventionists go home 100% in these patients, these complex cases. So we have to end the symposium. Thank you to Abbott for the organization, Jorge, Natalia, Jorge Chavarria, Natalia Pinilla. Thank you very much from Max Baxter University in Ontario. Thank you very much. We'll see you soon. Thank you.